on the dais. We are going to start the first session.
Good morning, everybody. Now we are going to start our academic sessions. I welcome you all to this STM. We yearly conduct this conference and we select one topic and we just churn that topic for almost 2-3 days so that we should get all the intricacies and inside and out of these injuries. This time we have taken a foot and ankle, and Dr. Gurunath Vache and Dr. Sunil Hanran has taken a lot of efforts to call many faculties across the India involving so many people. So I welcome you all, and now I request our moderators to take over this and start the ball rolling.
Yeah, good morning. Now we'll start with Liz Frank, and may I invite Dr. Drumin to talk on approach and fixation of Liz Frank.
So, pathoanatomy and radiology.
Sorry? Yeah, that's fine. The pathoanatomy and radiology.
So, good morning, everyone. Thank you, Solapur Orthopedic Society. Thanks, Dr. Gurunath Vache, for inviting me here for giving this talk. So, to begin with the Liz Frank session, we should understand a little bit about the anatomy and the radiology. Now, all of you are quite senior orthopedic, established foot and ankle surgeons and orthopedic surgeons, but still I'll go through it quickly. So, if you see the Liz Frank joint, it consists of 3 articulation. It's just not the TMT, it's just not tarsometatarsal. You also have to consider intertarsal and intermetatarsal, because even that causes instability, and it is important to address that while we fix it. So the bony architecture, as we know, is composed of 5 metatarsals, and they articulate with the cuneiforms proximally, which is medial side, and on the laterally there is the cuboid bone. And the TMT joint complex represents the dividing line between the midfoot and the forefoot. So what exactly is the Liz Frank ligament? It is a ligament which attaches the base of the second metatarsal to the medial cuneiform, and it is on the plantar aspect. As we see our patients, they come with plantar bruising. So the majority of the injury and the brunt, which is bone when the foot is actually loaded, is on the plantar aspect where the ligament ruptures and subsequent injury occurs. So if you see this diagram, this is like a keystone. So it's like a jigsaw puzzle where the second metatarsal fits in the intermediate or the middle cuneiform. So the height of the middle cuneiform is slightly lower, smaller than the medial and the lateral cuneiform, and the second metatarsal length is longer. So that fits in the like a keystone, and this is important to recreate when we are fixing our fractures. So this is a nice slide which I came across. Many orthopedic surgeons say, "Thoda sa displacement hai, why do you want to fix it?" But if you see this slide and the amount of movement and the shift happening at the midfoot and the forefoot when we walk, so during the gait cycle, as soon as we are in the swing phase, our foot is in supination. Okay, and that's on the right side picture where you see the first, second, third metatarsals go medially, and you can see the talar and calcaneal inclination as well. And as we land our foot on the floor, our foot goes into pronation, which is the picture on the left, and you see the center of gravity line shifting across medially and the second and third metatarsals going laterally. So during each movement, during each step, our Liz Frank joint is coming into play. And that's important to make our physios, make our colleagues and other orthopedic surgeons understand that Liz Frank joint shouldn't be taken for granted, and there is a lot of movement happening which hampers the quality of life of people. So who was Liz Frank? He was a French surgeon. He essentially described an amputation during the World War when a soldier came with a severe gangrene when he fell off a horse and the foot was caught in a stirrup. So that is the mechanism of Liz Frank injury. Although this doesn't cause gangrene, he might be having some coexisting problems that caused gangrene and eventually ended up in amputation. And that's how his name came into this injury. So this is the mechanism of injury. It is an axially loaded and a plantar flexed foot, and your whole body weight goes across that. So the tarsometatarsal joint, particularly the second one, takes the most brunt of it, and it dorsally dislocates, and your plantar ligament ruptures, and that's why you get a gap between the first and second metatarsal base. So this happens in footballers more commonly, but many a time we see patients who are middle-aged females walking on a footpath and suddenly twisting their leg, or a motorbike hitting them and they twist their legs. So similar kind of injury occurs in them, and that's how they get the subtle Lisfranc injuries. So patient comes with this picture, midfoot pain with difficulty in weight bearing. Some people with subtle injuries are able to walk, but they have an antalgic gait. There will be swelling, there is deformity which might not be very apparent because of the swelling, and plantar ecchymosis, which is pathognomonic for a Lisfranc injury. So after we diagnose the injury and see the patient, next comes the radiology. So these are the normal radiographs. What lines do you need to take care of? So on the left picture, the blue arrows, the medial border of the lateral border of the first metatarsal should align with the lateral border of the medial cuneiform. On the right bottom picture, the medial border of second metatarsal should be in line with the intermediate cuneiform medial border. This is the most important line which you should take care and see the right bottom picture. We take oblique x-rays, and in that you need to see the third, fourth and fifth. So the third metatarsal should align with the lateral cuneiform as seen with the blue arrows and the red arrows on the left, and the fourth metatarsal with the medial border of the cuboid. So this is the Lisfranc injury. As I said, the medial border of second metatarsal not aligning with medial cuneiform, very apparent space there. This needs stabilization. On the lateral x-ray, what you need to see, the dorsal surface. This is important, which many people miss and should be seen very carefully. So the first and second metatarsals, if you see, should level up with the cuneiform on the lateral x-ray. And if you see a step, that is a Lisfranc injury. So in subtle Lisfrancs, people will not often see like a left picture, which is non-weight bearing, not very apparent, the injury. So you should take full weight bearing x-rays. Any injury in which a patient is able to stand in foot and ankle should have weight bearing x-rays. And a flex sign, which is characteristically described by Meyerson in 1986. It should be sought in the medial cuneiform second metatarsal space. So next comes, after x-rays, what do? We need to plan whether we need to fix this or not. So CT and MRI, when to do CT, when to do MRI. Sometimes patient comes with both CT, MRI, sometimes orthopedic surgeons asks us which one to do, they don't know. So CT is basically when you have diagnosed already on the x-ray, when you know that it is Lisfranc and you have to plan the surgery, then you should do CT to see where is the piece, which metatarsal are dorsally subluxed, which are not. And it helps to formulate the surgical plan. Whereas MRI is when you are confused. You don't know whether it is a Lisfranc injury or not, when it is a very subtle injury. So that will show the edema in the Lisfranc ligament, it will show the edema in the bones, and again it will show a little bit of bony anatomy. So that's again a picture of Lisfranc showing the edema in the second, third and the cuneiform bones, and a fleck of bone as well. So in short, my job was just to describe this, and we have our other speakers who will describe further about approach and fixation and some cases to follow. And to conclude, so high suspicion of Lisfranc with axial loading injury and midfoot pain, always get weight-bearing x-rays, especially in subtle Lisfranc injuries. And MRI and CT have their own specific roles. You need to know which one you are doing and for what reason you are doing. Thank you.
Yeah, good morning, everyone. Thanks to Gurunath sir for organizing such a great meet. Thank you, Solapur Orthopedic Association, our president sir. And my job in next 7 minutes is to talk more about the Lisfranc, like how to do more clinical work and how to approach this injury and how not to miss and how to fix it. So just we have to run a continuation of my colleague Dr. Dhrumin. This is basically a beautifully talked by Dr. Dhrumil that the second metatarsal base is a recessed and it is a most stable structure between the cuneiform, And the anatomy of the midfoot is like, it's like a keystone which gives the maximum stability to the transverse arch. It's like a Roman arch. And this ligament is beautifully again explained by Dr. Drumin that it is the most stabilizing structure between the base of first and the second metatarsal. So it is on the plantar side. The Lisfranc is on the plantar side. So once it is disrupted, it leads to the dorsal subluxation of the second metatarsal. The same injury and the sports plantar flexion and the twisting injury, which creates a widening of the gap between the base of the second metatarsal and the medial cuneiform, which is usually evident. But the problem is 1 out of 5 injuries missed. There is some people, they diagnose it, they may conserve it, that is different, but 20% of the injuries they are completely missed. And this is the data from the big journal. Almost 50% of the injuries, they develop the post-traumatic arthritis and they develop a painful chronic midfoot pain. So just have a look what has been done to this guy. He is a 30-year-old guy, twisting injury. He came to some other physician. He got done some X-ray. There was no injury. He said there is only the mild sprain in the midfoot, and the crepe bandage was given. 15 days down the line, when the pain was not not reducing, the full weight-bearing X-ray was advised. The pain and the swelling were persistent, and then it was found that there is something going wrong at the base of the second metatarsal. But the patient is not willing because there is no any obvious indication of doing more workup in this situation. And it is our lookout on this injury. What you explain on the, if you explain that is a minor injury, they'll take it minor. Same patient, 40 days down the line, full weight bearing X-ray, which is showing that now the disruption is quite significant. And it is not the disruption at the base of second only. Look at the first TMT joint disruption. It's completely disrupted. Look at the other part. The foot is hyper abducted. Now you can understand the mechanism of the injury. The cuboid is also broken. The same guy, first metatarsal, second metatarsal, cuboid. So you can understand that how much hyper abducted injury it is, and it created an injury on the lateral column as well. So in short, all the midfoot injuries, he was not willing, and now you can see that there is a bad midfoot instability. Another patient, he is also the young patient. The injury was neglected for 8 months. Nothing happened, but look at the posture of the foot. He has developed a significant flat foot deformity. What is this flat foot? This is midfoot injury-induced flat foot, which is even more challenging to treat the flat foot in general. So if the Lisfranc injury is missed, is not just the midfoot instability, it may give you the flat foot, it may give you the 50% post-traumatic arthritis and a source of chronic pain. These are always a frustrating patients if it is missed. So some injuries are very easy to diagnose, like this lateral subluxation, but there are some subtle injuries where our work should be more, and we should be able to diagnose this injury, and how not to miss this injury should be our point. So there is something which is called 7 points for the Lisfranc, to how not to miss this Lisfranc, and this I understood over my practice, that if I remember the 7 points, I may not be able to miss any Lisfranc injury on presentation. So it may not be Modi ki guarantee, but it is quite significant guarantee ki you may not be able to miss it. So no political commitments. Tip number first, always don't underestimate the unexplained swelling. If the patient is coming to you after the midfoot sprain, if he is coming with some sort of visible deformity, make a high suspicion. If the pain is not, the swelling is not going in 15 days, always have a high suspicion. Tip number 2, always look at the plantar aspect. In the busy OPD, we don't see the foot on the plantar side, but always see, because it's a bleeding which is coming from the midfoot settling on the plantar aspect, which give us the idea of plantar ecchymosis, and this very significant sign of all midfoot injuries. Tip number 3, always palpate the TMT, because this is the only area which is, what we do, yahan dukta hai, yahan dukta hai, yahan dukta hai, ATFL dukta hai, no, it's, if you are suspecting the Lisfranc, your pain will be located at the TMT joint only. Tip number 4, always get done the weight bearing X-ray. Look at here, nothing was visible on the non-weight bearing X-ray, but on the weight bearing X-ray, you can see that there's something going wrong at the base of the second metatarsal. But and also look at the another form of the diastasis which Dhrumil is also explained. Always look at the lateral view of the X-ray. If you are suspecting Lisfranc, your oblique view may not be helpful, may not be, but your lateral view is more helpful because the dorsal subluxation is visible only on the lateral view. Flex sign, which is a base of the first metatarsal, base of the second metatarsal fracture, it's like a ACL avulsion fracture. When we see the tibial spine avulsion injury, and you find that some loose body inside the second TMT joint. If you are still in doubt, tip number 5, compare with the opposite side. See, your patient may have some laxity between the base of first and second metatarsal, but always compare with the opposite side. So, distance between the first and the second metatarsal as compared to the normal, if it is more than 1.3 mm, keep a high suspicion. If your patient is presenting little late, 7 days, 10 days, if he is not in that much pain, you are suspecting Lisfranc. Tip number 6 is always get done the provocative stress X-ray. You have to stabilize the hind foot. You have to give a hyperabduction force on the forefoot. What it creates? It creates a sort of instability which was subtle, which was not visible on any X-ray, any clinical examination. Always get done this stress X-ray if you are in doubt. And tip number 7, if you are still not sure that your patient is having a Lisfranc, then you get done the CT or the MRI. Also, to know the other injuries which are associated with the Lisfranc, this may be the investigation of choice. But this is not an investigation on day 1. That Lisfranc directly sent to MRI. It's not like that. MRI is only helpful when you are suspecting some subtle injury, not visible, not those that much unstable. But yes, so these are all the 7 points. Hierarchy wise, if you remember these 7 points, you may not be able to miss it. The Lisfranc injury. Management, we know that earlier there were a lot of people you are using the K-wire, but we came to know that this is not a treatment. So K-wire, no. For many years we have treated the Lisfranc with the open reduction internal fixation using the screw only, and now we have shifted to the extra-articular plating, and now there is always a confusion between arthrodesis versus ORIF. That is a matter of long debate. But the treatment depends whether the injury is subtle or the injury is high energy. So ORIF, which was doing through the screw only, that additionally created 6% of the damage to the cartilage, is already the cartilage injury. You are giving 6% of additional injury. So that created a concept of bridge plating. And now a lot of Indian companies, they came with the bridge plate. But again, you have to use it very, very cautiously. It's not a plate for all Lisfranc. Look at a case here. This was treated by the general orthopedic surgeon. He tried his best. There was a lot of dislocation. So maybe because of some soft tissue problem or what, I don't know. But patient presenting to me in this with this X-ray, surgeon has accepted this injury with the K-wires only, but look at here, look at the rotation at the first TMT joint and the diastasis of the second TMT. It is not acceptable. It is as good as untreated Lisfranc injury. So we have removed the K-wire, CT scan we are done, and the CT was showing, the instability. Look at the dorsal subluxation of almost all TMT joints. And this patient, when he was kept under the anesthesia and was dorsal incision was made. Earlier I used to use this dorsal incision, but now I have made some little changes in the approach, but that is older, fine, no problem. We are putting the video only to know the instability between the cuneiform and TMT joints. So this is how the fixation was done. It has the low profile plate, completely flushed, intercuneiform stability with the screw, and this is how the wound was healed. 6 weeks, 6 months, patient is doing good, no flat foot, no risk of arthritis, the very less risk of arthritis. So points to remember is this is an injury which may be missed. It may be missed by you on your routine practice. So don't miss this injury. They may have an extension up to the navicular. You may have an intercuneiform instability, and avoid the arthritis and the chronic foot pain by not missing it. Thank you so much.
Thank you, Girish. Now I invite Dr. Sampath Patil for the next talk.
Good morning. I will be talking on late presentations. 10:20 मध्ये. हां, आता मी ओपन करतो. मी करतो ओपन. So actually, Lisfranc injuries or midfoot injuries are not common, but commonly missed. And there are some tricky points which Dr. Girish has already mentioned, and we will try to highlight them in today's afternoon workshop on the radiology and orthopedics together. When do we see the ligament? When do we see CT scan? When do we advise MRI and CT scan both? How to see Lisfranc ligament? Through cases, we have put on some cases, nice interesting cases. But still we have to agree that they are uncommon but commonly missed. And probably we say uncommon because so many times we were calling them foot sprain. Probably ankle sprain exists, but there is nothing like foot sprain. You have to just keep it in mind while declaring that it is a foot sprain. Just keep it in mind that it is foot sprain only, because so many times we miss those injuries. Now, issues with Lisfranc, you understand the joint, that it has got very little cartilage, and that joint is not having adequate synovial fluid around. And third is scanty soft tissues. So 2 points to be remembered: scanty soft tissues and less amount of synovial fluid. Why we are considering these 2 points? Because if some joint is dislocated for little longer period, you reduce it and there is adequate amount of fibrosis there, so it is stable. But imagine TMT Lisfranc joint which has dislocated, you have reduced it, but then to stabilize there is no adequate soft tissue there. Understand this point. So that even if you put a plate, later on if you remove it, there are chances that it will jet out again. So this important anatomy you have to consider. Second, why I talked about synovial fluid, because if articular cartilage is dislocated and it is not bathed with the synovial fluid, its viability is not there. So if I am approaching one joint after say 6 weeks, 8 weeks, how much cartilage is viable? That is an issue. So you should have little different approach in these small joints. So then I will decide whether I will again go for osteosynthesis or fusion. Because these 2 points should be remembered, that no adequate soft tissue around for fibrosis and viability of cartilage because it is not having bath of the synovial fluid itself. These 2 points, just keep it in mind. Now look at this, 34-year male, almost 6 weeks injury, cast was given. But again, these intra-articular fractures, particularly of the medial column, should be treated aggressively. Now, after 6 weeks, we had no option than to go ahead and fuse it like this. So fusion of first TMT joint was done, because later on, after a few weeks, salvaging these joints are going to be a difficult issue. And this is how we achieved fusion. Now, this is fusion in corrected position. Every time this may not be possible. As Dr. Girish has nicely explained, it is probably deformity which is midfoot created. But understand this point. See, midfoot is like this. If I am looking at this dislocation, but I have to look at these dislocations also. I have to put it like this. It is not that easy after a few weeks. Got my point? Now this won't happen that it has dislocated only medially like this, usually. If we say that only medial column injury is alone not possible, why? Because it happens like this usually. And you understand this way. If you want to convince the patient for surgery early, you explain this way, then he understands. That look, you see this much, but usually it is not this much, it is like this. And are you going to solve this jigsaw puzzle by just putting like this? No, you have to get all the joints into place. So this important point you have to remember. Why? Because then if you are looking at late presentation in fusion, then fusion in situ and fusion after correction. These are the 2 concepts. I will show you through cases. 2 cases I will show. Now look at this. Again, same delayed presentation, somehow given cast. It was very unstable. Not every cast patient will progress like this, but somehow this was a patient who was unstable, and this was the result. Now, you have to know, see these, what are the joints involved. Almost all joints were involved, isn't it? And this is how she presented to us later. Now, when they are presented late, identify all the joints involved, and now identify the pain generators. Get the weight-bearing X-rays. In discussion, we will discuss how to take weight-bearing X-rays. And of course, you may have to give local injections, which are the maximum joints involved. We went on to do like this. Reasonably, we were able to achieve reduction, but as Dr. Girish has mentioned, I was not getting that much of good arch, okay? Because all correction interop is not possible after a few weeks. If you are this, we were operating almost 3 months later, but it is not possible to reduce each and every joint. So always remember like this. It is not possible to put it like this, all the joints this way, because then only you will get nice arch. So almost we have less than anatomical position of the joints, but we have done reasonable job. This is how she went on to heal. And this is the next case. So another case, this is how she went on to heal. Now look at this. This is suboptimal arch, but still her pain was less, but then we have to accept it. We will not get everything into place. So sometimes fusion in situ will have to accept. Another case, again same thing. See, we focus on these joints, but look at this, everything is disrupted. So in late presentation, this is a challenging position. So do not miss, and see, she was given a cast. So understand the art of taking good standing X-rays. So standing X-rays have to be taken. Please don't put them in cast like this, because then they will turn after cast removal like that. And we had a tough time to reduce them. It is very difficult after few weeks to reduce them. See, now this was dislocated completely. So we tried to reduce after mobilizing significantly, and used a 2.7 mm plate medially, because that is little sturdy one. And look at this, again less than optimum. This is not what we want to get, but it is very difficult to mobilize after few weeks. And this is how she went on to heal. Her medial plate had so much of stresses that look at this backed out. So amount of stresses while correcting the forefoot abduction and dorsiflexion, they are tremendous. So we could not hold it on, we have to remove it. Ultimately, she is painless, but see that it is less than anatomical position and fusion in situ. So I will end my talk after this case. Just remind of these points, that if we are diagnosing late, keep in your mind about the less amount of soft tissues and synovial fluid. See the cartilage. It is not that every time you will fuse it, but if it is possible to anatomically reduce, then reduce it. Otherwise, sometimes you will have to accept fusion in situ. Thank you so much. We have time for discussion. We will utilize it through cases. Next speakers who are going to present, and till Dr. Rahul loads his case, we will invite some questions. And particularly, if you allow me, I will just, yes.
I just want to say the same thing. I remember when we were really students, there was not much of understanding of this Lisfranc injury, etc. And I really think that how many patients we may have maltreated at that time, because there was no understanding of this. And now with your foot and ankle specialty, probably we are having such good insights. And thank you very much for giving these insights into this type of injuries.
Thank you, sir. I will just, you can load your talk, sir. I will just show you how we should take weight-bearing X-ray correctly. Now, so many times what happens is we ask them to stand on the cassette. Most of the times we have CR system now, and we should know that cost of one cassette is almost more than 50,000. So don't allow your technicians to make them stand on that cassette. But you can prepare a simple wooden box with a slot inside. Only issue is when you ask them to stand, they will stand like this, but obviously on painful side they will offload themselves. So it is not a proper standing X-ray. So what we have made two steps. Now, if this is a hind step, then normal side should stand on the hind step, and the affected side should step down, and he should be given some side support, so that if he is standing totally on this foot, then probably this is a true standing X-ray. So I will just demonstrate. This is a step here, and I'm standing like this. Then only this is a true AP view. Got it? Then very easy. Lateral, AP, and foot AP oblique. Otherwise, that is not a true standing X-ray, and that is why probably we miss so many times foot trauma. In radiology workshop, I am going to show you again one step where we miss those injuries and how to take a proper view. But this is a simple tip how we should not miss these injuries.
But if the patient is having a lot of pain,
Yes.
then in that case, whether you can give some local and relieve the pain and then do a weight bearing field, whether it is possible, we should do it or not.
Yes, sir. Issue is, always remember, patient speaks before radiology speaks. Patient will speak before X-ray speaks. So if patient is unable to weight bear, take it granted that there is something wrong there. Because injecting is going to diffuse your injection. These are not tight compartments. So they are going to diffuse, they are going to give you pain. But then why not to even do same thing when you start surgery, what Dr. Girish showed you, that stress view, always start with stress view. And in my video, some or the other time, I will show you how to take intra-op stress view as well. So this stress view has to be taken, and very important, if he or she is not able to weight bear, take it granted that it is not good. I am going to show through some cases that she was yelling, and they were telling that this is normal, X-ray is normal, she is fussy, she has a very less pain tolerance. It is not. She is speaking, she is giving you some inputs, so she will speak before your X-ray speaks. Yes.
What?
Yeah.
What I want to say is that if you are seeing Lisp Frank on a plain X-ray with non-weight bearing X-ray, still it is important to take a stress view?
Yes, yes, again, important point, because you have identified one joint. Let us diagnose Lisp Frank completely, because as I showed you, we were concentrating only on one joint which was obvious, but then it involves all the column. So you may stabilize, and particularly it happens, you stabilize second joint without stabilizing first TMT joint. It is like fixing ACL without fixing MCL. Got my point? If you don't fix first TMT joint, it will keep on abducting. You are only focusing on second TMT joint. First TMT joint is open. I will show through some cases. If you do not stabilize medial column, it will keep on drafting. It will keep on abducting. And that's why even if you have diagnosed it completely. So diagnosis is also missed, but incomplete diagnosis is also made. You have diagnosed that Lisp Frank is there, but you are not diagnosed that first, second, third, fourth, everything has gone. And you are fixing only second. Most of the times I have seen that first TMT joint is not fixed, but just logically you see, second is grossly displaced. Will it happen that second is grossly gone, but first is not this thing logically? Sometimes it may be intact if there is literally plantar flexion injury. But if it is abduction injury will start medially first. So do not leave it at least unaddressed on stress view.
If you cannot take the stress view, whether CT, you can go direct for CT or MRI?
Yes, but CT and MRI will show you injury, will not show you instability. Two different words. Will show you injury, but will not show you instability. Like afternoon, I am going to show you that Lisp Frank madam has diagnosed, but it was stable. We have conserved and it has healed. So even if injury is there, instability may not be there. Yeah, weight bearing CT is advocated, but in India few machines were there, but I don't know whether it is routinely done. Yeah. Yes. Yeah, please. Last question. And
You just put cross screws from medial cuneiform to second metatarsal and intercuneiform. Is that sufficient, or you mean to say you have to put a plate as well on first TMT?
it is very important to put a plate on first TMT because it is abducting. It is drafting laterally. If you want to prevent that lateral force, very important to put a low profile plate. I usually use those 2.4 distal radius plates as well. They are nice, thin, yet sturdy. So I will show you through some cases. Better to put plate because it is then act as buttressing and then everything comes into place. So it is just like fixing ACL without fixing MCL.
So if suppose a patient comes to you, okay, it's just a scenario, patient is having gross pain, history of trauma, everything is there. You can see a little bit of ecchymosis also, there is a swelling, but on X-ray it's absolutely normal. But patient is having pain. Do you advocate putting a slab and ask the patient to come after 5 days once the swelling comes down and then get the weight bearing X-ray? Or because for getting a stress X-ray also, okay, what Girish has told, even that is painful. So can we buy a time of 5 days or a week
Absolutely.
to get that fresh?
Yeah.
As you can see, I mean, as you are telling, CT scan and MRI doesn't show instability. So can we buy this time, 5 days or 7 days or a week or something like that?
In fact,
before
in fact, even if you are unable to make a decision, what we recommend is repeat standing X-ray after every 2 weeks. Even if you are conserving, even if you are not operating, after every 2 weeks you show on weight bearing X-ray that it is not progressing or it is not unstable, and initially it is going to happen that patient is not going to allow you weight bearing X-ray. It is absolutely fine, but I will warn probably not to put them in cast. Now cast, immobilize, but cast is probably is not a way, because one thing is we are going to close our eyes and we are not going to evaluate injury. Second, do not underestimate CRPS now. We are seeing lot of cases of CRPS now. So cast for more than 2 to 3 weeks, we have to question ourselves why we are giving cast.
Sometimes the stress X-rays are taken in operation theatre under anesthesia, with keeping the things all ready for open reduction internal fissure. What is your opinion about that?
You want to answer?
So I think this is also the wise idea. You keep everything ready. The main importance of doing the stress X-ray is to know the lateral column instability. The medial column, it is easy to understand with the pre-operative workup on the weight bearing X-ray. But the lateral instability, how much abducting, third, fourth and fifth instability can be diagnosed on the stress X-ray only. So I think you should be ready intraoperatively always to put some things, a stabilizing structure for the lateral column also. If your cuboid is disrupted and if the hyperabduction is allowed, it is advisable to put a small external fixator on the lateral column just to prevent the hyperabduction force, which Dr. Sampath has said. So this is a wise idea. Everyone should do the same. And we should, after even before starting the surgery, this should be the part of all disfranc fixation.
Thank you, sir. One thing I want to ask, that first metatarsal phalangeal, first tarsometatarsal joint fixation, whether you should always put dorsal plate or you can put a medial plate?
So there are two ways. If you want to place your incisions little apart, I prefer medial incision, medial plate for first TMT joint, and then dorsally you can use dorsal incision for second and third. But both approaches are fine. If you are taking only dorsal approach as he showed, then you have to take two soft tissue windows. One window, single incision, but one window medial to the vessels, one window lateral to vessel. Then take a big incision. See, in foot and ankle have to have full thickness dissection, sharp dissection. So in that case, take long incision, but make two soft tissue windows if you are taking only one dorsal incision. But generally I prefer medial incision for first and second, third, one dorsal incision, 4, 5, one dorsal incision.
Because I asked because the basic instability is mediolateral.
Yes.
So better to put a medial plate than a dorsal plate.
And have good plates. I saw very beautiful plates with Kotadia sir for his pelvis, small plates. He has made 2 mm, 2.4 mm. Those 2.4 mm low profile yet strong plates are good plates with you.
Sorry, last question
Yes.
because we are running. Since this is a common injury, implant removal, when should we advise? What should be the timing, or we should not remove that?
Yeah, I will give my thoughts. Even Dr. Rahul can talk about it. That's why I impressed that point, that very less amount of soft tissues around. If you remove implant, at least 20 to 30% of our patients may jet out again. So just warn them, if you have salvaged the joint and if you have removed the implant, there is a possibility that it may jet out again. And that's why this happens particularly in pure ligament injuries, pure Lisfranc ligament injuries. Now what we were talking about is bony Lisfranc. Bony Lisfranc is easy to heal, but pure Lisfranc ligaments, then probably I will not advocate removal of implant. It is like auto-stabilizing, they will break, let them break. But if you remove and adequate fibrosis is not there, then they may jet out. And that's why Coetzee et al. In 2012, he presented a paper where ligamentous Lisfranc, he was fusing day 1. But probably that was an extreme approach. Now we don't advocate that. But have that in mind that if you remove and there is no adequate fibrosis, probably they may jet out.
Just a quick comment. I think it's very important to understand that the order of fixation is also very relevant. As Dr. Sampath said, fixing the first TMT is the first puzzle, and don't compromise on the reduction. That reduction has to be absolutely 100%. Secondly, when you're trying to fix the second one, there is a lot of debris inside. So if you don't clear that debris, again, you will not get that metatarsal going inside and getting locked, and then putting this screw exactly. So, and also the third point, that your foot is a medial column is the rigid column, and the lateral column is the flexible column. So in the lateral column, never put a plate or a screw. It's only K-wire flexible fixation. Thank you.
Thank you. Yeah. We will discuss few points through cases. We have good cases here now.
Thank you, sir. And I would like to thank Gurunath sir and Solapur Orthopedic Society for this opportunity. So my topic is the worst midfoot trauma. So I'll be presenting these 2 cases which are not in the line with the standard Lisfranc approach and quite similar looking, but we approach these 2 cases differently. And yes, but they do have a few teaching points. So let's go one by one with these cases. My first case was a 34-year-old female who presented to us after an RTA. She was dragged along with a motorbike and was taken to a nearby government hospital, and later on she came to us. And this was her presentation when she came. And I think the discussion we'll have after the cases, so I'll just present both the cases here first. So this was the presentation when this female came. The thoughts in the mind is the limb salvage always. So this was her clinical picture from both the angles, from dorsal and the lateral view. These were her x-rays. So this was a severe midfoot injury. If you see, it's a gross Lisfranc fracture dislocation along with multiple metatarsal fractures. And as we had discussed about in the previous talks, that almost all columns are unstable, fractured. So before we wanted to go ahead and fix it, our consideration was first the vascularity. Now the CT and the color Doppler were in favor. There was an intact posterior tibial artery and the peroneal artery which was providing the supply, so it gave us some confidence. Second was to prevent infection. So sometimes even if the vascularity is good, but these kind of fractures or the injuries, they end up in infections, and such infection can be drastically ended up in the amputation. So you have to prevent infection in such cases. And third is an anatomical reconstruction. Now, mind you, the anatomical reconstruction is only the alignment part that I am talking about and not a rigid fixation as per the Lisfranc protocols, because the clinical scenario does not allow us. So our aim right now is to provide as much as possible a salvageable plantigrade walking limb to this female. So we went ahead, we did a very thorough debridement of this patient. We did a temporary fixation with the K-wires. The first metatarsal and the TMT joint was stabilized with the screw because we could get some amount of good coverage with the soft tissue. and intercuneiform fixation was also done. So again, going back to the principle that we wanted a rigid fixation on the medial side. So even if we are going ahead and trying to conserve this patient lately, she does not go into the abduction deformity. And the end result was just a target to achieve a plantigrade foot. So serial debridements and the VAC dressing was done. And this lady came to this level after a period of about 3 months. After 3 months, once we achieved a good granulation, we went ahead, did a skin grafting. And fortunately for us and for her, she was able to come back. This was her 5 months post-op X-ray when she was able to weight bear. Now our plan was, if she has any further complaints of pain later on, we might go ahead and do a primary fusion of the other second and third joints, but she has not yet presented to us. Sorry. So again, when we talk about the second case here,
now compound Lisfranc till he loads his talk. Compound Lisfranc is really an challenging scenario where we have to wait till soft tissues they heal, and then probably K-wires they do work well. Yeah.
So again, a second case, a similar looking case, is a young male, 24 years old male. Now he had again an RTA and his foot was entrapped between a bike and a road divider. He was taken to a nearby government hospital and he was advised an amputation. Looking at this, it was quite a drastic decision. Now it was very interesting because he had this accident at around 11 o'clock in the night. He was taken to a nearby hospital. By 11:30, he was in emergency, and the residents were very eager to perform an amputation. He was taken to the OT. He was given a spinal anesthesia. And then patient, for some reason, decided he does not want an amputation. So he was taken out of the OT, under anesthesia, still under spinal anesthesia, came to us, and when he came to us, it was around 1 o'clock. He was still under anesthesia, effect of anesthesia. And we got a fast Doppler and a CT for this patient. This was the clinical picture when he came. And again, the vascularity, as we said, the challenge. He had no posterior tibial artery, he had no anterior tibial artery, he had no dorsalis pedis. Amputation was obviously a good option. It was explained that we can try to salvage this point. Luckily, our microvascular surgeon was in the hospital at that point of time. We sat down together, talked to the patient and his attendants about the possibility that we might try and repair this. But again, the end result could be a drastic amputation. Sometimes a patient who trusts you is very vital to have a good outcome. So this patient was okay with a chance to survive. We went ahead, did a venous graft, and we repaired the anterior tibial artery. Now just to look at this X-ray, it was not just a midfoot X-ray, it was also a hindfoot involvement. Basically, it was a subtalar, pantalar dislocation with midfoot involvement. So intraoperatively, we just achieved reduction of all the joints. This was after the repair of the anterior tibial artery by the microvascular surgeon, and we could cover as much as possible. Now our microvascular and the plastic surgeon did say that the midfoot flap will give up after some time, so don't be happy right now. We waited. 24 hours after, we had a good capillary refill. That was the first good sign. Okay, this video is not working. So anyways, so it was just to show that there was a good capillary refill. 24 hours after that, it was patent. So we waited. Now, but as expected, this was nearly 6 weeks later on that the midfoot flap had given up. So we did a repeat debridement of this patient, and we went ahead and did VAC dressing with a dermal implant. So this was done, a dermal implant and a VAC dressing under it. The patient started to give us some good signs. There was good granulation, and this was 4 months down the line. The good part was patient was very persistent. We continued with the multiple dressings, and total around 13 VAC dressings were applied to this patient. And finally this. Now one important point to see in this case is, this is what happens when you fix it with a K-wire. But though we never had an option even to put an external fixator because of very poor vascularity. But if you could see, there is a midfoot drop. There is a cavus deformity there. This was nearly 5 months later. We did a primary skin grafting and everything was healed. Now we'll allow this patient to walk. This is just 3 days back that we got this, and we'll allow this patient to walk, and we'll see if he had any complaints, any deformity further, we might try to correct this deformity, but then again, the choice of correction would be a frame rather than going and opening it up again. Thank you.
Thank you, sir. Till we take some questions, Giri sir, can we load your talk, please? Your case? Okay, then can we ask Sunil sir to present his case, and we'll take some questions. If we are managing the compound scenario, yes, Sunil sir, please load your talks. So if we are managing this compound scenario, what I will recommend, more difficult situations, go for more simpler approach, like simple K-wire is also fine. But if you put one Dunham pin through calcaneus and one connecting rod on lateral side, one connecting rod on medial side, it maintains fairly good length. It is least morbid. One Dunham pin through calcaneus, and what Jess fixator you apply for 4 mm Jess fixator for your distal radius ligamentotaxis. So one pin in the first metatarsal neck, one pin in the fifth metatarsal neck. That's it. That quadrangular frame will give you good length, and then supported K-wires. Sir, we are waiting for you. So those K-wires will help. So I agree whatever Rahul sir has done. More difficult scenario, go for more simpler solutions. We will not be heroic in putting plates and anatomic reduction there, because even reconstruction of this foot is good. We have to keep it in mind that foot will not give you repeated opportunities to revisit, because even soft tissue procedures, repeated soft tissue procedures will not yield that good result. So one simple frame and simple K-wires, I think, will maintain the length well.
Excuse me, anybody with the mobile? Please.
Yeah, Sunil sir.
Good morning. Those who have come late, I think will again revise. And I must tell, not all government hospitals conserve the less francs or go for amputation. Sorry to your previous speaker. This is like a TFCC of wrist joint. You know, we all know triangular fibrocartilaginous complex is very, very important for maintaining this grip strength. It maintains the stability of the wrist. Similarly, this Lisfranc is very, very important, which takes the brunt of your weight while weight bearing. It maintains the arch. It is a summit. It is like a pull. Very important stone. When it is removed, there will be collapse. So it is a very important part of the transverse arch. If you go back to anatomy, longitudinal arch and transverse arch, it forms a very important summit in the transverse arch. So these are the types, that type A, B1, B2, C1, C2, divergent and all, which were discussed previously by previous speakers. So the main force is the brunt on the first toe in a plantar flex. So very common in footballers. It's a direct fall on weight or twisting foot, axial loading, abduction with a flexed hind foot. So most common is road traffic accidents, sports injury, or windsurfers. So the common clinical presentation is pain, swelling, plantar ecchymosis, and tenderness. Of course, you can go for what? Flexion of foot at Lisfranc joint. You can do a piano key test. Press the second metatarsal. If it goes down like a piano key, then that is a very important clinical sign. And you can, of course, go for passive abduction and pronation for stress view, as well as seeing for the pain at the Lisfrancs. So you can go for X-rays, stress views. A lot of have been discussed by Sampath sir. And definitely 20% of injuries go unrecognized. So it is very important for all GR1s who takes the brunt of the casualty in the first setup. So many ankle sprains have been sent home just with a BK slab. So you must remember, each and every foot sprain, there can be a missed Lisfrancs. So indications of injuries are stage 2, stage 3 with more than 2 mm of diastasis, any unstable like piano key test, and goal of surgery is definitely anatomical reduction of TMT with a stable. That is second metatarsal is in the peg. So that is our goal. what are contraindications? Definitely, there are contraindications like medically unstable, poor soft tissue coverage, non-ambulatory patient, and poor peripheral vascular supply like uncontrolled diabetes or smoker. So complications, definitely we must understand there are complications like compartment syndrome, distal neurovascular deficit, late arthritis, and deformity like flat foot. So the first case, 23-year-old male with a RTA 2 days back with a swelling over his left foot, no history of any other trauma, non-smoker, non-alcoholic. So this was his 3D CT. I'll straight away go to everybody can see it's a C1 type of injury, divergent at the midfoot with a base of second metatarsal fracture as well as Lisfranc's ligament injury. So this was his X-ray. He was a biker, and similarly in the plantar flexed, he bumped the divider, road divider. So this was a day done on a day 1. Definitely anatomical reduction of second metatarsal, and as Sampath sir said, from one screw needed from the medial side, that is from the base of first metatarsal to the cuneiform. So this was his after implant removal of almost 6-year follow-up. Arch is maintained. There is slight valgus is seen in a hind foot, you can see. He is completely weight bearing without any pain. Another case, 24-year male
Sunil sir,
presented with...
Sunil sir, can we discuss first case?
Yes,
if you allow.
okay.
Can we go to this thing?
Sure.
Can we go to the last this thing? Because there are very few important points. See this now, as sir said that there is little valgus, that is little abduction. You see, abduction of this forefoot.
Even
at
on
midfoot.
hind foot you can see.
Yeah.
There is little abduction.
Yeah, just see this now. If you, because all of us we have done that. Now, how to read this injury? Look at this. Everything is gone here, and this takes away our attention over here. But what I was saying, MCL and ACL. See this now. This medial column is dislocated, and what we fail to recognize is, see this. First cuneiform has a facet on navicular. Now, thus, this first cuneiform should never be in the line of navicular. It should be at least 1 centimeter lateral to the navicular. Got my point? This first cuneiform should be at least here. This is a facet. You got my point? Are you able to see? Yeah. This is a facet for the navicular where it should sit down. Okay. So, if this is like this, keep it in mind that there is already something wrong here, and that's why Sunil sir has got nice reduction. He's been holding it with this, but if I start a plate from here, straight under contoured plate will achieve reduction. Anatomical plates usually need you to achieve reduction everywhere in the body. So straight under contoured plate, if I start from here till here, usually 2.4 or 2.7 mm plates, if you start from here and here, they will automatically take this inside. I will show you through some cases. So first, if you take it, immediately abduction is corrected. Got my point? Now, he has also done it, but these implants will not hold it that great the way you were holding it with the plate. So somebody asked question whether to plate or this thing. Plate is always better as a reduction tool and as a maintenance tool also. So whatever 10%, I am not criticizing his reduction, I have also done same thing, but then to improve that abduction, patient is painless, but to improve that abduction and again you see, I will show you on your other x-rays that this is never like this here. See, it should be here. Got my point? So it should not be in line with here, and this is also to be neutralized with one medial plate. It will give you very good reduction. So medial plate. So you can see. Can I go back here?
Yes.
You can imagine that this much is disrupted. in abduction. This much is disrupted in abduction. Without medial column disruption, is going to happen? No. So first thing is going to be on medial side. So medial side is going to absolutely open. So try to rigidly fix this column. So next time what you do, sir, plate from here to here, one screw in navicular, a tip. If I can get one model, next time I will show you. A tip. When you start drilling, just drill first cortex. Why? Don't drill bicortical. Then you start the screw and it will not pierce the joint. It will find its own path because that screw is difficult to penetrate the joint unless you drill. So less CM exposure. And it is a boat-shaped bone, no? Boat-shaped bone. So like scaphoid, you keep on seeing in the trajectories and somewhere or the other you are out. So instead of doing this, if this is a navicular, drill one cortex and start putting the screw, cortical screw 2.7 mm and or 2.4 mm, and then screw will find its own path, but it will not penetrate the joint. Got my point? That is the first screw, and this is the first screw. Got my point? This plate should be under the tibialis anterior tendon. Only structure here is going to come is tibialis anterior here. Got it? Under the tibialis anterior, and second screw should be here. So your plate is one screw here, one screw in the navicular, job is done. Then put in between screws, but then this under contour plate is going to drive the medial column in correct place. Don't put these screws first, otherwise it is going to maintain the abducted position.
Yes.
Okay, thank you, sir.
Yeah, that we have.
Sir, under contoured means a straight plate. See, this is under contoured. So same. Yeah, suppose my this thing is deformity is like this, but I am putting a straight plate that is under contoured for this surface. Then it is going to get the reduction. Same thing in fibula. Fibula, nice anatomical plates are available. People are using this. That's fine, but then it is your responsibility to get the reduction. Don't expect plate to work up magic for you. But if you imagine under counter, that is straight 1/3 tubular plate, you put on the posterolateral surface of fibula and you tighten one apex screw, it gives you beautiful reduction. It drives everything towards the middle malleolus. So that is one of the tool where you will get the reduction with plate. But with anatomical plate, if you want to do that, then what happens is anatomical plate has a valgus inbuilt, and then it will keep in abduction, or it will keep in valgus.
Yes, yes.
But then you can counter it, but then you will have to achieve reduction. Your plate will not allow you to get the reduction. Yeah, but then, sir, this reduction has to be there, sir. I am saying to achieve this reduction, I want to push this cuneiform laterally. Got my point? If I want to push this cuneiform laterally, I need a plate. Now see, my first plate is going to be here, point.
First screw.
Second counter is this. So it has to come inside. Got my point? So this has to be understood, and navicular and cuneiform anatomy has to be kept in mind. I will show you through this case, some cases. Yes, if you want to achieve reduction, at least first 2 screws should be cortical screws, because then they are going to achieve the reduction.
So we have corrected the same thing, all things in second case. You will see. 24-year male presented with a history of fall from height on a plantar flex foot, came with the OPD with complaint of pain and swelling over right foot, definitely 1-day-old trauma, closed Lisfranc's fracture dislocation. So this was his X-ray. We had gone for CT and it was confirmed that there was a flake sign and second metatarsal. So you can definitely, on opening, you can see the fragment of base of the second metatarsal. Well, Lisfranc's ligament is attached. There is a flake sign, and piano keys test is also positive. You can press that second metatarsal base downwards like a piano key. So after reduction, temporary K-wire fixation is done. Then what we did was to maintain the arch, you have to bowstring the FHL. That is very, very important. When you dorsiflex the first great toe, that will build the arch, longitudinal arch, and that will maintain the transverse arch as well. So this is the crux of this surgery. Always dorsiflex while you are fixing the midfoot. That will help in maintaining. Otherwise, you will end up in fixing in flat foot only, flat foot position only. Or if you plate a dorsal plate, then that itself will collapse the arch. So this is the crux key point. We did fixation with a Z plate, that is a crisscross plate which is available nowadays. So this plate, as there was a articular cartilage damage, and so we sorted for primary orthodesis, fixing from first empty definitely the medial column and lateral column, and the crux of fixing the Lisfranc's. So this was the final picture, intra-op picture. So nicely fixed and very stable configuration with maintained arch. So this was his post-op picture and intra-op picture. So thank you. Thank you for allowing my presentations.
Yeah, Sunil sir, the last question. Yeah. Who is the next? Yeah, Swapnil sir. Sir, in this case, probably you have a cuboid injury as well, right?
Yes, yes,
Yeah.
yes, yes.
So,
yes.
Anything you did for the lateral column also?
No, sir, no.
Okay. So, I think, sir, when you have a cuboid injury, these are the cases where you are very high likely to end up with the hyperabduction. Because whatever you are doing on the medial side, there is always a force which will bring all the metatarsal on the hyperabduction. So I think these are the cases where you should start with the lateral column first. You put a small external fixator, prevent a hyperabduction, and then that reduction will be easy. And when you are dealing with first column and the second column injury only, third, fourth and fifth are stable, I think this dorsal approach is a great technique to fix all the two cuneiform, the two metatarsal. But when we are dealing with the lateral column injury, I think the Sampath sir, which earlier he explained, one direct medial incision and the second incision on third and the fourth, second and the third, it is one of the very good method of fixing this thing without deformity.
And Swapnil sir, just I'm going to take 1 minute. What he explained, Sunil sir has mentioned is very important point. When you want to have good normal medial arch, you have to dorsiflex the toes, all the toes. Why? Because intact plantar fascia is going to act for the creating the arch. So these all toes should be dorsiflexed. Then it creates a good medial arch if you want to have anatomical medial arch. So dorsiflex all the toes, and intact plantar fascia is going to act as a bowstring. Yeah, please. Thank you. Thank you, sir.
So good morning friends, this is just a case presentation and not any theory. So here is a 55-year male patient with history of road traffic accident due to fall from bullock cart. Complaints of pain and swelling over both feet. Clinically there is a huge amount of swelling, bilateral, tenderness, movements were painful, no distal neurovascular deficit. So this is his right side. There is a complete disruption of tarsometatarsal area, and okay, so this is the right side which is showing there is complete displacement here, as we can see here. So the patient is having gross amount of swelling, as I told. So what will be the approach for this type of patient when it comes to you, Sampath sir?
So always we should know that these have aggressive soft tissues. So first we will identify injuries and we will allow them to settle. But if you feel that it is very unstable, then for temporary purpose we can put them in K wires if it is dorsally dislocated. But generally I will just wait with the posterior slab and wait till soft tissues improve.
So Girish sir, how many days we can plan to wait for the soft tissue to heal, or as sir has told, you can go for temporary some fixation, wait for few days and then again address him with open surgery?
Swapni sir, the majority of the soft tissue problems, it comes with the dislocation of first TMT. If your first TMT is okay, usually these are the cases which don't create any impingement on the vessel, and these are the cases which usually settle down even without doing a close reduction. And doing a close reduction and the fixation with the K-wire is very difficult in this case because there are a lot of impinging structures at the base of second. Yeah. So if you just give a slab for 7 days, usually the injury will settle down.
Okay.
And then you can go with the routine. Okay. But if you are dealing with a fracture dislocation of first and second TMT with a hyperabduction forefoot, these are the cases which you may need two-stage protocol. I mean, the Sampath sir which I said.
Two-stage.
Yeah, I mean, first reduction with K-wires, because if you keep them dislocated and if you wait for the soft tissue to settle, it will not come down to the position because a dorsal subluxation of the first and the second TMT, it creates a pressure on the dorsal vessels.
Okay. Okay.
So usually these are the soft tissue will take very long time. Okay. So if you do the close reduction K-wire for those cases, you may be very easy to get the soft tissue settlement in 7 to 10 days. And then you can go for the second stage.
Rahul sir, your opinion?
So I absolutely agree with them. And one more important thing about Lisfranc is that out of other midfoot injuries, Lisfranc is notorious to go into compartments.
Yes, that's
so. If you ever suspect that it is a high velocity injury, the amount of swelling is too gross, I would rather advise you to keep patient with you for next 2-3 days. Yeah. Admit it, observe him, keep it elevated over 2 pillows and observe him that he is not going into a compartment syndrome. Once you are sure that it is not, then you can discharge the patient on a slab, back slab for about 7 to 10 days and get him back. But yes, any amount of gross dislocation, if it is present, it has to be reduced back. If possible, close, otherwise just small open, put a temporary K-wire, let him go and do a second stage fixation.
Any role of maxillary dressing or now the zinc plast, any
I don't think
faculty who can apply this to reduce the swelling, elevation, ice fermentation?
Yes, that's what. Elevation, ice fermentation, everything is going to help.
Okay.
So all the measures.
But any application like Maxell for zinc plast, what?
I personally don't use and don't have experience with that.
No, sir. I mean, the use of glycerin max sulfate, I have learned that it is okay when you are dealing with only the cellulitis problem of the soft tissue. When it is the soft tissue compromise due to the bony dislocation or the underlying bony injury, I think we don't need this stuff to remove the lymphatics from the skins, and just wait and watch elevation, elastocrep application and enzyme preparation, usually sufficient for most of the time.
Okay. So the crux is when the swelling is there, we can wait. The most important thing, don't rush and fix with the plate because there are very high chances of soft tissue which may get exposed and patient may lead to some form of infection or something like that. So wait till the soft tissue get healed up like in calcaneus fracture, upper and tibia fractures to avoid the compartment syndrome. So this is the first take home message. So this was done close reduction and just a K-wire fixation was done. This is done in 2011 I think. So before I meet Sampath sir and before I start attending the foot and ankle conferences. So this is done just with closed K-wire, and here you can see there is a swelling which was there on this part on the right side. So it is just reduced with temporary flexor K-wire. I know this is not a stable fixation. This was just done on a temporary basis, and I told patient that he may need to fix it after a few days once the swelling subsides. And this is the left side. Again here there is a complete combination of the foot, tarsal metatarsal area. On this side I fixed with temporary K-wires and a fixator what Rahul sir has showed, but it was a compound. This was with a gross swelling. So the indications for K-wires are again swelling as well as compound injury. And this is the clinical picture of the same patient. And this is 1 month follow-up. This is 2 month follow-up. And again on the right side again 2 months follow-up. Unfortunately this patient did come for follow-up after 2 months. I called him 2-3 times, but he said, I'm okay, and with some other orthopedic surgeon in his area, he removed the fixator as well as K-wires, and patient came with his relatives 9 years after that. So this is his X-ray on the left side, and this is the X-ray on the right side, which is standing. As you can see, as everyone is telling, the dorsal side on the right side, you can see there is still displacement on the dorsal side. The talonavicular joint is not aligned properly. So actually he need to be fixed with a plate. So this is follow-up is good, but this is not a very ideal scenario. So this is 9 years follow-up. This is weight bearing. The arch is good, but still these K-wires and fixator mean to be a temporary fixator. So this is just a case. The results are good, but don't go every time. We cannot get these results. So fixation with the plate is very ideal to maintain the reduction and maintain the arch. Thank you.
Thank you, sir.
Thank you all.
You will not get the same result.
Exactly.
So if you put an external fixator K wire in a grossly comminuted, so much of scarring, it stabilizes and you get away. But that's the point. If it's more ligamentous, more stability, right?
Thank you.
Thank you all, the panelists, for the wonderful session. Please wait. Dr. Pradeep sir is going to felicitate you. Please come, all the faculties. I request Dr. Pradeep Munot. Yeah. All the faculties, please come up. Dr. Girish Motwani, please come. Yeah. 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 Dr. Dhrumin. Dr. Dhrumin Sangui. Dhrumin, Dr. Dhrumin. Okay. Dr. Sampath. Yeah, thank you. Dr. Rahul Upadhyay. Dr. Sunil Andralmar. Dr. Swapnil Kothadia. Yeah, again, thanks to all these panelists for a wonderful session. We are heading towards the second session. I hand over the mic to Dr. Arvind Kumthale, Dr. Vinay Gundla, Dr. Avinash Kulkarni, and Dr. Rohan Singh. They are the panelists. And moderator, Dr. Nagesh Naik, Dr. Mahendra, and Dr. Madhura Kulkarni. Please come on the dais.
I thank all the chairperson, Dr. Pradeep Kothadia sir, Dr. Adarsh Mehta and Dr. Bhandari sir. Thank you for chairing the session.
Next session is malleolus fractures. I request moderators Dr. Nagesh Naik sir, Dr. Mahendra Kuchadkar sir, and Dr. Madhura Kulkarni on this side, and our panelists Dr. Arvind Komthale, Dr. Vinay Gundla, Dr. Avinash Kulkarni, Dr. Rohan Singh is there. I request all the faculties, moderators and panelists, please stick to the time, please. With gentle reminder, I request all of you, because program is very tight schedule is there. So I request everybody, please finish in time so that there will be good discussion. The motto of this conference is learn through our own cases and discuss the cases so that everyone will enjoy the academic discussion.
Good morning, everyone. Today we'll start the trauma session of malleolus. The first lecture by syndesmosis injuries by Dr. Girish Motwani.
Yeah, thank you, Madhura madam. So I am basically covering the talk of Dr. Lucky as well as my own talk. So it's like approach to the rotational ankle fracture and the syndesmosis both. So with the due permission of the moderators, I will take 10 to 12 minutes. Yeah. Thank you, sir. Yeah. So we all are aware about the rotational ankle fracture malleolus injury, and I'm just going with the routine case because Gurunath sir has specifically warned us that it should be the case based. So no theory, case based. 35-year-old female fell down from the stairs. This is an injury. Anybody wants to read the injury? Or it's a simple case? Routine one? No. Okay. So the CT scan was done to know the injury in the better way. So there is a lateral malleolus fracture, there is a posterior malleolus fracture, and there is some widening of the medial, deltoid space, we don't know. So CT scan was done to know this injury in the better way. So you can see what is the type of posterior malleus. It's a simple looking posterior malleus, but there is some interfract piece, and there is almost no syndesmotic disruption, but there is a Weber B fracture of the lateral column. So this is the case which you usually start with the posterolateral approach. We all are aware about the posterolateral approach, that you have to be in the anterior half of this, between these two lines, and this is lateral malleus, Achilles, medial border, and this is how we do the superficial dissection. You can be little anterior to the sural nerve if you don't want to see it, but this is a routinely described incision on the textbook, that this is a routine incision. You are going between the center of these two lines and you want to identify the sural nerves and the vessels. You are securing the vessels with some rubber tubing, and this is the way of identifying and securing the neurovascular structure. But there is a modification, you may not be able to see it. Go little anteriorly, secure your all vessels in the soft tissue, and you may not be able to see the sural throughout a surgery. So this is how you have to protect it, and you retract it. Now after this dissection, superficial dissection, it's very important to identify the peroneal sheath, and these are usually the peroneal tendon which are close to the posterior border of the fibula, and you separate a sheath to mobilize the tendon so that you can move anteriorly, posteriorly, and you may be able to see the lateral column, the lateral malleolus and the posterior malleolus. So this is how you separate a sheath, you separate the tendon. If you retract the tendon posteriorly, you see the lateral malleolus. Apex of the fracture is very important, identification of the lateral malleolus, fracture, reduction, rotation, length, alignment. And then after doing a temporary reduction with the lateral malleolus to get a length of the fibula and correction of the rotation, then it's a time to move and see the posterior malleus. And this is a routine dissection. We separate the flexor hallucis longus, and you have to identify it by moving the great toe. If you are in doubt, you can move the great toe and you can see where is the posterior malleus and where is the flexor hallucis longus moving. So you separate a sheath of the flexor hallucis longus because it's a low lying belly. It's a very tough, hard belly. You see a lot of mass. So for the retraction of this belly, you need more force. You need to separate it from the posterior malleolus through the periosteum, and once you separate the belly after a strong instruments, you may be able to apply a Homans, and this is how you can see the posterior malleolus. So this is a routine posterolateral approach to the ankle. So my posterior malleolus was fixed, my lateral malleolus was fixed, and this is a routine plane to identify both the fractures and a contoured plate. Now many years we have used the distal and radius plate. It should be properly contoured. The apex of the plate should be stick to the bone and it should not be out, and this is how you apply a plate. But now we have designed a posterior malleolus plate which is available with the Nebula Surgicals, and which has a main supporter for the today's conference. You can go and have a look on the posterior malleolus plate, and if you don't have the posterior malleolus plate, this is how you have to contour it. So a tip of the plate should be on the inner side because there are a lot of tendons, and then 1 or 2 hole proximal, you can just have a bend like this. So this is first bend. I am just giving you the idea of using a distal and radius. You can use the anatomical plate also, but this is the second bend. So the plate which was like a straight plate, now it is contoured like this. Only when you contour like this, then only you will be able to apply and buttress it on the posterior malleus anatomically. Because see, there are a lot of tendons, and sometimes in our practice we have applied a plate like this, and this is a plate which may create a problems on the tendons. So a plate should not be off because it create a buttress. Your work will be okay. I mean, your reduction will be fine because it's a buttress principle. It's not a neutralization plate. So your reduction is fine, but the problem is the impingement of the tendon, and you need a removal after some time. And then it's a routine posterior malleus fixation through the plate, and this is a routine fixation of the fibula. Many times I use a recon plate, but when I'm dealing with osteoporotic patients, when I need more locking options, after the good reduction, I applied a anatomical plate on the lateral aspect of the fibula. So this is how the simpler case was dealt with the open reduction internal fixation. At the end, we cannot leave the operation theatre by checking the syndesmosis. And this is very important to check a syndesmotic instability, because when you fixed everything, you want to see whether it is stable or not. And what is the gold standard? Still after many years, the gold standard is the Cotton's test. So you apply a gentle force, and this is how when you apply a cotton, when you apply 3 centimeter above, when you apply a lateral force, you may find that there may be the widening of the tibiofibular space, or with or without the increase in the medial clear space. So they all suggest a syndesmotic disruption. This is an example of a stable syndesmosis. When you apply a lateral force, your medial clear space is fine, your tibiofibular space is fine. But when you find this kind of X-ray or the intraoperative stress X-ray, you have to fix the syndesmosis. So this is a stable fixation with no syndesmotic instability, and this is how the fixation was done. And the tension-free closure in 2 layers, we all are aware about the wound management. A syndesmotic clamp. Now we are talking about the syndesmosis, whether the clamp should use or not. What should be the position of the clamp? What are the precautions when you are using through the clamp? And what are the risk of malreduction? So let's go to the point number 1, whether it should be used or not. You can use it if you are doing a reduction by closed method. But it is an instrument which may give you even more malreduction rate if it is not precautiously used. So what should be the position of the clamp? This is very important. Nowadays we are shifting to the open reduction of the syndesmosis. But you can do the close reduction if your injury is stable. But a position and the application of the clamp should be very important. So when you have a more instability, you always open it. But when you want to do the close reduction, you can apply a clamp in a proper way. Now, how to avoid the malreduction of the syndesmosis? What should be the position of the clamp? Now, these are the 2 beautiful articles which are talking about the position of the clamp. And usually we apply a clamp in a neutral axis. We buttress the lateral malleus, we buttress the medial malleus. But a clamp, oblique position of the clamp, it reduces the malreduction. It's not a neutral. What does it mean? A, B and C point on the lateral malleus, and first, second and third point on medial malleus. Now this is the axis of application of the clamp. If you have applied, if your clamp is neutral, it gives you even more malreduction because it shifted the fibula down. If the syndesmosis is unstable, the fibula can move anteriorly, fibula can move posteriorly. So if your clamp is not proper, it may leads to malreduction of the position of the fibula. So, 2 prongs of the clamp should be visible, point number 1, and it should be applied on the oblique axis. It should not be a neutral axis. If you are neutral, it means always go and again correct it. In lateral position, see, it's not required, but if you want to know more about the position of the clamp, in the lateral position, your anterior prong should be in the anterior half of the lateral view. So this should be the position of your medial malleolus clamp. And now, as I said, now we are moving to the mini open reduction of the syndesmosis. So this is considered as a most vitential approach to fix the syndesmosis. A small mini incision on the anterior column, see it, fix it, feel with the finger, put the K-wires, don't use a clamp. This is a current practice of using a syndesmosis. Now, how to prevent a malreduction when you are doing a open reduction or the close reduction? These are the 2 K-wires which are very important when you are fixing a syndesmotic screw. one wire anterior to the fibula, because fibula may move anteriorly. So anterior malreduction of the fibula is very common. So one wire, anti-glide wire, which will prevent the anterior migration of the fibula, and one wire through the fibula, and both the distance between both the wires should be 2 to 3 centimeter, where you can put a screw or the tight rope. So this is how you can see the reduction, you can temporarily hold the reduction, and then you have to screw it. So these are usually the two wires which are very helpful, and this is before and the after application of the syndesmotic screw. This you have to put a probe and you have to apply a pressure so that you can move the fibula, but after application of the syndesmotic screw, make sure it should not be very tight, otherwise it may lead to secondary problem of over tightening and the restriction of the dorsiflexion. So a syndesmotic screw insertion, what should be the angle, what should be the position, whether it should be the solid or the cannulated, and how many the numbers. Now there were many problems, there were many articles talking that there is no significant difference, but we will try to find out some learning points. What should be the position? So whether you apply a 1 screw, 2 screw, that's fine, but this position of the drill, it should be 20-25 degree down the neutral axis. Why? Because this is a study which is showing that if you are anterior, if your screw is anterior, you will get anterior malreduction. If your screw is posterior, you will get a posterior malreduction. As I said, the fibula is a plastic bone. Wherever you put a screw, it will go in that direction, and that creates a malreduction. So you should be at the center, neutral. You should not be anterior or the posterior. Another important trick, always get done the lateral X-ray and take a shoot and put it on the opposite side of the screen before you start a surgery. This is an uninjured X-ray. And then you compare your reduction, lateral view, with the uninjured side. So if suppose your distance between the posterior border of the fibula and the posterior malleus, if on uninjured side is this much, on injured side if it is this much opening, you can understand that my fibula is shifting anteriorly. Again you take out a screw, you compare it, fibula should be at the lateral or the posterior half in the lateral view. This is a key. So this is a tip to reduce the anterior fibular malreduction. Now in some cases when the patients are sports patients, young patient, high demanding, I sometimes use the tightrope, but it is not when you compare with the screw, there are a lot of things to consider, but it's considered as the most flexible fixation. So when you see a lot of articles, there is always confusion between, some say that there is no difference when you apply a screw or when you apply a tightrope, but for the younger athlete patient, that has been documented in many studies that the flexible fixation is important, and there is a sports performance or the dorsiflexion is far better on the tightrope patient as compared to the screw. So this was a 26-year-old boy, twisting injury, pain, swelling, instability. This patient, there is some widening on the medial clear space, you can see, but when on the weight-bearing X-ray, because the patient was comfortable, so we tried to take a weight-bearing X-ray of the ankle, and now you can see what is the injury level. What is the widening of the tibiofibular space and how much is the medial clear space widening. This is possible only when you have a disruption of all 4 columns of your foot. Medial, lateral, posterior, anterior. Trimallear, quadrimalleolar fracture. So this is the soft tissue form of that injury. So this is possible when you have a syndesmosis and the deltoid rupture. So this is how the reduction was done, tightrope was applied. But even application of the tightrope, you can see on some valgus application of the force, we are getting some talar tilt. So this has been corrected with the application of the anchor. You can apply a 3.5 mm anchor, 5 mm doesn't make too much difference. And then you repair your soft tissue. Don't go up to the deep deltoid, but you repair the soft deltoid. And this is a stability video of the same patient. And this is how, when you apply external rotation, there is no opening on the lateral side and there is no widening of the medial clear space. So to know whether we are failing or we are successful understanding the cause of failed syndesmosis is very important. So this is not my job. Dr. Sampath will definitely bring you more attention for the posterior malleolus fracture, but poor management of the posterior malleus, poor management of the fibula, poor management, poor reduction of the syndesmosis, clamp application improper, screw orientation is improper, premature removal of the screw. These are all the causes of a failed syndesmosis. So understanding the techniques of reduction is very important. And in the last slide, I just want to bring this paper, which is saying that the malreduction rate in in rotational ankle fracture, syndesmosis malunion, is more than 50%. If you don't see the syndesmosis, if you are doing close reduction, see, 1 out of 2 patients, we are doing syndesmotic malreduction. But a same malreduction, when you see it directly, open it, it is still 16%. So, it doesn't mean that opening the syndesmosis is solving all the problem. Techniques of the reduction, understanding the malleolus fixation, these are all important. You may get malreduction in open technique also. So, be precautious. Thank you so much.
Thank you, Girish. It was an excellent presentation. Just 2 points I want to make.
Yes, sir.
One is in the exposure. If you want to get a good exposure in posterolateral approach, releasing the tendon sheath of the FHL and peroneal is very, very important. Otherwise, you will not be able to mobilize it.
Yes.
That's number one. Second, so many times when you go in, you retract all the muscles, you will not be able to see the posterior malleolus at all. On the X-ray, you can see it, but you can't see it in intraoperative. The reason is you have to incise that thick periosteum and go to the apex, and only then you will be able to see it. That's the second point in the exposure. As far as syndesmosis is concerned, as Girish has very tightly said, now reduction of syndesmosis is not a compression mode, it is a positional reduction. If you try to compress the syndesmosis, you're going to get a malreduction. And once you do the CT, there are some incisura fibularis which is very shallow. So it has a tendency to go anteriorly. So if at all you press, it has to be more posteriorly. But once you start doing CTs, even pre-op CTs, you will get an idea about what is the shape of the incisura, where you are going to position the clamp, and a very low threshold for open reduction of the syndesmosis. This will avoid those malreductions. That anterior K-wire is an excellent way of preventing it, but be aware that just doing a small open reduction is not going to compromise, but it's going to help you to get the best position. And it is a positional reduction, not in a compression mode. That's why the tightrope sometimes gives you a better result than a screw. Because in a screw, you're trying to push it and jam it inside. You don't need to. It's just closing the ring. That's all.
Yeah, I think I completely agree to you, sir. And the small message, which, if I summarize this thing, a small message which I want to give for all rotational ankle fracture, if you're using a posterolateral approach, don't compromise with the small incision. Take a big incision, little lazy or the straight doesn't make too much difference, but always see the things and retract the tissues in a comfortable environment. Don't try to do this by MIS technique. There is no MIS technique for the malleolus. You need a soft tissue dissection. FHL is a low-lying belly. You need to do lot of work for the FHL. Peroneal are very simple. When you mobilize the sheath, you can move the peroneal tendon anteriorly or the posteriorly. If you want to see the fibula, you can mobilize it posteriorly. If you want to see the posterior malleus, you can mobilize. But FHL is a non-moving tissue. It doesn't move too much. So you need a long incision, separation of the belly, releasing the sheath, and then applying the 2 Homans retractor to see the small posterior malleus fracture to avoid the wound complication.
For benefit of delegates, when will you advise removal of these screws?
Yeah, so I think, sir, this is a very wise question, but now after so many articles, it has been final conclusion that you don't have to remove it. Let it break. Explain to the patient that if your body needs the movement at the tibiofibular site, because you are not fusing it, if your body needs the movement at the tibiofibular site, it will break down. But if you want to remove it, always remove after 4 months, if you want to remove it. But if your patient is having pain, if your patient, after doing all good reduction, if your patient is having pain and some restriction of the dorsiflexion, always suspect some amount of malunion at the syndesmosis. And these are the cases where you need a planned removal, early removal of a screw. Because sometime after removing the screw, you will find that there is improvement in the range of motion and the pain disappears. So after 2-3 months of all union of the malleolus, if your patient is in pain, remove it. If he is not in pain, don't remove it.
And does it depend on 3 cortex, 4 cortex? No.
So if you allow the patient to break the screw, and if you want to remove it, only the tetracortical screw you can remove. So removal is easy with the tetracortical. So tricortical, when you are planning for the removal, tetracortical is good. Suppose if it is broken, you can remove from the opposite side. So tetra is better. Yeah. Yes, sir.
Not very sure about the ligaments regarding the interosseous ligaments which are there near the syndesmosis. So can we, out of box thinking, can we have a combo technique like screw fixation as well as tightrope? With screw fixation, you maintain it for some days. After some days, you remove the screw, the tightrope will take over and it will give some mobile. Whether it is just out of box thinking, whether it is possible.
I mean, there are a lot of UK-based articles. Drumil might be knowing the better. There are a lot of UK people that are doing the same thing, and there is nothing wrong. They keep the tightrope for the long, and then for the after some time they remove the screw. But combination of both the techniques, they are not too much helpful in our settings when we are seeing a less sports people. These are the cases which they have done for the sports people. Because they want to maintain the reduction, so they have done a screw fixation and after some time they have removed and so this is a good idea. But so the thing is, you don't need this much amount of fixation, syndesmosis with screw and a tightrope, if your all malleolus fixation is proper. The need of syndesmosis reduction with just a tightrope or the screw is 20% in rotational ankle fracture. So it's 1 out of 5 patients you will require the syndesmotic fixation. Rest all 4 patients, 4 out of 5, if your malleolus reduction is good, you don't need syndesmotic fixation.
So there is one study where if you reduce the posterior malleolus, it increases the reduction by 57%.
Absolutely, yeah, completely.
Yeah, syndesmosis.
Yes, sir.
Because look at it as a ring. It is not just one facet.
Whenever there is a fracture, you fix the fracture and everything comes in position, that is okay. But when there is only ligamentous injury, they are more unstable than the fractures. People say fractures are better than the ligaments injury, always.
Yeah. Can I?
Please, sir.
Sir has made important point. Even I was going to discuss in Girish sir's case, this much of instability, if you find, always look at the proximal fibula. Okay, if proximal fibula is broken, then probably what he is talking about, or you are talking about, 2 screws, because I am not going to go that proximally to fix it. See, syndesmosis is gone, but both malleoli intact. That is what was his case. All interosseous ligament is gone. We are not talking about that. Many times we talk about deltoid, we talk about anterior syndesmotic, we talk about posterior syndesmotic, but even interosseous ligament is equally important.
Yes.
And along with that, if this is gone, now more and more literature to say that even you should fix this. But for the sake of nerve and all those things, we are not that aggressive. But in that scenario, we will advocate you to put 2-hole plate and 2 screws, because this is an indirect responsibility of complete fibula on these 2 screws. Got my point?
Yes.
So these 2 screws are going to be most vital screws. And along with that, for the sake, we were doing this, to answer your original question, we were doing this flexible technique, and when we were not comfortable that only this flexible screw button is that good, then we used to insert this screw and remove after 3 months or 4 months. But these 2 screws are most important, rigid, when you have proximal fibular fracture or complete interosseous gone. So AITFL gone, PITFL gone, deltoid gone, proximal fibula may or may not be there, but then that time 2-hole or 3-hole plate and at least 2 screws, they are most.
Yeah, so in my first case, I applied a 2-hole because that was a proximal fibular fracture and the massive day. But if you are sure that your fibula is not broken proximally, and if your instability is limited only ankle, there are only few cases like that.
So in that 2 screws which are you're keeping, one should go through the that is syndesmosis, and second goes proximally?
No, same, at same levels.
Same level.
here, I mean semi-annulus is down only. I mean no this thing up here.
That means one screw at the syndesmotic level,
At-
it is here,
yeah.
and one screw here, because there is whole intersection is gone.
Yeah, but do not span it, sir.
Don't span.
Do not span it. Oh, hardly 2-hole plate at these two, this thing is fine. I mean 4-hole plate with one screw left, this thing, and 2 screws is good enough.
Yeah.
Is good enough. And
Yeah.
again,
Yeah, plate with 2 screws of a span of 3 to 4 centimeters is usually enough for the masonry injury, sir. Yeah.
Can I take one more minutes?
Yeah, please, sir, please.
Yeah.
So, one more question. The question is that what will be the weight bearing protocol with the screw inside, syndesmotic screw inside? Whether you will start it immediately or you will start after some time?
I mean, only screw or malleolus with the screw?
Yeah, malleolus with the screw.
It's a fracture protocol, 6 weeks non-weight bearing and the same.
Okay.
If you are with the pure ligamentous injury only, then again you have to give us 6 weeks for at least for the consolidation of those ligaments. So fracture protocol.
And what about the posterior malleolus? Whether you fix every posterior malleolus or because the previous concept was that 25%?
I'm going to talk on it.
Yeah, I mean,
My
Sampath
next
sir will definitely talk on it, yeah.
And about reconsidering his point of the screw removal, the paper which he talked about is an American Army paper, and his author was with me in fellowship. So it was an interesting paper where they did post-op CT scan of all their fixation. They found mal reduction to the tune of more than 54%. More than 54% was mal reduced because CT scan will show you accurately. So, and what was the next pose of that paper was, when it was mal reduced, they tried to remove that screw within 3 months. And to their surprise, relocation was possible in more than 80% of patients. So just to give you some hint about removal of screw, if you have inserted a screw and if you have done the CT scan, or if you have not done CT scan but patient is unhappy because of dorsiflexion or pain or you suspect malreduction, then if you remove it before 3 months, then probably chances of relocation, I won't say that every time it will, but chances of relocation are high. And as he correctly mentioned, if you want to keep it, at least keep for 4 months because that adequate fibrosis should be there, and otherwise let it break, but inform that patient that it may break, and when it breaks it will give you pain for hardly 1 week that time because it is going to readjust, it is going to relocate. So this fibula is going to sit nicely into the lip of the tibia, and what he was advocating is to just open here and see this lip, okay, but by opening, do not open that AITFL, you have to just palpate it, because then if you want to open it, then you are going to damage it more. Same way posteriorly also, I am going to talk in posterior malleolus lecture. Posterior malleolus you will not see with your open eyes because it is already covered with PITFL, posterior inferior tibiofibular ligament. It's a very strong sheet. You are going to see only sometimes apex if it is large. So do not try to see posterior malleolus. If you have seen the posterior malleolus, you have done the damage. Because that intact PITFL you want to be intact with the fibula. Got my point? So what you are going to do is you are going to manipulate the posterior malleolus with K-wire as a joystick. And remember that posterior malleolus is at lower level than the anterior rim. So while reduction, do it like this, but do not see it with your open eyes. If you are seeing with the open eyes, you have already erased the PITFL.
Yeah. Thank you, sir.
I'd like to give key points that before reduction, in syndesmotic reduction, put a fully threaded screw, not a artery, you don't want to compress it. Second thing, do a hyperdorsiflexion. That is the anterior rod part of the talus should go into the ankle mortise. That will definitely help with reduction of this.
Yeah, it should be a positional screw and not a compression screw.
So, few of the times, the anterior inferior tibiofibular ligament is torn. So you can go through that and visualize the joint and then fix the thing. Otherwise, without opening the AITFL, is it possible to correctly see whether it was properly reduced?
You don't have to see, sir. Now this is fibula. This is, I will show you video. I will show you how to assess syndesmosis through a video.
I think he's talking about is there's sometimes a waxed up fragment, it gets avulsed.
Open door, you can do the open door and go through that.
That's okay.
What he is telling is correct. Most of the times when they are hello, most of the times whenever it is isolated ligamentous injury of the syndesmosis, it is an external rotation injury. And anterior tibiofibular ligament is torn, and that is the time when you open it anteriorly, see it nice reduction. How many times we have seen isolated posterior inferior tibiofibular ligament injury?
Posterior inferior tibiofibular is most strong. It is seen in footballers.
I think his point is more valid in isolated
Yeah,
ligament.
that's what I'm saying. Even Korean literature supports open reduction and internal fixation with the suture anchor of that anterior inferior also. But that is true in footballers where there is a isolated injury. It is fine. But to assess reduction, don't open it. What I mean to say, if this fibula is sitting nicely, your artery forceps, I am going to show in a video, your artery forceps is just going to palpate whether it is sitting nicely. If I am up, artery forceps is going to go up. If it is, I am going posteriorly, it is going to dip down. So it is easy to palpate rather than open and see, because you are already doing a damage by opening it. So don't open the ligament, but see that fibula is sitting nicely into the notch. Okay, so it is easy to palpate this. See, it is easy to palpate.
So you never do open reduction.
Open, but take an incision. Do not see this. This is suppose AITFL. Don't cut it to see the notch actually. Just feel it.
Only if there is avulsion fracture.
Only avulsion fractures, they do repair it.
You can actually see that fragment on the lateral view. You can actually see it.
But if it is unstable, because 60% of stability is given by PITFL. So even if AITFL is gone, still you can conserve and go conservatively.
Thank you, sir.
Okay, now we'll move ahead. Now we have a talk about posterior malleolus by Dr. Sampat Dumre Patil.
Yeah, I will.
We will have 3 talks back to back and then we'll go for discussion.
Can I get my presentation? Yeah, I will be just brief in the posterior malleolus. Now, posterior malleolus, what it contributes? It contributes to the articular congruity of ankle joint. It contributes to the articular congruity of this tibial notch for fibula. Understand this. It contributes to the congruity of ankle joint, that is tibiotalar, but it contributes to the congruity of the tibiofibular joint, that is also important, and of course the stability of the posterior inferior tibiofibular joint ligament. So this ligament is also important, but congruity is also important. Various classifications anatomically they are important to know for some practical points. Haraguchi, Mason's and third classification, where they are talking about the lip or involving complete rim or only the posteromedial part. These are the few classifications. Haraguchi classification talks about if it is involving only posterolateral complete rim or involving the medial side. Ramel classification, again same thing. Here we should keep it in mind that anatomically we should know which part are to be reconstructed of the posterior malleolus. It is not only posterior malleolus that needs to be fixed. I will go into the detail of fixation. See this Mason's classification. Now this is easy. This is a rim, posterolateral part and medial part. Now when it involves the medial part, how the forces are transmitted, mainly external rotation. First the posterolateral part, which almost is gone, and then even the medial part is gone. Why we should remember this? Because unless you reduce this first, posteromedial first, you cannot make this posterolateral to sit back. Okay, And one typical association with this, usually type 1 is avulsion of medial malleolus like that. Type 2B or A or B and this thing is mainly oblique fracture like that. But type 3, you can imagine almost same obliquity of fibula is there in obliquity of posterior malleolus. It is a big chunk, but even this obliquity of fibula and obliquity of big posterior malleolus, it coincides almost like each other. So just keep that in mind. This will help you. And what I was saying, if you open this posterior malleolus, you have done the damage. But if I am able to see this apex for reduction, then it is fine. Got my point? Because then posterior inferior tibiofibular ligament attached here. So don't try to see this posterior malleolus. But if you see this apex for reduction purpose, it is fine. Now, how do we evaluate? CT scan, yes, it is going to give you good this thing. This is the posterolateral part, fixed, big chunk fixed with these screws, and it is fine, that is good. But how to suspect on X-ray? Do this X-ray, lateral X-ray in 45 degree of external rotation. So this is my X-ray plate and the source is from other side. External rotation, 50 degree view. What it is going to help you? It is going to take fibula away and it is going to show you the posterior malleolus. To suspect that, at least do AP lateral and oblique views, isn't it? If your patient is not affording for CT scan, at least do this X-ray view, external rotation, 50 degree lateral. Got it? Indication. Why, somebody was asking, why we should fix the posterior malleolus? One, for the sake of ankle joint congruity. Two, for the sake of ankle stability, because then it is going to be a posterior down part which is going to give an hindrance to the posterior dislocation. Syndesmosis stability because of PITFL and reconstruction of fibular notch. Probably we do not give importance to this because that tibial lip should be recreated where fibula should sit in. Got my point? So that recreation of tibial notch for fibula also should be kept in mind. Now, over the time what we were doing, we were fixing it indirectly with syndesmotic screw. What literature says, can I do that? This is a recent paper by Vinod Panchbhavi sir, 223. And in that he has quoted, Gardner has studied this. Oh, that was a cadaveric study. In cadavers, only malleolar screw was, syndesmotic screw was put. Stability was regained to only 40%. But only posterior malleolus was fixed. Stability regained was 70%. It gives you an insight. This is an honest study, cadaveric study, where only syndesmotic screw stability can be only 40%, while posterior malleolus fixation alone 70%. Some more studies. Miller et al. He says only posterior malleolus fixation stability to the tune of 97.9, almost there. Again, same this thing, that if you fix only posterior malleolus till 1 year, every parameter remains same. So, posterior malleolar fixation should be done, and irrespective of size which we were taught about should be done. Now, this was fracture dislocation. Posterior malleolus is there, and see, we have fixed with anterior to posterior screw. So, what is the verdict? Anterior to posterior or posterior to anterior? You can do both, but logically or biomechanically posterior to anterior is better, because to miss it anterior to posterior is quite easy. You see this now, this is some different trajectory. Here it required from here to there, from anterolateral to posteromedial, and posteromedially to direct it I needed to go this much posteromedially. But if I am proud posterior medially, I am going to irritate tibialis posterior tendon, which is going to slide in the groove of the tibialis posterior tendon. Got my point? And tibialis posterior tendon is the only tendon in the body which has a least excursion. If it loses excursion, it is gone. Got it? So anterior to posterior possible, but Why? When you want to put it percutaneous. If soft tissues are compromised, then you can put it, but not an ideal way to do it. Posterior to anterior is better way. Another case where posterior malleolus was there, posterolateral approach, and then again under contour plate. Then posterior anterior screw is better or plate is better. Verdict is same, that depend on your fracture geometry. Either plate or screw, both work well. If it is a large fragment, maybe screw. If it is a comminuted fragment, maybe plate. But biomechanical it is same. Approach you know, posterolateral approach, this is FHL, between peroneal and FHL, that is the approach. And this was a plate, posterolateral plate. Just remember that this plate should be under contoured plate. If it is anatomical plate, I will straighten it out and then put it apex screw, then it will drive that piece towards the anterior colliculus. Got it? In true AP view, see that this does not extend much medially. Got it? In true AP view. It is difficult when you are doing it in lateral position. In true AP view, see that it does not cross much on medial side. I will show you why. Now, posterior malleolus, this is called as shoulder sign. If this is a line beyond medial malleolus, this is called as a shoulder sign, which indicates posteromedial fragment. Usually posterior malleolus is a posterolateral fragment. But if this is there, you have to keep it in mind that there is associated posteromedial fragment. And why we talked about that? Because along with the posterolateral fixation, we need to fix the posteromedial. And tricky thing is, if you want to fix posteromedial, probably keep Herbert screw handy. Otherwise, it is going to irritate your posterior tibialis posterior tendon. Got it? So whenever on even plain X-ray, if you have spur sign, this is called as spur sign. If this is a spur beyond the medial shoulder, then that indicates posteromedial fragment. What I have done here is fixed it with the screw, and we should remember that if this is a posteromedial and posterolateral fragment, fix up first posteromedial, then only this can sit and create a good fibular notch of the tibia. So this is a separate this thing. This was very old case where I have put a head screw, but screw with the head, but it is going to irritate. This is outside the plate. This is going to irritate the tibialis posterior tendon. Now look at this case. My plate, what I was talking about, this is a synthesis plate, which is anatomic plate for this thing. I was little bit more proud on medial side. This patient started getting numbness and burning on the posterior tibial nerve area, and see this was tibial nerve, and my plate edge was irritating the tibialis posterior tibial nerve. I had to take it out. So if you see this, probably I am too much on medial side. Okay, so try to avoid going too much medial. If you are going there, then it should be under contour plate, very flush to this thing. Anatomical plate, little thick plate is going to irritate. So be careful in this. So to summarize, posterior malleolar fixation should be done for the sake of ankle congruity, for the sake of congruity of tibiofibular notch, and for the sake of stability of syndesmosis. Thank you.
Thank you, sir. Now I welcome Dr. Rahul Upadhyay to give his talk on deltoid injuries. What is the verdict of today?
By the time he loads his slides. One question I will ask.
Yes.
Do you find it easy to do in lateral position, or posterior will be more easy?
Prone position is easy, but issue is it is not isolated posterior malleolus. So rather, I will give you evidence that isolated posterior malleolus can be conserved, but it is very rare to get isolated posterior malleolus.
Those commonest injuries are external rotation injuries,
yes,
where you get a spinal fracture of fibula with the posterior malleolus.
Yeah.
So posterior plating of the fibula as well as posterior plating of the tibia, is it more easy in prone?
It is easy, but if I want to check all around, I will give you a position where it is a floppy lateral position. When you can externally rotate, go on medial side, you can little bit internal rotate, go on posterior side. So probably it is going to give us more flexibility to work all around. And usually the plate for fibula I always apply on posterolateral border because it nicely contours and take it towards the anteromedial.
Up to how much medial would you be able to go through a posterolateral approach? So if you have a big posteromedial fragment, then would you change your approach?
You can reach, you can put a homons, but you cannot fix it. For fixation, go from medial approach and come towards the posteromedial border, but you can reach, but you may not be able to fix.
What is the role of ligamentoid axis? The role of ligamentoid axis?
Yeah, in posterior malleolus.
Posterior malleolus.
It is there when it is a shell of bone, and this is called as pilon variant. It is there in women, osteoporotic women, when there is a pilon variant. It is a posterior, but it is a rim. That time you can indirectly fix it because you really don't want that to go this thing, and that time only you reduce it, fix it with the syndesmosis, and like ligamentoid axis indirectly you this thing, because it is osteoporotic, it is like a rim.
Many times you find that after ligamentoid axis everything falls in place.
Falls in place, but stability has to be there.
Yeah, Mahendra sir, sir, your question, how medial we can go from the posterolateral approach, I just want to add few things. Sampath sir has perfectly said that you can reach to the medial bed, you cannot plate it. The problem is the apex of the posteromedial fragment is at the posterior malleolus, is at the tibialis posterior tendon. So unless you move the tibialis posterior tendon, you will not able to see the apex of the fracture. So either medial or posteromedial, but posteromedial, which is classically described, is too much posteromedial. So when I was with Anish Kadakia, so Anish has said, he has done a very beautiful job, not posteromedial, not medial. You just apply an incision on a on the posteromedial border of this fragment, or directly on the tibialis posterior. Just separate the tibialis posterior from the groove, you will find apex, apply a small buttress plate and come out.
So that's what the point I was trying to make is that you can't fix a posteromedial fragment through a posterolateral. That's the reason I asked this question, was to address that issue.
Sambaram, we will take question after this lecture. Huh? Yeah.
Right. Thank you, sir. So after these two illustrative lectures, so we'll be talking about probably the final support of the syndesmosis, which is the deltoid, and probably one of the most neglected part of the entire ankle ligament complex. So we are today talking about only the acute deltoid injury, which are mostly associated with the acute fractures or the rotational ankle fractures. And in today's lecture, we are trying to find out about the anatomy of this deltoid, about the injury, about the literature, what does the literature says, that how the treatment has been, how the treatment is, and how the treatment should be. And finally, can we conclude about what is the current verdict of the deltoid ligament repair in the acute setup? Now, talking about the anatomy, so the deltoid is a very thick ligament which is medially. The entire structure of this ligament itself says that it is a very important structure. Now, you don't have a ligament which has nearly 6 bends, which has a thick 6 bands, and it is torn and you don't repair it. So again, the main important 3 bands are the tibio-navicular ligament, the tibio-spring ligament, and the deep posterior tibio-talar ligament. These are the 3 important and static bands of the deltoid, which are always present. And these are covered with the superficial part of the deltoid ligament. So then these 6 bands together make the medial stability of the ankle joint. Now the stability of the ankle joint is important because we have to treat ankle, and we have seen by the previous 2 speakers that there was always some amount of instability even after the best syndesmosis, even after the best posterior malleolus. And what was giving that amount of instability? So is deltoid the culprit there, and then that we have not addressed the deltoid, which is giving that residual amount of instability? Let's see what the article, what the literature has to say about it. So what is an ankle stability basically? So the ability to maintain the talus centralized under the tibia when it is held in a neutral position and it is undergoing the physiological stress, that is the weight bearing. So under the physiological stress, your ankle has to be centralized. That is a stable ankle. And a stable ankle has varied responses to the trauma, and the presentation of the injury guides us as to what kind of injury it is, what kind of fixation it needs. And some injuries, they don't need any words. You can't miss this. And you just can't expect that this deltoid is going to heal by itself. It's because this amount of translation means the entire deltoid complex is gone. So can it heal by itself? The traditional teaching has been leave this deltoid alone. But we have seen that most of the pronation injuries are always associated with the medial structures, and this deltoid is very unlikely to heal by itself. But let's talk about the supination external rotation injuries. What about this? Traditional teaching says that anatomical reduction is sufficient. It will give you stability. And fibula and syndesmosis can do a job beautifully. But can they? So this is the same patient, the same X-ray. The fibula was fixed. Again, on the stress view, there was a medial clear space. So what was the culprit? Is syndesmosis? Do we need the syndesmosis fixation here? And that is going to give us the better stability? Not always. Even after the syndesmotic fixation, there is talar tilt. And finally, when you fix the deltoid, you get a stable centralized ankle. So deltoid definitely is very, very important. So can we call it as an ignored ligament complex? Because it is under-recognized in mostly acute sprains, associated with syndesmotic injuries. It is associated with almost all fractures. So we have not seen what happens in the long term. Maybe in the short term we see that, okay, the ankle is stable, but what happens to the patients in long term? What are the complications there? So it is important to see. So we go back to the literature and see what happens in the long term. And we have seen that 40% of ankle fractures are associated with deltoid injuries, whether partial or complete ruptures. And even 3 to 4% have isolated deltoid injuries. They are always associated with syndesmotic injuries. They lead to OCDs, they lead to the malleolar fractures, they lead to the flat foot. So this is the ring that we have been talking about the whole day in this session. This is the ring of syndesmosis. So if you see, now this ring is only complete when you have AITFL, PITFL, interosseous membrane and the deltoid. So you cannot miss the deltoid a part of this ring, because if deltoid is not there, it's not a ring. So make sure that we give adequate value to this ligament. Evaluate this deltoid. Even after your fixation, look for the talar tilt. A valgus talar tilt, even after the fixation. Now if you see, it is a robust fixation on the right side with a screw, a syndesmotic screw with 2 tight ropes, as we have been discussing before, and still it is unstable. So deltoid has a major role to play. Now this is a very important test to identify whether your medial clear space is significant or not. So you draw this line straight from the lateral border of the fibula, and you give a talar tilt, and if your calcaneus is touching this line, there is abnormal increase in the medial clear space, and you have to make sure this does not happen. So this is an indirect way to assess the instability of the ankle joint. Do a thorough MRI evaluation whenever you are in doubt. So if you see a deltoid complex, and on the right side you see the complete rupture of superficial and the deep deltoid complex. Even if you have still doubt, do an arthroscopic evaluation of the deltoid, and you could see a complete deltoid tear. So what does the literature say about this? We have come a long way. So from 1965, when Solon et al. Said that only anatomical fixation is needed, 1995, again, Stromso said that deltoid repair is not needed. But in 2015 came a meta-analysis, a wonderful paper that talked about the deltoid repair in the NFL players and their return to sports. And they had nearly 90% return to sports with a pre-injury level. And again, 2023 meta-analysis talked about the need for the deltoid repair in the current scenario. So has it become the them and us situation, whether someone is in the favor of bony anatomy restoration and some in the favor of deltoid ligament restoration? So I think we have to come to a consensus where we understand that both of them are together important. So this was a paper of Stromso who talked about analysis of about 50 patients, and they said that no difference was recorded, but that was in early 1995. And there were a lot of criteria that was not considered in those patients. So again, one more study was done, and they said that it did not affect the medial clear space. The fixation of the deltoid did not affect the medial clear space. But did we actually read all the criteria? What was the status of this patient? What was the functional need, demand of these patients? Were they sports individuals? Were they young? Were they old? None of these criteria was studied in this. So then came this editorial article from our home, from the PGI, and they talked about various studies. I think the slide's gone. And they said that with the new advent, with the new meta-analysis, deltoid is becoming all the more important structure to fix. And this Chinese meta-analysis confirmed that. They said that there is a statistical difference in long-term medial clear space. The ligament repair could reduce it, and it could reduce the complications, and it led to a better prognosis. So that does the addition of deltoid ligament, is it now necessary? So this from the Vinod Panchbhavi et al., and it does not provide, maybe today, with the many evidences that it has to be fixed, but it has to be taken into consideration by the operating surgeons, because the cited studies, they lack lot of data which may be showing the bias. So again, Jasidoti and Panchbhavi came up with this article, and they said that again the commonly cited data is not in favor because it warrants a very, very careful consideration. So then came this very, very beautiful article in Journal of Orthopedics, and that they talked about after the deltoid repair, the talar coronal and axial rotation, they were normalized to the uninjured state when they compared with the normal ORIF alone. The medial clear space was much more superiorly and statistically superior to the deltoid repair group. The functional score of AFS score was again statistically significantly improved in a deltoid repair group. The pain score, it did not show much difference, but the overall complication rate again statistically improved in the deltoid repair group. And one very important thing, this paper talked about occurrence of delayed flat foot in all those patients which were repaired anatomically and deltoid repair was not done. So deltoid repair not done led to a delayed onset flat foot deformity in all these patients.
Sir, please try to.
Yeah. So as you said, we are coming into the conclusion. So deltoid repair is right now leading the race, and we have to make sure that we give a stable ankle, a painless ankle, avoid complications, and return to sports. There are many studies right now going around the world, and they have come up to this conclusion. Said you have to get a medial clear space which is wide, talus reduction isn't acceptable, increase medial clear space and talar tail even after the fibula and syndesmotic fixation, a high energy injury, and injury in the athletes, they all warrant a dedicated deltoid fixation. So beautiful x-rays can be deceiving, so you have to unmask by the stresses, by the evaluation, and fix the deltoid for a final outcome. Thank you.
Vache sir, we are lagging behind by around half an hour. Already we have discussed in first 2-3 lectures many questions we have taken. So by the time next speaker loads his slides, we will take 1 or 2 questions and
yeah.
Okay, so we'll
I welcome Dr. Kishore Dudak to present unstable lateral malleolus fracture, a case presentation.
please next speaker Dr. Satish Kumar, be ready with you on the front seat. All of you see your names, Satish Kumar followed by Senthil Kumar followed by Shirish Tumbal and Venugopal Samaram. I request them to keep in time so that we will finish in time. All speakers. Okay.
So, good morning, and I am very thankful to Solapur Orthopedic Association and Dr. Gurunath Vache sir. So, after listening previous talk on ankle fractures like posterior malleolus and deltoid injury, the case, I think this is talus case. You have to show me the unstable. So, most common fracture of the ankle injury, that's lateral malleolus fracture, and sometimes we get confused whether to be cast or to operate. So, like such a situation where we get such X-ray from the relatives only on WhatsApp. So, in today's social media group, the people abuse us on WhatsApp. They get free consultation on X-ray. Whether
I need a cast or surgery or leave it as a. So they send only 2 views. Usually they take X-ray from elsewhere and we just see the X-ray and we advise the castable. Is it right or not? So after listening from the previous 2 talks, our fundamentals are clear. But we have the habit as being an orthopedic surgeon, we take the AP lateral and oblique view. But Girish sir has nicely shown this external rotation view. The 50-degree external rotation may show the posterior malleolus slightly. So, but when there is isolated lateral malleolus, we have to see the medial clear space. But what we see is the raised position X-ray. Patient is lying on the X-ray table, not weight-bearing X-ray. So sometimes we miss that medial clear space. But looking at the clinical pictures, we should see the ecchymosis or bruise on the medial side. That is a telltale sign of the something happened on the medial side, along with the lateral malleolus. So always check if there is a pain, tenderness and bruise on the medial side. Always check gravity assisted view to confirm if there is any increased clear space along with the lateral malleolus fracture. So this is the method how I learned from these various conferences in foot and ankle. So please do attend every talk on foot and ankle. You will get beautiful tips and tricks from our stalwarts or leading practitioner in foot and ankle. Talar tilt and medial clear space. Sometimes external rotation view, that also gives idea. So there are different methods to check the instability of the lateral malleolus. Why it is unstable, that I will show you. So such kind of oblique fracture, small oblique or large oblique fracture at the level of syndesmosis, very difficult to judge clinically, but you can give stress view under hematoma block. You can inject lignocaine and do external rotation or weight bearing X-ray and you will find there is increase in the medial clear space. So after seeing the previous slides where we have seen the attachment of the PITFL, AITFL, very beautifully shown by Sampath sir. We have cleared it in our mind where is the attachment of the AITFL and PITFL. So you can judge whether the syndesmosis is intact or not. But we have some dilemma about the deltoid. For that the clinical judgment is very important. And sometimes there is hidden lines for the posterior malleolus may be there. So when is the simple fracture of lateral malleolus is unstable? Very beautiful paper. An article is published in 2017 and there are some criteria whether we should focus more on the clear space or not. So they have shown more than 4 mm. That's the classic documentation. More than 4 mm of clear space on medial side is the indication for the deltoid. Okay. Again, that's the case which has plastered somewhere else. Patient comes to me with pain along with plaster. He was walking on plaster. So I advised him to remove the plaster and I want to take the gravity assisted view. He denied for the same and I have done the gravity view with class on demand of the patient. Ideally it should be removed. But with cast you can see there is an increase in the clear space. So that's an unstable picture. Even after explanation, you need stability. Patient was not ready, so I have to leave the patient. And I will not go in deep details of this classification. Previous talks were there on classifications. So various papers support that operative versus non-operative results of the unstable malleolar fracture. And there is a multi-center trial in March 2012. The risk of displacement and problems with union were substantially lower in patient managed with surgery. So there should be high threshold of surgery for unstable lateral malleolus. Like this, there is a medial clear space and that can be best managed with the buttressing plate. The apex should be addressed first and simple buttress 130 bular plate on posterolateral border will be sufficient. That's the case. Simple sorted out, but sometimes a direct posterior plate gives a better stability, and there is a study between comparison of the lateral plate and posterior plate of the lateral malleolus. The direct posterior plate gives more stability compared to the lateral because it pushes the apex more toward the medial. All the deforming force become neutral. So, and impingement of the screw on the syndesmotic side can be avoided if you are putting a plate on the posterior side. So, posterior to anterior screw are more safer. Here in this case, even after putting the plate, there was no stability at the syndesmotic level. So, surgeon has inserted one screw. But sometimes, even after putting syndesmotic screw, such kind of medial clear space will be there. Means there is some problem on the medial side. That time we should go and check on medial side, check the injury on the deltoid part, and if possible, try to repair it with the help of anchor. See, in this case, 2 syndesmotic screws were used at the level of syndesmosis. Even after that base fixation, can I have 1 more minute? There is a medial clear space. That means deltoid is injured there, and that needs a deltoid fixation. So, that's the case. You can fix it with the 2 anchor. Just with the 1 anchor, you can fix only the superficial deltoid, but you need to fix both the deep and superficial. That's the last case. Sometimes we see the tip of lateral malleolus is fractured and we conserve with the cast. This case was conserved with the cast. Patient was walking on the cast, and that's the CFL avulsion treated conservatively, and patient having a chronic pain and instability, and that was again assessed with the MRI, and that was repaired at 5 months using bone graft and anchor on the medial side for deltoid, and LCP for the distal radius has been converted to hook plate manually on intra-op by cutting the distal hole of the plate and made it a hook plate and fixed on both the sides. So putting just, sir? Yes, last case, thank you.
Thank you, sir. We will discuss at the end.
Yes.
I welcome Dr. Satish Kumar to present distal tibia posterior plating, innovative Indian design.
Good morning, everybody. And first, I would like to thank the organizers and Gurunath sir for giving this opportunity. Greetings from Madras Orthopedic Society and Tamil Nadu Orthopedic Society. Since this is a part of the case-based discussion, I'll just begin with some cases. This is my first case, 20-year-old male with such fracture. My second case, 59-year-old gentleman. This is fracture pattern. And this is a third one, a 63-year-old gentleman. So what are the options we have in hand? All these cases had something in common. They had wound on the anteromedial aspect. So what is the option left? So this is the zone which we are talking about. Here where the soft tissue component is more well pronounced rather than the fracture itself. So we have multiple options. We have nails, we have plates, you can go with external fixator. My talk is restricted to the plating system. So the plating system which is available currently is the anterolateral plate and the medial plating system. And in both the approaches, you can see that the wound complications aren't uncommon. So how we can overcome this? We need to take advantage of the posterior flat surface of the tibia, which is highly vascular and also gives good coverage of the implant. And this article clearly states that how the FHL acts as a buffer and gives good coverage to the implant. There has been multiple studies in the past where the contralateral anterolateral plate has been used through the posterolateral approach, and also some angle blade plates for non-union has been attempted. Even from our own institute, they have actually bent the DCP and used for fixation through the posterolateral approach. Why this approach, even though it has been there in vogue for more than 100 years, it is not that much very popular because of the lack of fear of injury to the neurovascular structure and lack of the anatomical plate in Indian scenario. So this article also clearly states that there was no anatomical plate. This was somewhere around 2016-17. So why do we need these plates? Because we need plates to match the anatomy of the Indian population, because all the plates where Sir was telling were, most of them are imported plates and they are not cost effective. So right now we are using the distal radius system, which is a 3.5 system. The problem is the strength and the length. We also use the proximal tibia plating system, which is a 4.5 system, but this plate is very thick and it irritates the muscle. So what do we need? We need a system which is a combination of both the 3.5 and the 4.5 system, which gives the strength of the 4.5 system as well as the agility of the 3.5 system. So this is a very, very good article which throws light on how to go about with plate designing. So this was the article which actually helped us to go about with this plate designing. We took two parameters of the general population. One was the posterior tibial slope and the next one was the mediolateral width. So we calculated that in 50 male and 50 females and 50 on the right side and 50 on the left side using CT. And we were also able to calculate the twisting length, which was helpful to design the length of the plate. And with this, we fed this into a software which was developed by the National Hub for Healthcare, which is in Chennai. And this software gives us the precise model which we want, how we want to design the plate. And when this model is being fed into this flash fogger finder, we get something like this in PLA. This is a first generation plate on the left side and the right side is the second generation plate which we have designed. And when this is handed over to the company, we get it in a SS output in stainless steel, which is a combination of 3.5 system for the distal row and 5.5 system with oblong holes for the proximal end. And then we also did the radiological superimposition technique to see whether this plate is exactly fitting our population anatomical bone. So we can see the distal radius plate is very small, the proximal tibia plate is very large, and our plate just fitting the anatomy of the bone, the contour of the bone. You can see the radiological comparison, and this is the dry bone model superimposition comparison. And we have used close to more than 100, and we were able to see that the results were comparable with any other plating system which is commonly used in practice. So these are some of our case which I showed, the first, second and third cases. You can see the results are incompatible with any other plating system available. Now comes the next interesting part, how to evaluate the outcome. As far as now, the outcome is being evaluated on the radiological union and the functional outcome, which is the movements. But there is an alternative which is evolving. Here, the gait analysis lab, which has been developed by the same NHHD, which is there in Chennai. So there you have these wireless systems which are just strapped down to the patients. And this is the protocol. We just make the patient to walk for 10 meters up and down, climb stairs, that's all. This is the actual data collection which was done in our center. There you can see the patient being strapped with the wireless system and he is walking. On the other side, you can see the patient walking, trying to walk up and down the stairs. 20 parameters are clearly recorded with just one simple act. All these parameters are captured, and the result is also it comes like a graph. You can clearly see the right side, there is overlap of the graph, which means it is normal. On the left side, you can see the graph is not overlapping, that means there is abnormality. And this is also it also brings everything, hip, knee, ankle movements, everything. So we can clearly say that where there is an abnormality or it is close to normality. And then the next level is the strength testing. We want to test the strength of our plate. So again, there is a new software. Here you can see the patient jumping and standing with single stance. So when the pressure is maximum, whether our plate is able to withstand the trend. This is called as an anybody modeling software, which was developed by DRDO, and we did the strength testing using this software. And we also applied for intellectual property rights. And then we came out with the second generation plates where there are 2 rows in the distal end and oblong holes in the proximal end. And now we have come out with just last slide, sir. We have come out with the third generation plate, whereas for any patient, you take the recording of this posterior slope and medial lateral length, you feed in the machine, you will get a custom made plate. So we have created that software where you feed the patient parameter, it will give the output. So these are the advantages where we have used all latest technology in inbuilting the plate, and this is the first plate to be designed by an institution for the distal tibia with the help of all latest technologies. Thank you for your patient listening.
For the knowledge of the speakers, we will ring first bell at the end of 6 minutes so that they will get 1 minute to conclude, and second bell will be at the end of 7 minutes so that it will not delay the proceedings.
Yeah. Thanks.
Thank you, Dr. Satish Kumar. It was a fabulous paper. Now I invite Dr. Senthil Kumar for medial malleolus vertical fracture.
Good morning, and I thank the organizers for giving the opportunity. Since it was given as a case-based discussion, so we can go to the case. A 34-year-old male with the supination adduction injury. So mine is more of a vertical malleolus, medial malleolus cases. So this is a classification, and these are the methods of fixation. So let us go to the case. So the patient presented to the emergency with this type of an X-ray. So what you will do, sir? What will be your management options?
So I think, and definitely this is the intra-articular fracture. You can't treat it conservatively, right?
Yes,
so,
sir.
And you have to look at the fracture lines. The line on the medial side is vertical. So you have to fix it as a buttress mode and maybe a additional screw. And the fibula is type Weber type B. So that also needs to be stabilized.
So your implants of choice for the fibula and...
There's a small fragment there
Yes.
of a T-lox anteriorly.
Yes.
So, I mean, you can either put in two screws perpendicular to the thing, or you can put a buttress plate and add an additional screw through the plate on the medial side. And the fibula you can fix with a pre-contoured fibular locking plate.
Okay, sir. Any approaches? How do you...
I mean, you can use a lateral approach for the fibula and a medial approach for the medial malleolus.
So any other construct, or everyone is comfortable with the plate and buttress plate, or any other constructs?
Do you have a scan?
Yes, sir.
Okay. Just a K-wire? No, I mean, I wouldn't do that. Well, see, the scan here now gives much more information. That shows that there is an impaction fracture onto the plafond. Now, the whole idea is that it's not just intra-articular, it's an impaction fracture which has to be depunched. It's just like a die punch fracture in the wrist. So that CT scan here is a very important investigation. So now the plan really changes up. You just need to open it out, get the fragments out, and then reduce it.
So generally most of these vertical malleolus, they have a impaction type of fracture. So the importance of CT scan is very much important, this type of fractures. Sir, for a fibula, generally whether you go for any intramedullary screw can be also, it's an option.
Yeah, it's an option. You can put in a long screw which can engage into as it is a transverse fracture, yes.
Okay. So this was actually done. So lateral side plating and with medial side buttress plating along with this. So actually we should have also gone anteriorly and decompressed it, but that was not done because it was much before. And one more thing I wanted to ask, sir, only this buttress plate is enough, or you want only a buttress mode of plate is enough, or you try to pass screws even in the distal part of the plate, because it's a plate is only a buttress type of plate.
See, you see the fracture orientation, you need to compress that fracture. So your medial screw has done that, and on the medial side you have buttress. So you have taken care of both the forces using that sort of an implant.
So if you have not used a single screw and we could have put a transfer screw over this setup.
No, that would not take care of the, see the fracture is at 90 degrees,
Yes,
so you
sir.
need to compress that. Just putting a buttress that, it's not going to help.
So anything else you would have added, sir, to the fixation?
So there's another thing that if you get the plate right down to the medial malleolus, you could use it like a hook and then
Yes.
put in a screw, so that takes care of the compression through the plate. But then the other thing I would like to do is probably engage on the other cortex to actually compress that fracture. So the vertical screw.
Yes, sir.
If it has gone, I don't know, you can't make out whether it has
No,
gone
it
to the
does
other
not
cortex.
engage the
Yeah,
opposite
so
cortex.
if you compress that, then it will achieve more compression there. So that's another thing.
So this is a post-op X-ray, and so this is an article and which shows that buttress plating is more superior than a single type of screw. So this is another case. So pre-operative, I don't pictures are not there. So in this case, what was done with the fibula? They were not. Fibula was a very small fragment. So initially they tried fixing of the fibula through the 1/3 tubular plate, and there was a lot of comminution, and they couldn't fix, so it was left conservatively. And we used a 1/3 tubular plate for fixation of the medial malleolus. So is this construct stable enough, or any additional more?
See, if there is a comminution at the apex, it will still allow the fragment to go up. If it's a very good cortical contact, then you may get away. But since there is a comminution at that corner where you have not put in the screw, this fragment is going to get displaced, pushing the talus upwards.
This side. So in this type, only the plates alone will not. We have to.
It won't.
That's all, sir. Thank you, sir.
Sir, you said, what about the distal screw of the plate? Of course, the plate is applied for the buttress, but because of the medial impaction, that medial osteochondral fragment, it also needs some fixation, which is not possible with the buttress plate only.
Yes, sir.
So in your CT scan, if you can see your CT scan, yeah, can you go to your CT? Okay. Huh?
That scan was a different patient.
No, that was
the first patient I'm talking.
patient
Yeah,
you
first
were
patient. So that was having a big medial impaction.
Yes, sir.
So you have to disimpact it. That creates a more subchondral loosening. So one screw through the subchondral area, through the plate, gives, because we don't need compression here. So compression is, yes. So one screw, one locking screw through the subchondral area where the osteochondral fragment was mobilized. That creates a static environment for that fragment to
Yes, sir.
heal in that
So
position.
in this case, that was the thing which was missed. So that should have been done, sir.
Yes.
Thank you, sir.
Thank you. Now I call upon Dr. Shirish Tumbar for trimalleolar fracture case presentation.
Good morning, everyone. Today, I'm going to present a case on fragment-specific fixation by plating of trimalleolar fracture. He was a 72-year-old male patient with past medical history of congestive heart failure, diabetic, hypertensive. After landing on left ankle, he had severe sharp pain that was non-radiating, worsened by movement and weight bearing. He was referred from a peripheral health center, non-alcoholic, non-smoker. The radiographs of ankle were taken and a below knee slab was applied, and he was sent to our institute. So these are the pre-operative radiographs where we can see the fibular fracture can be seen, the medial malleolar fracture is seen, and on lateral view it is difficult to appreciate the posterior malleolar fracture. So we decided to go for a better geometry, that is went for a 3D CT scan. So according to classification as we have discussed, this is a AO type 44B3. So after doing a 3D CT scan, the true fragment size and geometry is assessed. Displacement of the fragment can be seen. There is a posterolateral fragment at the tibial plafond along with the oblique fracture of fibula and the middle malleus is seen. So on this axial CT we can see a separate posterolateral fragment, and this is the shell of a bone on the posterolateral aspect. So recently, as Sampath sir told, Haraguchi classification, this is a type 1 where it is a posterolateral oblique vase-shaped fragment involving the posterolateral corner of the tibial plafond. So after getting anesthetic and cardiac fitness, he was posted for the fixation. A posterolateral approach was used. I will not go in the details. So the main internervous plane, as we know, it is between the FHL tibial nerve and the peroneal muscles, and accessing the posterior malleus, it is mainly by anterior retraction of peroneal tendons and the interval between FHL and peroneal tendons. Sequence of fixation: fibular plate was fixed first with 3.5 millimeter low profile distal fibular plate, and also the posterolateral fragment, as I had didn't have any other plate available, I fixed it the same distal fibular plate, and then medial malleus fracture was fixed with a malleolar screw. This is the immediate post-op X-ray where we can see the articular congruency is well maintained. Post-op rehabilitation, partial weight bearing was started after 2 months and full weight bearing after 3 months after bony union was confirmed on radiographs. Functional outcome was assessed by foot and ankle measure. Actually, I have lost the 3 months post-op X-ray. This is 1 year follow-up. There is complete bony union is seen and the articular congruency is well maintained at the distal fibular, and the fibula has united, malleolus has united. So this is a clinical photo. Healed operative scar is seen on the posterolateral aspect. This is the video showing the movements at the ankle. Actually, his walking video has been not traced. So take home message is a better outcome of direct posterior in comparison to indirect reduction with comparable complications rate. Anatopical fracture reduction and fixation of posterior malleolar fracture are paramount as they affect syndesmotic reduction. And with this posterolateral approach, we can go for open reduction and internal fixation of both posterior malleus as well as the distal fibular fractures. Some of the references. Thank you.
Thank you, sir. We can have questions.
Yeah, we can ask.
You can ask.
Quite take time.
Sir.
Yes, sir. So one last question. I mean, when you operate a rotational ankle fracture,
yes, sir,
in a diabetic, you have to categorize in 2 categories. I mean, ankle fracture in diabetes is a different scenario,
okay,
where something you need to do some additional work. So you need to divide this patient into 2 categories.
Okay.
One is stable patient, one is unstable patient. So stable like diabetes and rotational ankle fracture, like HbA1c is controlled, 6, no neuropathy, no heart disease, no nephropathy, retinopathy. But ankle fracture in a complicated diabetes, where you have retinopathy, nephropathy, heart disease,
yes.
poor control on the sugar, and insulin dependence, diabetes mellitus. These are the cases. In I think in your case is a heart patient also.
Yeah. Yes, sir.
So in these cases, these are the cases where they are very high prone for the failure on the routine fixation.
Okay.
And I mean, I'm completely satisfied your fixation. Your posterior malleus, your lateral malleolus, you have plated it, which is a strong fixation. But these are the cases where you need to put additional stability by transsyndesmotic screws.
Okay, sir.
So these are the cases which usually fail when you start working on the 6 weeks.
Okay.
So you need to immobilize the patient for at least 3 months.
Yeah, I done same.
Yeah, and so transsyndesmotic overfixation, we called it protibial fixation. In spite of syndesmotic injury, you are applying a syndesmotic screw.
Okay.
So protibial fixation, immobilization for 3 months, tight control on the sugar, and even the bracing for 6 months.
Okay, sir.
This should be the routine protocol.
Yes, sir.
Also, your medial malleus fixation, although you have put a screw, which is completely acceptable, But rather than putting a partly cannulated screw, compression screw, if you fix, if you reduce it with the clamp, and if you apply a fully threaded screw, in diabetes this is far better to improve the rigidity of the fixation.
Yes, sir.
So bicortical fixation with a 3.5 mm screw, you can use even 2 screws instead of a single 4 mm. That just putting that screw in the cancellous bone expecting to compress won't happen. You have to engage it on the other side and use a smaller 3.5. It's as stronger. You can put 2 3.5 mm screws. So that's the point.
Yes, thank you, sir.
Now I invite Dr. Venugopal Sambaram for neglected ankle fracture, a case discussion.
Case 1. Khali, Venu case 1. Good morning, everybody. I have a case. 38 years, hefty male met with twisting injury to the ankle area. These are his preoperative X-rays. Can we have some information from the moderators?
Any stress view?
I have not taken stress view. Agreed, there is a fracture fibula, high oblique fracture fibula, and a small posterior malleus fracture. The medial malleus is an end-on view, we don't know whether it is rotated, so there is doubt. I went ahead, did a CT scan. These are the CT scan pictures. You can note there is inferior tibiofibular disruption as well as small posterior malleus fragment, type 1 Mason's fracture. And this is another sagittal view, a small posterior malleolus fracture. These are 3D CT images, posterior medial view where we can note the posterior malleolus fracture, anterolateral view, oblique fracture of fibula, posterolateral view, and the posterior view. So this is a supination external rotation pattern type 4 injury, AO-OTA type 44C1.3. So what I decided, I went in the OT, decided to fix the fracture fibula with DCP plating with syndesmotic screw fixation. But on reducing the fracture fibula, the medial clear space did not close. Then opened the medial malleolar site, deltoid ligament was torn from the tibial side and entrapped in between the medial malleus and the talus. It was removed and then the fracture fibula reduced and held with interfragmentary K wires. Initially, the inferior tibiofibular syndesmosis was held reduced with a pointed clamp and fixed with a can-can screw. Agreed that the syndesmotic screw should have been fully threaded. Then the medial clear space also reduced and the fibula fixation was done. At the end, deltoid ligament was repaired with intraosseous suture tunnels with Ethipon type 2. These are intraoperative pictures of CM, where the medial clear space and the inferior tibiofibular is opened even after fixing of the temporary reduction with fibula and also the syndesmosis. I could not reduce the medial clear space. This is the picture where I opened on the medial side. The deltoid ligament was torn. This is the orientation. After I removed the deltoid ligament which was caught in between the talus and the medial malleus, here again I changed the screw to a smaller screw. Interfragmentary screw was used for the oblique fracture fibula. This is his immediate postoperative X-ray. This is his 3 months X-ray. This is his CT scan. I think the inferior syndesmosis is well reduced. Sampath sir? Agreed. Okay, and at the just level of the ankle joint, the posterior malleus is a small fragment. I removed the syndesmotic screw at 3 months.
Just go back on the CT scan picture.
CT?
So, though it is well reduced, here is the point.
Screw orientation should have been
exactly. The orientation could have been better. So that's why it has to be at that 25-30 degrees.
Agreed. That's what
and also, it gives you an idea about how shallow that incisura fibula is. Those which are a little deeper, you may get away, but those which are shallow, the tendency to push the fibula anterior.
Agreed. This is a learning point which I took. The screw should be perpendicular to the incisura of the inferior tibiofibular joint.
He has put the screw to the plate and plate is lateral, so it is naturally likely to go like that.
There is.
That is why Dr. Girish, what he has mentioned, that point is most important, because nobody can tell how the screw is going. So many times foot is a little oblique, we feel that we are going 30, 40. Invariably your CT scan is going to see like this, but what happens is now, if this is a partially threaded screw, the head is going to take your fibula towards the direction of the screw. And even if you have reduced initially well, it is going to malreduce. So
Correct.
what he has mentioned is, that is called as gliding path hole K-wire. There is a paper on it. Gliding path hole K-wire, that means the way धावपट्टीवर विमान उतरायला जशी मदत होते की नाही, तसं that K-wire helps you to keep it reduced. And then whatever screw, positional screw, that doesn't matter. So hold on with these K-wires, 1 or 2. I always put that K-wire as a derotation K-wire, and then put this screw, so that this screw will not drive fibula that way. So even if that direction is missed, it is fine. But that K-wire is a holding wire, and it should be a fully threaded positional screw, so that then direction won't matter. I mean, even if you little bit miss, it won't matter.
So don't use the screw as a reduction tool. It's a positional screw. Reduction is done by yourself.
Okay. So this was at 3 months. This is the 2 years post-implant removal X-ray, and this is his walking video. The video showing the incision on the 2 sides, on the medial side for the deltoid repair.
Posterior malleolus, because it was thin shell of bone, but he was knowing that he is going to fix it indirectly with the syndesmotic screw. We agree. I mean, somebody was discussing about the ligamento-taxis. Probably this is a rim where even if you wish, you cannot
fix it. Agreed, sir. So I went back to some of the review of literature, as already Rahul sir had shown that it is the same. Short-term results of the ruptured deltoid ligament repair during an acute ankle fracture. So they have given some tips. More favorable final follow-up of medial clear space in the deltoid repair group, particularly when accompanied by a syndesmotic injury. Final follow-up clear space and the clinical outcomes were better in deltoid repair group. This is another paper in 2020, outcome of primary deltoid repair in acute ankle fractures, a meta-analysis comparative study. They showed that who had their deltoid ligament repaired had superior early and late radiological correction of the medial clear space. However, they quoted that no differences in the functional outcome and complication rates were reported. Adding deltoid ligament repair in ankle fracture treatment, is it necessary? A systematic review. They said that there may be some advantages of adding deltoid ligament repair for patients with high fibula fractures or in patients with concomitant syndesmotic fixation. The take-home message from my side would be POTS fracture with inferior tibiofibular syndesmotic injury without medial clear space problem, no need to open the medial side. But if the medial clear space, but if the medial clear space with these injuries then is increased, then always open on the medial side to see the MCL injuries. Thank you.
Thank you, excellent presentation.
How much time is
After this session, I just want to ask a question to Dr. Sampath, Rahul and Girish. And
how much time is there for discussion now? 5 minutes?
You said that the syndesmotic reduction there are 50 to 60% are malreduced. So is it necessary for every, after fixing every syndesmotic, CT scan is must?
No, sir. Not necessarily. You need to do a CT scan only when you have a doubt. See, malreduction rates are high, but if you follow the protocol or the techniques, and if your reduction and everything is perfect, you don't have to go for the post-operative CT scan. But yes, if you are not sure on the post-operative X-ray that your tibiofibular space or the medial clear space, or if you are not sure, and if your patient is having pain on walking after the reasonable period of time when the fracture are healed, these are the time when you need to go for the CT scan, and you need to identify more whether we should go with the removal or do the revision surgery. But as a routine, you don't require.
I agree with him, because unless you suspect, it is difficult. And in institute it is easy, because anyway we don't charge them extra. We just take a limited cut, because we have charged him pre-op CT. So that time only we will request radiologists that, look, I am going to take post-op 1 or 2 cuts, don't charge for it. But only thing is, you have to study yourself. You don't want to just read the report that screw seen through the syndesmosis. You have to see the reduction.
Any questions for this session?
The 50 to 60% that he was talking about was about the close reduction of syndesmosis, not about the open reduction. So the ideal thing is to do an open reduction. So anyways, your complication rates comes down to 15-16%. And then further improvement in the technique of it, it will get it further down. So I think that is the better option.
Sambaram, you had a question, you wanted to ask.
For minor malreductions, early removal of screw is better, or carrying with the screw till it breaks and with arthrosis for 6 months, which is the better choice? Because revision surgery, getting into the entire thing again, which is the patient's choice, or what is the surgeon's choice as well? You got my point, sir?
I think it's a very good question, and through this question you can give the clear message. Like, very good question of whether to remove or not. Sir, when you have done a surrogate fixation of the posterior malleus by syndesmosis, if you remove the syndesmotic screw, suppose your patient is having posterior malleus fracture, chip fracture, and a syndesmotic injury and the fibular fracture, and you have done a surrogate fixation of a posterior malleus by the syndesmotic screw. You have not fixed the small shell-like posterior malleus fracture directly. These are the cases when you remove the screw early, they'll go into dehiscence for sure. Because the syndesmosis ligament takes 3 to 4 months for the fibrotic healing. And still that fibrosis, if your posterior malleus is not fixed, with the body force, it may go into posterolateral. The talus may follow the posterolateral course. And you find that my syndesmotic space is reopened after the removal of the screw. But if your posterior malleus fixation is done, lateral malleus fixation is done, medial malleus, and then you are applying a screw, routine removal is not advised. But yes, if your patient is having pain, or if the patient is having restricted dorsiflexion, you can remove the screw after 4 months. So both are the different scenarios. If posterior malleus is not fixed, please don't remove it.
We had the discussion that if there is a small posterior malleus, your plate should not go much more medial. It should be on the lateral so that it should protect the posterior. Suppose it is associated with pillar fracture, where the fragment is a very large fragment. How much up can you go, and what are the problems facing during the study?
Yeah, that's a good question. Going up by the posterolateral approach, one hindrance is the FHL, which is arising from fibula. You have to take down that muscle. That is only one hindrance. Second is the peroneal perforator, on which plastic surgeons they base their flap. That peroneal perforator has to be cauterized or has to be tied by Vicryl. That is second. But I will give you an easy solution. If it is high, then take that opportunity to see the apex from medial incision. Because medially if you go, it is very easy to go on the posterolateral aspect and see that spike. Thank you. See this. We are talking about this particular going up and up. When it goes up and up, very easy to just take a nick on medial side, see tibialis posterior tendon FHL, go subperiosteally, just put small homons, and that apex reduction is the best reduction because you are putting that apex into the position. So rather than struggling here up and up unnecessary, see this FHL is going to traverse like this. This is the only hindrance. You have to take this muscle away like this. So if you have to put long plate, it is fine. But otherwise, only to see the reduction, you can just come from medial side, see that apex, hold it with some pointed reduction, and then put a plate. Bigger the fragment, no need to buttress it with large plate. 2 good screws are going to take care. So why to unnecessarily do that much of dissection? So just play with the principles, because more proximal apex, then you are good. Unnecessary, rather than going from down, see from up and medial side.
There is no need to go above the apex, buttress the plate. Palpate the apex.
Because we are now thinking this is usually in pilon fractures, pilon variants. Because this much big, Yeah, because our pilon fracture is a soft tissue injury. This is not a bony injury. You have to respect soft tissue. And you do the fixation by taking away soft tissues is a carpentry work. So probably we have to just put your soft tissues back, and those soft tissues will give the stability which none of the implant is going to give. So keep the soft tissues intact, just play around with the apex, put the apex back and 2 screws, and then of course your pilon other construct is going to give the stability.
I think we'll be discussing about pilon later, but one important thing about this is whenever you are dealing about the pilon, you have to take care of one of the most drastic complications of pilon. Whether it is the least possible percentage is a severe wound disease. And you have to also make sure that you, as much as possible, keep the territory of a sural flap uninterrupted. Do not go there, do not give incisions there. Your perforator should be intact. So make sure you don't go proximal to the syndesmosis laterally as much as possible. Because unfortunately, if you have that in dehiscence, you would need that local reverse sural flap to come over there, and if you have already reached there, that flap is gone. So your patient would end up into a free flap. So in a pilon, you have to be very careful about that flap possibility also.
Sampath sir, one last question. So posterior approach, what we have described, one paper says there is some abnormal artery which is crossing across the field, and in some small percentage of cases that being a major artery may create some vascular issues. Have you come across any such cases?
Recently I had one patient, and that too VIP patient, when literally I thought that I should call plastic surgeon because she was VIP lady, young lady, and that was this thing. When I involved plastic surgeon, we have to see around the vascularity. Very rare, don't get discouraged, but you can see a very big vessel. Even to be honest, I was not aware. When I saw that much of big vessel, then I involved my colleague. Little easy to get the help in institute, but then she had enough vessels around, so we could. But while tying also, I was not sure that whether I am going to do any this thing. But it is possible, but I have seen only once.
But what that paper says that because in that paper it led to gangrene, it seems. And
Yeah, that's what. But fortunately,
it is worth doing angiography also.
yes, then that time you can just stop, you can see. That's why vascularity all around should be seen. Little be aware of this, but not very common. Only once I had come across, but that time I took my time. I was not hesitating even to close and come back, because you can just span with the external fixator, you can always come out and say, rather than landing in soft tissue issues.
Thank you very much. I think it was a good session. I would like to thank the panelists, Dr. Arvind, Dr. Vinay, and Dr. Avinash. Thank you very much. And also my co-moderators for excellent discussion, Dr. Nagesh and Dr. Madhura. And thank you for giving this opportunity to guide this session. Thank you very much.
Thank you, sir. Excellent discussion. This is what we wanted in this session. Our team is case-based discussion, no bilateral discussion.
Thank you, moderator
I
sir.
request Dr. Kumtale to please felicitate Dr. Kucharkar sir. Dr. Avinash Kulkarni, please felicitate Dr. Nagesh Naik sir. Dr. Vinay, please felicitate Dr. Madhura Kulkarni. So 2 sessions we have already completed with excellent discussions. The next session is most common, that is the biggest tarsal bone, that is calcaneus. I know there will be a lot of hot discussion here. So I request moderator Dr. Sampath Dumbre Patil be on the stage, Dr. Girish, Dr. Sunil Patil sir, panelist Dr. Santosh Deshpande, Dr. Abhijit Vaksavre, Dr. Shirish Tumbal, please be on the stage. One more announcement, after this we are going to have first live demonstration in India in any orthopedic surgery conference, that is live demonstration on patient with ultrasonic machine. Thanks to Dr. Sampath who has suggested this. So there will be live patient and the ultrasonic machine is there. Dr. Mrs. Sampath Dumbre Patil, Mrs. Vaishali Patil is there, and Dr. Ashwini Hulle madam is there from Pune. After this session we will have that session. Next speakers, please be in time. Dr. Rahul, Dr. Sampat Dumre Patil, Girish, then Dr. Vaibhav Gandhi sir, Nagesh Naik sir, Dr. Nitin Patil sir, Dr. Rohan, please.
So we'll move on to the next session about.
Sorry to disturb you. Before that, I just want to felicitate Dr. Satish Kumar, please. Dr. Sanjeev Kumar. I request Dr. Abhijit Vaksore, please felicitate our faculty, national faculty from Chennai. Dr. Kishore from Surat. Thank you all national faculties from all over the India. Taken time from their busy schedule and attending this conference. Dr. Shirish, please felicitate Dr. Kishore Dudat from Surat. Rahul, please.
Thank you, sir. So now we'll talk about the largest tarsal, the calcaneus, and about the decision-making part of the calcaneus fractures. So just a brief introduction, because it is one of the largest tarsal bone. 2% of all the fractures are calcaneus. And the most important part is 60 to 75% of these calcaneus fractures are displaced intra-articular. So that means that the principle of a displaced intra-articular fracture anywhere else has to be applied to the calcaneus. And also one important point is 90% is occurring in young adults. So if we do not manage this bone carefully, if we do not give the perfect outcome, we are affecting the most productive aspect of our society. And these patients, if they land up in a malunion, painful calcaneus, their overall productivity goes down. So the anatomy of the calcaneus, it is very important to understand its surfaces, its articular facets, its orientation in respect to the talus, its orientation in respect to the cuboid bone. So once we understand the anatomic, bony anatomy and the tissue anatomy of the calcaneus, then only we can proceed further with the fixation part of the calcaneus. And with the history which says the man who breaks his calcaneus, or the man who breaks his heel is doomed. So I think now it's time that we move on to it, because for late this has been the scenario, and I think all of us see very frequently a malunited calcaneus coming to us with walking difficulties, limping, and they complain that they're not able to get back to their previous activities, especially the job profiles. So we have to understand the fracture pattern, that the primary fracture line, which is laterally, it causes and divides the body of the calcaneus into the medial sustentaculum fragment, which is considered a stable fragment most of the times, sometimes it is not, and an anterolateral fragment. And further, if the joint forces continue, it causes a secondary fracture line, which causes it to depress and make a tongue type or the joint depression type of fracture patterns. So how do we differentiate? This is how we differentiate a joint depression. The line is posterior to the facet, and the tongue type is just posterior and inferior to the posterior tuberosity. And that is how a tongue type fracture pattern comes up. So these are the two types. The fixation pattern can be decided later on once we decide the clinical aspect of this patient. So we have to assess this patient clinically, because just like a pilon fracture, this is also a soft tissue injury, not just a bony injury. So any severe disruption of the soft tissue, swelling, all these things have to be taken care. You have to make sure that there is no associated compartment syndrome, the skin blisters on the incision site. If it is an open fracture, that has to be dealt differently. And you have to make sure it is the associated injuries, because most often these are fall from heights or high velocity RTAs. So the conditions like these, a condition like this, they do warrant you to wait and watch this patient, so that once we have treated the soft tissue, then only we move on to the treatment of the bony injury. So now how to decide the bony injury? It needs an evaluation through the radiographic. A radiological evaluation needs proper radiographs, a CT scan before we decide. So a plain radiograph that involves foot and ankle has a lateral view of the hind foot, AP view of the foot, axial view of the heel, a mortised view of the ankle, and finally the associated spine and pelvis x-rays. So we make sure that we look at the tuber angle of Bowler and the crucial angle of Giesen in all these lateral views. So you see, this is how we measure both the angles. So all the lateral views have to be assessed on the basis of this angle. And what they give information, they talk about intra-articular extension, they talk about the kind of fracture, which is joint depression or tongue type, loss of height, change in the angles. Second is the Harris axial view. They talk about the loss of calcaneal height, they talk about the width increase, varus angulation, and depression on the articular surface. So these are the lateral and the Harris axial view that we are supposed to take. The associated views are AP and the mortise view, because they are going to tell you about the CC joint, they are going to tell you about anterior lateral fragment, lateral calcaneus wall, the posterior facet, abutment of the lateral malleolus. So these are the compilation of all the views that a calcaneal fracture needs to have. So we have to have a lateral, an oblique, anterior lateral fragment you have to see, a Broaden's view to finish with, and a Harris axial view. How to take a Broaden's view intraoperatively? You can take foot on the X-ray, 10, 20, 30 degree of internal rotation, and sequentially you see the subtalar joint and the posterior facet of the calcaneus. CT scan, now you have to make sure that it is less than 2 millimeter interval, the axial cuts, sagittal cuts, and 30 degree semi-coronal cuts. These three cuts are very, very important when we are taking the CT scans, and these are going to tell us about the various problems this fracture pattern can cause, like the abutment of the peroneal tendons, the widening of the heel, the varus angulations, and how and which is the stable fragment to fix with. And then we classify on the Sanders type, like type 1, type 2, depending on the number of fracture lines and distribution of the posterior facet. Now coming up to the treatment part, once we have categorized, we have done the evaluation radiographically, we have classified on the basis of the classification, the Sanders, then we decide what kind of treatment this patient needs. So a non-operative treatment is only and only reserved for an extra-articular and undisplaced fractures, a Sanders type 1 intra-articular fracture with less than 2 millimeter displacement, or any patient with a severe peripheral vascular disease who might end up in a risk of amputation, uncontrolled and a poorly controlled diabetes mellitus, elderly with minimal or no ambulations, abnormally large wounds, and life-threatening injuries which take priority over the calcaneal fractures. So for non-operative, you immobilize in a below knee slab, limb elevation. After edema subsides, you can put them on a cast or a fracture boot, and gradual initiation of weight bearing by 6 to 12 weeks. Coming up to the next and the more common part, which is the operative treatment. Now we saw that up to 70% are displaced intra-articular fractures. So nearly 70% of the fractures do need treatment operatively. So since a displaced intra-articular fracture of a proximal tibia needs attention, similarly a displaced intra-articular fracture of a calcaneus needs attention. Various approaches have been talked about, like the medial, the lateral, a combined approach, a sinus tarsi approach, an extensile lateral approach, percutaneous fixation. So the most common and an approach which gives you the maximum amount of exposure is an extensile lateral approach. But whatever approach we choose, we have to see these following things. We have to make sure that we attend to the facetal depression. We attend to the subfibular impingement, wherein the fragment impinges on the peroneal tendons between the fracture fragment and the lateral malleolus. We have to see for the lateral the heel widening. We have to address the heel widening component of it. We have to address the talus inclination component. So you have to make sure that all these four components are addressed, whatever approaches we are choosing. Now the wrinkle sign. Now this is a very important aspect as long as we are going ahead and doing fixation with the open extensile approach. You have to wait for the wrinkle signs to come, and then only you go ahead and operate with an extensile approach. Yes, if you are well versed with extensile and you have moved on to the sinus tarsi, then you can go early, or with a percutaneous approach you can go early. But with an extensile, wait for the wrinkle signs to appear, and never miss the associated injuries with the calcaneus, because these are high velocity injuries, so the patients might have a missed Lisfranc injury, a midfoot fracture dislocation, spine and pelvis. Sometimes an open fracture may be there, so wait for these conditions to improve. Do a proper pre-operative planning. So we'll just see a few cases and various approaches how to do. So the first case, again, if you see, it's a tongue type depression, and we can easily fix this with a percutaneous fixation technique and get away without any open complications. Case 2, again, this we have addressed with an extensile lateral approach. Now this is a brilliant approach because it gives you access to almost all the anatomical aspects of the calcaneus. You can get rid of the heel varus, you can get rid of the heel widening, you can get rid of the facetal depression, and you can do a thorough anatomical reconstruction of the calcaneus. One more example of an extensile lateral approach where you could see there is the facet is down here, which is depressed, and the body of the calcaneus, rather the posterior tuberosity, is in line with the subtalar joint. So that we can correct and elevate the joint, do a fixation with a lateral plate. Now coming up to the next approach, which could be a sinus tracea approach. Now make sure that you are well versed with the calcaneus anatomy. You have done at least 20-25 cases with an open technique before you move on to the sinus tracea approach. So this is a minimal invasive approach where you can fix this with a small incision. Use this plate. Any plate is fine. This is a distal and radius plate that we have used here. But now we have more advanced Indian sinus tracea locking plates along with the international imported implants. And we can fix these fractures easily with the sinus tracea. So this is an Arthrex plate now here. The same fixation can be done with the sinus tracea. And coming up to the last part of it, the open fractures, these you have to wait and always make sure that you get all the views. So if you see now, the Harris axial view has shown, in spite of the lateral view not showing much of the deformity, the Harris axial shows that there is a big medial chunk. And this is an open injury you can fix with the small K-wires and get away with the problems. Again, one more example of a sinus tracea plate fixation, correcting all the aspects of the calcaneus deformity. And last, the malunited calcaneus, that needs either a fusion or a reconstruction depending upon the type of injury. Thank you.
Good morning. I will be talking on calcaneus fractures, how I have evolved. Now, always remember this slide that calcaneus has very good thalamic bone here. So this has very good cortical bone and this is little void. So we should understand that nature has given us very good bone here where you can insert a screw from here to the sustentaculum talus and this will get a good hold. Don't try to fill in this with the bone graft and expect this to remain up. What is going to hold is your screw and not that bone graft. So there is no need of bone graft in calcaneus and this is Sanders' study. So always remember thalamic portion, very good cortical bone over here. What is best treatment for intra-articular? Still it is debatable. What works best at your hand should be done. Either pendulum is swinging from conservative to operative, extensile, sinus tarsi, many plates, and I have now shifted to maximum of sinus tarsi with the K-wires. Why? I will just show you. While treating calcaneus fracture, please assess every case individually. And always remember 3 points. Patient, what patient needs, what injury needs, and what surgeon knows. Okay, so what patient needs is different, what injury needs is different, and what surgeon knows is different. What do I mean by that? If there is a calcaneus fracture, same geometry in a 12-year boy, or a 40-year adult, or a 60-year smoker or diabetic, is it going to be same? Of course not, isn't it? So that is the answer. So I always do this, I always do that. Let us not make science that simple, isn't it? So just do adequate for the patient, isn't it? So what do we mean by patient? If patient is diabetic, smoker, open wounds, then definitely he is not a good candidate for lateral extensile approach. If you choose lateral extensile approach, it is not that approach which is going to fail, it is our decision making which is going to fail, isn't it? So this is the literature support which says that if diabetes, smoking, vascular insufficiencies together, then wound dehiscence chances are to the tune of 90%. So if patient comes to you, he is a 60-year tobacco chewer and diabetic, will you consider lateral extensile approach? No, just do adequate for him or her. Injury. So Dr. Rahul has nicely told about injury, joint depression or tongue type. Now, this injury, what it requires is definitely different than what this injury requires. That means any translation of this tuberosity fragment is going to get reflected into the posterior facet fragment. But any manipulation of this is not going to get evaluated in posterior facet. Got my point? So, manipulation of this is going to get reflected intra-articular, but manipulation of this tuberosity is not going to get reflected into the joint depression type. So, I will just skip through this. We know we have talked about it. So, I will just go to the case. I like this classification. In CT scan, just see this is a body, this is sustentacular talus. Okay. Now you see this lateral facet, whether it is here, whether it is here, or whether it is here. Got it? So coronal CT scan, you particularly see, evaluate. If this facet is lying down here, then I need to put my homons here, like this, and elevate it up. Then only intra-articular reduction will also be good, and then only this varus is also going to get corrected. Got my point? So it will help you for both the things. Now, injury assessment by CT scan, widest facet of talus, what it does to the calcaneus, that is most important. Because there you are going to see the intra-articular part. Align this way, go to the CT console, align your CT scan this way and not this way. This orientation is not going to show you the facet. This facet is going to be seen like this. Got my point? You can do it yourself. What surgeon knows, Dr. Rohil sir has talked about, we have the responsibility not only intra-articular alignment, but axial alignment, height, width, length, and subfibular impingement, everything, and even the axis of talus. We have to correct so many things. So tomorrow a 65-year person comes and it is Sanders 4, still don't get disheartened. You have got so many things to do closed way. You can correct his varus, you can correct his length, you can correct his heel widening, so many things you can do. And before MIS, be adequate surgeon to have fixed some this thing. I will always tell my colleagues, never start calcaneal case without seeing a good axial view, and never leave OT unless you see a good Broaden's view. Got my point? Means before you start, you have to see that your table allows good axial view to be seen, your position is adequate, and your table doesn't have that metal end plate there. Otherwise you will struggle. And good Broaden's view means good reduction. Okay, so these two things I always tell my younger colleagues. You have to have soft tissue resecting approach. I started my journey like this. These were the cases where I waited till wrinkle sign 10 to 12 days, lateral extensile approach, good reduction, good follow-up, and good function. Even this was working well. Then I shifted to this. This is a joint depression type. You see, joint depression absolutely going down there. Sinus tarsi approach, elevate it, fix it with sustentacular screw. I am talking about this screw. Don't fill this with the bone graft. Don't expect bone graft to do magic for you there. And this happens, this applies to the most of the even proximal tibia condyle. Don't expect proximal tibia condyle to be only filled or held with the bone graft there, but your raft screw is going to hold. Same way, this is the thalamic portion which is going to be held with the sustentacular fragment. And this axial alignment is maintained, facet is been doing good, and Broaden's is good. That time I was fixing it with the screw and sustentacular screw. Even this has worked well. Later on, we shifted to the distal radius dorsal plates. Even they were working fine for us. Distal radius plates, small plates, that also can be done with sinus tarsi plate. But look at this. Everything has to be corrected. Axial alignment, height, width. Then with these difficult fractures, we can even go with these Arthrix plates, which are nice plates. We have used those fragment specific plates. But then what we realized, he was a diabetic, 65-year-old patient. But look at this. This has a deeped down so much that even it has subluxated in ankle joint. Now, being a diabetic 65-year, I cannot leave him like this. So, we started our journey like this from here. Look at this. Talus has been absolutely gone down into the calcaneus and ankle is subluxated. Fearing the soft tissue complications, I cannot conserve this. So, what we did, see this, completely open calcaneus and talus has gone into the calcaneus. So, ankle was subluxated. So, we took sinus tarsi approach. This first Steinman pin or Dunham pin with sterile bandage to achieve the length. Got this disimpacted, talus has come back. A screw, as I told you, lateral to medial, little caudal to cephalad and little posterior to anterior. This sustentacular screw and a K-wire. This K-wire is going to be absolutely a lateral strut. If you want, you can put one medial K-wire also. This is a transarticular K-wire. And that's it. I show the patient that this is out so that he doesn't walk on it, and compliance is also good. If I am using this screw, I will remove the wire after 6 weeks. If I am not using the screw, then I am going to take the wire after 8 weeks. 12-year boy, Vachesar's case. What you will do? Will you do plate for this? No. Simple K-wires, transarticular K-wires. Look at the union. This is Vachesar's case we did here. Another case, see this is tuberosity avulsion also, but intra-articular also. And always, wounds on calcaneus are on medial side. Usually posterior medial side or medial side. Look at this now. Reduction achieved. Transarticular K-wire for holding this across the talocalcaneal, but here even this was involved, so across the calcaneocuboid also. Now, I started from the plantar aspect, not the posterior aspect, so that it will not irritate the patient while lying down. It is out here. I started here, but came out of the cuboid, and I am going to keep the out wire here, so that it is not going to irritate the posterior part. See this, good axial alignment, good Broaden's view. All other aspects has to be taken care. And look at this. Good reconstruction, good healing. But show this to the patient that look, this is out. Okay, but this is out anteriorly, although I started posteriorly. And this is how it heals. See the function. And this is immediately after K-wire removal, we allow them to start like this, and later on they do well. Another case where it is Vachesar's case again, where multiple K-wires were put, but try to avoid K-wire keeping out here rather than keep it out anteriorly. So what K-wires help us? Avoid subsidence of facet, because so many times along with the plate also there is a subsidence or there is a varus. Maintains the axial alignment, maintains height, maintains width, maintains length, because they are transarticular. Remember well, they are not only K-wires, they are transarticular, and the amount of hold which you get in talus is phenomenal. And if you put it here, lateral wall, if you put it here, medial wall, axial alignment, length, height, width, everything can be maintained. And basically compliance of patient. Patient will not walk. And see this how it heals. So, I will show you multiple cases where this is a compound case. Again, medial side wound. Again, same thing. Reduction, K-wires removed. And this is long-term follow-up after almost 10 years. I will show you last case. This case I did in Mirrors, where he had a spine fracture, and we were involved only after 6 to 8 weeks. Now, after 8 weeks, if you translate this, obviously lateral soft tissue are going to be stretched, and wound healing issues. So again, we decided same thing, that where I used this Homans as a reduction tool because it was grossly overlying here. Slowly we brought down there. Look at the good axial alignment, good intra-articular alignment. 6 weeks. I won't give you message that do it after 6 weeks, but I'm just presenting that even this can be done. And see this, one strut medially, one strut laterally, transarticular wire. This is long-term result, and he is walking well. Even I have video of this. So multiple cases I will just run through. Just do adequate to the patient. But by adequate doesn't mean that you do only the intra-articular part. We are correcting everything. We are correcting axial alignment, height, width, length. And this is very helpful, particularly in compromised or difficult scenarios. And we have recently published this also. Thank you so much.
Yeah, thank you, Sampath sir, Rahul, for the enlightening talk. We may have 1 or 2 questions before I load my presentation.
Uh, 1.8 wires for the transarticular part, and initially to hold maybe 1.5 K wires from that screw as a orientation.
Sampath, regarding this calcaneal wires you are passing through the heel pad, the commonly known as a chronic heel pad pain due to the malunion or something, you are piercing to the fat pad which will cause a bleeding inside the fibrous. It's a specialized areolar tissue which causes the bleeding. So we should go from the posterior facet rather than going from the heel. What is your view on this?
Yeah, it is said theoretically, but we have never faced it. I mean, we always pass it from plantar aspect to this thing. And even when I were publishing, there was an objection to this. But intra-operatively, even other surgeons pass it same way, but they remove it. So once you put it and keep it there, it is same as what we retain there, and hardly it has caused any problem. But this problem of fat pad atrophy or this thing is definitely there if it is secondary to injection. If it is there, it is definitely going to be harmful, but not with the K wires. Definitely not. We have not faced a single time.
Sir, what is your treatment strategy for both, for medial wound and lateral wound? Initial strategies.
For the?
Medial wound.
Yeah.
Wound on the medial side of the calcaneus, and another case, wound on the lateral side of the calcaneus.
Usually wound is on the medial side. Usually, all compound this thing. If I want to answer your literature wise, till compound grade 1, you are allowed to put plate laterally. Till compound grade 1. Beyond compound grade 1, 100 times think over if you want to put lateral plate. Okay. Generally, I do not put in compound distinct plate. I will try to put screw and K wires. But if literature wise you want to answer, then compound grade 1 definitely you can safely put a plate. Compound 2 onwards, you can literally wait and go for a second time, or you can think of other alternative this thing. Lateral wounds I have come across, but then I would only go for K wires, as I showed you in this. K wires and screws. Screws inside with thorough debridement, provided you are going initially and you are the first surgeon to do it, then it is better that put screws inside and K wires.
So in first stage only, during
First
the
stage.
debridement you put the
Yes,
screw,
there,
if it is on the lateral side.
Yeah. Sir, in foot and ankle, you will hardly get second time to go in with that good this thing. Yes. So whatever you can do, I showed you that case with a big wound. Everything was done day 1. And probably that is the best time to do it. Later on, it is all salvage, salvage and salvage.
Thank you.
So in your presentation, you had showed initially sometimes you used to two screws on the medial and lateral side.
Yes.
So what made you stop using that? Because it would be holding for a long time if it is used a full threaded subarticular screw on both sides, medial and lateral side. So what made you to stop that?
I won't say that don't do that. people are still doing it. Only issue is, while doing that, so many times intra-articular coronal splits are underestimated. Sometimes how much that screw is holding, we don't know. But definitely you can do that. Still people are doing it with multiple screws, and that is also a well accepted modality of treatment. I won't say that this K-wire
Now you are using only
two wires,
which are trans
articular.
and through the talus. So I mean to say using of same directional screws, fully threaded, but they are subarticular.
Yeah, subarticular. Yeah, that's what, sir. So many times you have put it only in calcaneus. Along with that, it may go in valgus, or along with that, I have seen subsidence of facet. Because, yeah, these transarticular wires, sir, they don't allow subsidence at all. You just pull them out.
See, just adding to his question further, there is something called as a truss and beam effect in the calcaneum. If you have seen, you put a screw in the at the area of the substanticulum talum and two screws percutaneously, cancellous screws fully. So that substanticulum talus screws you may put from, most of the times he puts from the lateral side, but some cases I have put from the medial side as well. Because it's like putting in a Stillman pin from the medial side of the tibia, because we don't know where it's going to end up into the peroneal. So similarly here, it is better sometimes to put, if you have a larger fragment which is displaced on the substanticulum talum side, it is better to enter from the medial side, putting in K-wires and you getting the directions and putting it exactly subchondral to the, and 90 degrees perpendicular to the fracture side. Thank you.
This was my question, sir. How do you manage the substanticulum talus which has displaced medially? How do you pull it and bring it into position? If you have any video, then...
So we have a video presentation. My next talk is a video presentation. It's a 8-year-old video, but I still feel that this is a good video. Only thing which I need to modify is the plate which I am using right now. Earlier I used to use the 2.7 mm T plate on the L plate from the set of distal and radius. So this is basically a technique video where we'll get all those answers, how to do the reduction and how to put a wires. So this is a Sanders type 2 and type 3 where I use the sinus tarsi approach in most of my cases, I would say, which are presenting for less than 6 weeks. Is it running? Okay. So, so this is a technique video. This video has been recorded at my friend's place almost 8 years back. So you know the burning issues in the calcaneal fracture which we already we have already discussed. Lateral extensile approach is not an approach for the diabetes patients, for the patient with a high hematoma, PVD and the gross swelling which have not subsided for more than 6 weeks. So these are not this is not the case for the lateral extensile approach. But we have seen some of percutaneous technique also, but it is just a play. Without opening and without seeing the joint depression and elevating the posterior facet, there is no technique which is called percutaneous reduction and the fixation without a opening and the elevation. And that creates a burning issues and complication of the calcaneal fracture when you came up with the calcaneal fracture malunion. And that leads to subtalar arthritis, varus valgus malunion, peroneal impingement and lot many other problems. So I'm just showing a single case which I operated a long back. So this is a technique video where all three components of the fracture are present, which Dr. Rahul has beautifully explained what are the components of the injury. You have to wait till the soft tissues settle. This is also not a new knowledge. And this is a CT scan which is showing a big chunk of a sustentaculum tali and a small posterior facet depression which you have to do from the lateral sinus tarsi approach. So you have to keep the patient in the supine position. Okay, so this is a time which is recorded in my hometown Gondia. So we were having some basic setup. So this small pillow was kept, hard pillow which was kept, tourniquet was applied, painting, draping as usual. This is a position of a patient with a pillow. And the C-arm position is very important because you should not disturb yourself during the surgery. So you have to move the C-arm in only one direction. So this is the oblique position of the C-arm. So this will give you lateral view, and this when you turn the C-arm in this position will get a axial view. So this is how you have to move. And the broadens, as Sampath sir said, in the last, before you leave the OT, you have to see to know whether my reduction is acceptable or not. So this is a patient position, and let's do the surface marking. So what is the surface marking? The base of the fibula and the base of base of fourth metatarsal and not fifth. Sometimes we have seen that some people, they go little plantarly, but it creates a problem with the sural nerve and a visibility of a CC joint. So this is very important that you have to be at the base of fourth metatarsal so that you can see the anterior part of the calcaneum beautifully. So this is the area where you don't have to go deep. Unlike the lateral extensile approach, when you go deep up to the bone, here you can go do the skin, subcutaneous tissue, superficial dissection. You will find some fibrofatty tissue. And if you find some fibrofatty tissue, that means you are close to sinus tarsi. So when you are beginners, you can mark a K-wire. And this is how you can enter. But if suppose you have done 10 to 12 cases, this job and the superficial dissection will be very easy, and believe me, it takes hardly 5 to 10 minutes to enter inside the subtalar joint. So this is a superficial dissection. Only muscle which comes on the way is a EDB, which is anterior part of your incision, so you can split it to see your CC joint. So this is how you see the fibrofatty tissue. And the very important step to know whether we are in the subtalar joint or not is this is a fibrofatty tissue, and anteriorly you can find the EDB muscle. So just move the peroneal tendon with the retractor, and the structure which you find is the calcaneofibular ligament. Cut the ligament. This is the only ligament which you compromise because it is blended with the capsule. So once you cut it, you will find the hematoma blood which is coming out, and that give you the idea that no, I am entering into the joint space. There may be small bleeders which you can cauterize. So once you cut the calcaneofibular ligament, see, this is a calcaneofibular ligament. So I am holding my peroneal tendon, and this is a stroud ligament. You will have a good feeling that you are cutting some hard tissue. Not like a capsule. So, and once you cut it, you will find a lateral talar process. So now you can see the lateral talar process. Hematoma blood, if you are operating within 7 days, after 7 days you may find some clots. So you have to give a lot of wash, remove the clots, because you have to see the sustentaculum tali. It is like a proximal tibia where you want to build the depressed portion of the posterior, of the lateral part of the posterior facet to the medial sustentaculum. So the medial sustentaculum is our height. On medial sustentaculum, you have to build your lateral tissue, lateral bone. And for that, you need to do elevation and the reduction maneuver. So this is how I am entering. My talus is now completely visible. Because the joint is depressed, you can see the undersurface of the talus. This undersurface of the talus without putting any distraction is only possible because your posterior facet is down. So now I am just separating my peroneal tendon from the lateral wall so that I can see the depressed part of the posterior facet on my lateral wall. So you have to give a lot of wash. You can put a distractor if you are new. See, I am putting 2 K-wires, one in talus and one in calcaneum. No logic, you can put anywhere. There is no position for the K-wire. You can put 1 wire in talus and 1 in calcaneum, but when you are doing a frequent cases, you don't need to distract and see the joint. But when you are beginners, always put 1 wire in talus, 1 in calcaneum. Your peroneal tendon should not be hurt, and you should able to see the joint before you start the manipulation. So put a hinter, because without hinterment distraction, you cannot visualize the complete joint line. So always put a distractor. Distract it, try to understand. Now let's see how much information you can get with this much amount of small distraction. See the posterior facet, now the fracture is very clearly visible. The posterior facet fracture, which is the lateral 1/3, it is now clearly visible. And this is a medial part, which is a sustentaculum tali, which you can now easily appreciate from this small retraction. Again, you have to remove all clots because this is a space which is usually filled with lot of blood clots, and now this is a posterior facet. Try to disimpact the fracture if you are operating in 7 to 10 days. So use a small Homans, use a small osteotome, or you can use any small corpse elevator to distract it. Because because of the cancellous nature of the bone, usually in 7 to 10 days, the mobilization becomes little hard. So try to put a small mini instrument, and this will distract your medial fragment with the lateral fragments. Identify the sustentacular fragment. And this one wire, if you have a heel varus, so just if you put a one wire from posterior to anterior without crossing the depressed posterior facet, because it helps to pull it helps to give you the valgus force, so it's easy. So don't put a K wire beyond that. So that is an easy step to control the tuberosity. Now the main part is the elevation of the posterior facet. For that you can use any instrument. You can use even the lamina spreader also. But make sure it should elevate to make a congruent joint with sustentaculum tali. It should not be above the sustentaculum tali. So you have to do the various procedures, and these are all the custom made instruments which you can use. If your suppose elevation is not acceptable, or if you are struggling, you can put a small lamina spreader and you can elevate it. But this is for the older injuries. In the fresh cases, generally you don't need that. So this is how you can elevate it, and you can put now multiple K wires. Transarticular K wires also, but I generally use the transarticular K wire for the intraoperative reduction and to maintain the elevation of the posterior facet. Because I completely agree to Sampath sir, no other than a transarticular K wire will help you to maintain the elevation of the depressed posterior facet. So now I am advancing my posterior to anterior K wire in a neutral position. I am putting one more wire. If my lateral view and the calcaneal view are acceptable, I am putting one more wire to fix my tuberosity. So one screw. Now this is a very important screw. Your question, sir, how to put a sustentacular screw? This is very important. So you have to be in oblique direction from posterolateral to anteromedial. If you are supposed directly perpendicular to the bone, the subtalar joint is having a posterolateral slope. So if you are putting a direct wire, you will end up with the intra-articular impingement of the wire. From medial side, the wire will come out. So you have to be from posterolateral to anteromedial. This is a wire position. So it should not be directly perpendicular to the bone. It should be the oblique position. And then now I am putting my tuberosity screw. Earlier we used to use the screw, but now after the plates we are not using the screw many times. So this is a sustentacular screw. This is the tuberosity screw, which helps to keep the heel in neutral position. And because I have done lot of elevation, because my anterior facet is also broken, not in this case, majority of the time I am very happy to use the small T plate or the L plate, because it helps my posterior facet it helps my reduction to maintain from anterior posterior to tuberosity. And the mobilization and the circumduction movement from the day 2 or day 3 is very easy if you are applied a plate on the lateral column. The another important advantage is when you are dealing with the lateral column blown out. So if it is suppose too much lateral column blow out, and after the elevation you have created a big void, you don't have to put a bone graft, but if your plate is there, this is the 8-year-old surgery when we didn't have a sinus tarsi plate. But now we have a small sinus tarsi, very low profile plate, so you just slide it under the peroneal tendons, put two screws into the anterior column, into the anterior half of the calcaneum to maintain the CC joint reduction. This completely buttresses your lateral wall, and this helps to maintain your heel into the neutral position like this. And this is the position of the plate and a sustentacular screw. But this is an older thing. Now we have replaced it with the plates. And in last, you can see this is the reduction. And this is how you can see the axial correction. Repair of the EDB muscle is very important if you have applied a plate, because the plate should be completely covered with the EDB muscle. So 2 or 3 layer closure is usually enough with 3-0 Vicryl. And here generally the wound complications are extremely less as compared to the lateral extensile approach, and also there is no risk of damage to the lateral calcaneal artery, which is the commonest cause of wound dehiscence. This is how the closure, but if you don't have to go anteriorly, you can minimize your incision. This is usually a reduction and the alignment. Another case, similar cases where I have used 2.7 mm T plate, L plate, and this is how the cases are done. Then another case, depending on the lateral wall blown out and the amount of the elevation, this is the mobilization from 7th day, 10th day, immediately after the removal, and this is the maintenance of this correction. Thank you so much for the attention, and I think from many part of the intra-articular reduction, yes, you can trace this video on the YouTube also. Thank you. Yeah, thank you, sir.
The next talk, we will answer the questions through cases because we are already running half an hour late. Rahul sir, any inputs from Baksore sir or Shirish sir? Yeah.
Yeah, so sir, three important steps or three important goals of fixing the calcaneal fracture is fix the CC joint perfectly, elevate the posterior facet to regain the molar angle, and the tuberosity should be fixed in either neutral or valgus. If these three goals are achieved, that means your work is done. Most of the radiological success factor is a molar angle, and on the basis of these three factors, generally the success of the calcaneal surgery is traced. So this is the important part. Many of the time you find that there is a small anterior fracture fragment of the calcaneum, which is not, you cannot put a K-wire on it. You have to apply a plate so that you can hold the two fragments of the CC joint to the posterior facet to the tuberosity. So it's quite easy. If it is not broken, yes, you can go with the screws or with the K-wires only.
When you don't do this approach?
This is again a very important question. If I'm dealing with the older injuries, so earlier the cutout was, if your fracture is 3 weeks old, doing a surgery with the sinus tarsi is difficult, but now we have done little extension. If your fracture is 6 weeks old, you can, up to that part, you can use the sinus tarsi. But if the patient is presenting after 6 weeks, you should not use this approach. Also, when you are beginners, if you have not done too much of the sinus tarsi approach, it's always better to understand the anatomy, to do the reduction method, elevation of the posterior facet by the lateral extensile approach. But in most of my cases, I am doing a sinus tarsi now.
So if you want to extend the plate posteriorly, how do you do that? By a continuous method or some G?
No. So you have to lift the peroneal tendons, take a 15 number knife and separate skins of subcutaneous tissue and a bone. So you have to apply a 15 number knife at the junction of bone and the subcutaneous tissue. No, not retract. When you apply a plate, so hold the plate with one sleeve and just push it under your peroneal tendon. You don't have to.
Dr. Girish, he is asking, putting the screw is correct. He is going to put the screw percutaneous shoutside this thing, because.
So tuberosity screw, small extra nick and percutaneous.
Under CM. Sham sir, we are running very late, and I will request speakers to avoid shifting the laptops, because we are little wasting time in shifting the laptops as well. Can we have talks loaded on the laptop first, please? Please do that. Rahul sir, please go.
Yeah. So we move on to the next approach, which is probably the workhorse of all the calcaneus fractures, the extensile lateral approach. Now this approach has gone into a lot of disrepute of late because of the wound complications, but we have to understand that if the wound complication reported is as high as 41%, it is also reported as low as 3%. So we can just, if we follow a few simple basics about this approach, we can also end up in a lower wound complication rate sites. So our aim today is to understand the indications, the preoperative planning, patient positioning, the intraoperative steps, how to close an extensile lateral approach, and the follow-up. So now this is a benchmark approach to the calcaneus, which gives the best exposure to the fracture and the bone anatomy. It makes the reduction very easy, fixation is easy, visible, and complication rates, okay, we can always debate over that. But the primary goal of this talk and also of this approach is to encourage young surgeons to start approaching the calcaneus with confidence. And once you have done 20-25 cases through this approach, you can easily shift over to the sinus tracea approach, because then, till then you get a very good orientation of the calcaneus anatomy. Indications is all displaced intra-articular fractures. So we have to do a preoperative planning, as we discussed before, by thorough radiological examination, by X-rays and the CT scan. Again, I would stress on this point, always do these 20-25 cases before moving on to the sinus tracea approach. What are the essentials? You need a radiolucent table, you need a large pillow to be put under the foot, like Giri showed in his video, a lateral position. Keep many K-wires with you up to the size 3 mm, K-wire distractors, lamina spreaders. And how do we do it? We grow gradually, we make a thick flap, we identify the facets, we identify various pathologies, and then we finally fix it. So here it is a lateral wall, we open the lateral wall, then after we open the lateral wall, we could see the facet. And once you have seen the facet, then we can elevate it and fix it with the plate. So we'll just see this through this small video demonstration, how to do a sinus tracea approach fixation of the calcaneus. So I always start in a lateral position, extension using the S-march. You might not use it, you can just lift the leg for a minute and follow this up. Then we do a surface marking of this patient. Stop for a minute. I'm sorry, the video has stopped, so I'll just replay this thing. Can you just see? This is just running.
Separate run करते हैं तो क्या बगा? Next, all talks are loaded there. Please, I will request speakers, next 4 speakers, to please load the talk, because it is taking too much of time in shifting the laptop. Dr. Vaibhav Gandhi sir, Dr. Gurunath Vache sir, Dr. Nagesh Naik sir, Dr. Rohan Singh and Dr. Nitin Patil. Please load the talks of this session at least.
Hello, good afternoon everybody. I am Dr. Vaibhav Gandhi, presenting here on totally different approach. You will see the calcaneum fractures, extra-articular, intra-articular, with a total different kaleidoscope. I am insisting for this minimally invasive surgery for this complex bone. Next, please. Hello. Kashade. I am trying to balance the things of AO principles of treating the calcaneal fractures or fracture fixation and a conservative line of treatments. So I am trying to balance this. As you know, calcaneum being a very complex bone, having a different, very difficult and different shape to understand, and multiple facets in different planes. So, and also it's a very demanding bone. As you know, as my previous speakers have insisted, this restoration of the bolus angle and the tuber angle is very must, otherwise invariably the patient lands in subtalar arthritis and subsequent need surgery. So what should be the goals of the treatment for the achieving better, not very good results, but even at least a better results in the average hand, is to restore the height of the calcaneum, which is very important, restore the length of the calcaneum, and the width of the calcaneum. These 3 points, if one address, it gives satisfactory to good results. So what is the mechanism? Most of the time it is a fall from height, and it involves mainly male patients and young patients. So here we will see how the fracture pattern goes. इसका light का नहीं है, त्याच्यावर brightness. So I am showing this animation only for the intra-articular fracture involvement. I had a similar type of animation for the extra-articular fractures. Most of this vertical line which splits the posterior facet in two fragments in sagittal plane, and whenever we see from the lateral side of the sinus tarsi, we can see only the medial portion of the facet only. This is the central depression of the posterior facet. We have to see the calcaneum bone in our hand. We have to imagine all three-dimensional views from the different angles to fix before fixing the calcaneum. Sorry. As you know, there is all the time there are wide variety of fracture patterns. There is no fixed pattern. Close reduction and percutaneous spinning for the comminuted intra-articular fractures gives a low risk of wound complications and requires less time, operative time. Wound healing tends to be much better, faster, as the soft tissue handles are very less. We have seen so many complications of open reduction and extensile approach, etc. So here we advise minimal invasive fixation. This approach is good in patients with significant comorbidities, with soft tissue compromise, and in polytrauma cases. The goal is, as I have said already, to restore the posterior facet, the height, width, and the length of the calcaneum. Many times we use only K wires, and as Sampath suggested, who is actually Virat Kohli of the foot and ankle, he plays 20-20, 50 overs match and the 5 days match also, and gives very good results. I am only like Surya Kumar Yadav. I try to be only on a very percutaneous fixation for the calcaneum. So the wires, K-wire fixation, transarticular K-wire fixation, bend on the skin, and the plaster fixation, it also gives good results. I usually prefer to put a 6.5 mm screw, one in the axial direction, from the posterior superior to the anterior inferior direction, and the second screw I always put from the sustentaculum tali to the lateral wall, which prevents the broadening of the calcaneum. Sustentaculum tali is like a calcar of the calcaneum, which is the most strongest portion, and it always goes, as he has shown, it goes to the just subchondral bone of the posterior facet, and it gives very good results. While putting this K-wire, it is very important, as my previous speaker has said, the sustentaculum tali, if one put a guide wire from the medial side to the lateral side, it has to be always from the medial superior to the posterior inferior and lateral side. So direction of this fixation is very important. This is the esophageal for the just percutaneous manipulation of the tongue type of fractures. We will go through the video of such same thing, how I do it. Talus, inferior surface of the talus is a mold or a template. We have to put each and every fragments, try to put each and every fragments, just pushing up to the inferior surface of the talus, so that the maximum posterior facet and the medial facet will be reduced properly, and we will achieve a good height of the calcaneum. See the previous first just slide of this same one, how the height of the calcaneum is achieved only by percutaneous way. and then I tried to put different K wires and put the screws, 6.5 mm screws over that. So this way, that I have put from the tongue type of fracture. If there is a central depression fracture, as mentioned by Sampath, it requires a different way of percutaneous elevation. I just poke the lateral wall and with any stout radius lever, I just elevate the posterior facet and the middle facet superiorly, and I put everything towards the talus, and it will get the automatic. So I will run fast. This is some simple tongue type of fractures. These are the depressed fractures with central depression. One can see this is the yellow, the horizontal line. This is to elevate this fragment intraarticular portion, and this is the way I put the sustainable tali guide wire. Here you can see the same one, how this prevents the broadening of the talus. This is the main crux for the success of the fracture fixation. There are different cases. I will just run through very fastly. These are all cases managed in the same way. See how nicely the height is maintained. These are the different cases. Here one can see the facet is almost driven in the bone and it is elevated very nicely. You can see here how it is just maintained in the subtalar joint. And then multiple guide wires are fixed and screw is passed over it. So here are some few cases treated in the similar fashion. One can use a bone spike or a strong lever to handle the fragments, try to push them towards the talus. Just I will conclude. These are the different cases, all different varieties of fracture fixation, but I just do it in this percutaneous way only. These are the clinical results of the patients. Here one can see what was the height of the calcaneum in here, what we have achieved it. So these are the only percutaneous single stitch fixations. These are the clinical results in different patients. So here comes one compound injury which was fixed in the similar fashion. Here I want to highlight, this is the undercorrection. This is not done properly. There are few X-rays were shared by some colleagues to me, and they asked the opinion. My peer Dr. Motwani, he in his first case, he put the screw like this one, but I am very much against of this putting the screw with so much of head outside, because it always irritates the skin.
Sir, can we conclude,
yeah,
sir, because we are running out of time.
So this should be avoided. This screw head should be avoided. The direction of the axial screw should not be like this, but it should be towards the sustaining tali. So in conclusion, the restoration of the calcaneum height, width and length is very important to have a good satisfactory radiological and functional results. Thank you very much.
Thank you, sir. Thank you, sir. Till Bache sir loads his talk, any question to Vaibhav Gandhi, sir? Okay, we'll take it at the end.
After Gavaskar, Tendulkar, Virat Kohli, Surya Kumar, being organizer, I am just allowed to throw one wide ball. Yeah, you can say bounce. Just want to share one case of sustainable TALI and want to advise from our national STM faculty. 45 years male patient with RTA history.
Just 1 minute. This project to that. Go ahead.
As we know, it is a very vital load-bearing structure, and isolated S-type fracture is rare, though it is rare, but we see nowadays a lot of common things in our practice. 55 years old patient with artery history came with this X-ray. I just want to ask the expert panelist and our moderators, Dr. Sampath.
Yeah. Actually, on X-ray, it is not obvious injury seen.
Just want to show the axial view.
Good. So this X-ray, taking X-ray in X-ray department is going to be difficult, axial X-ray, but yes.
So it is S-type fracture plus anterior facet calcaneus fracture is there. Just show the CT scan. Can you run this slide? Yes, comments after seeing the scan?
I mean, CT scan should be evaluated for this particular fracture geometry because anterior process that is involving calcaneocuboid joint and sustentacular, these are little awkward injuries and should be known for because sustentacular is called as a constant fragment. Deep deltoid or deltoid ligament is attaching to the sustentaculum and talus from the medial malleolus. So it is the most constant fragment, but here it has moved, and also the intra-articular part is calcaneocuboid.
So how you are going to address this patient?
First, correct the varus, reduce it into the axial alignment, see the calcaneocuboid joint, and now here smaller piece is the sustentacular piece. So here it is worth to go from medial to lateral. It is like going from smaller fragment to larger fragment, not to miss it.
Yes. So I just went after subsidence of the swelling. First I opened on medial side and then on the lateral side. So medial approach is to reduce and fix the S-type fractures. So this was the X-ray, but on table I found that it is unstable being bicolumnar fracture. So I have kept the fixator on table, and after medial side fixation I applied the medial side fixator in situ, that was for 6 to 8 weeks, and laterally with sinus tarsi approach I fixed the anterior facet. So this is the 2 years follow-up, and lateral process of talus was also fracture, so I fixed with the Herbert screw there. So this is the recent follow-up after 3 years. Comments from the panelists and moderators, Dr. Girish.
Yeah, it's a good fixation. One should remember how to address the sustentaculums. One vertical line up from the medial malleolus and one horizontal line from the first metatarsal. Where it intersects, there is exactly the sustentaculum talus. Again, I will repeat, one vertical line from medial malleolus and one horizontal line from the navicular. They intersect exactly at the sustentaculum talus. Now it is like putting a K wire in supracondylar humerus, medial K wire. You don't want to enter the ulnar nerve. So what you do, you take a small incision and you see that there is nothing else than the medial epicondylar. You really don't want to dissect the nerve, but you really want to see that there is nothing other than the medial epicondylar. Here, same way, you take a small incision here. You can take a big incision if you want, but if you want to plan medial lateral approach mainly, here you can open it, see that there is nothing else than the sustentaculum talus. Put K wire as a joystick, adjust it, and then put it across and then put the cannulated screw over that. If you can take the bigger approach, you can, but considering the approach, amount of soft tissue corridor you get is hardly 2 centimeters only to put a plate. You can put it, but neurovascular bundle and FDL is absolutely rubbing against that medial border of the calcaneus.
Yes. So conclusion, fracture style, though rare, it is associated with anterofacet and other associated fractures. Open reduction and end fixation is must for these fractures, and sometimes if it is unstable, you have to be ready with a fixator in situ. So this is 6 weeks follow-up. You can see fixator in situ. This is after fixator removal. These are the latest follow-up x-rays. And patient is heavy worker, doing all his routine activities. Thank you.
Thank you, sir. May I invite Nagesh Naik, sir, to talk on the calcaneus fractures.
Good afternoon. बैठो वाला था क्या? So Dr. Motwani has made my job quite easy, and a lot of repetition is going to be there, so I am going to run rapidly and save your time. So next that nahi. So this is a story of 2015 when I am doing this for a long time, since 2005, this approach. And 2015 I had got a lot of cases, and when I wanted to publish this paper, that time the extensile approach and plate was quite in vogue, and no journal, international journal was ready to accept this publication. So we tried with Americans, and European Journal of Orthopedics and Traumatology published this that time with lot of queries and lot of these things. But today my intention is only to show how I do it. So I am not going to tell you results and all those who want to know how I assessed AOFS and all those things, those can refer to this paper. So this is a patient's preoperative X-ray. Position same, lateral position, incision, little modification but nearly same. It's a part of combination of Olier's approach to tarsus and Korcher's lateral approach. The difference what I do in this way, other than what Dr. Motwani has showed. So in the proximal part of the incision, just behind the lower end of the fibula, artery percept is dipped directly into the peroneal tendon sheath to visualize the peroneal tendon through a small spread of artery forceps. Care is taken not to elevate the skin flaps at all to avoid soft tissue issues. With the help of pair of scissors, the peroneal sheath opening is extended distally to visualize both peroneal tendons. Distally, the peroneals are dissected subcutaneously for about 2 centimeters without incising the skin. What he was doing is he was taking all peroneal tendons posteriorly and not bringing it into the wound. Then I like to retract them proximally rather than pulling it distally. And with the right angle retractors hook around the tendons, they are retracted cranially over the lower end of the fibula. Instrument like Alice forceps, right angle retractors are not used to retract the skin for the fear of devascularization of the edges, and sural nerve is protected by avoiding it. Then once, as he has shown, once you clear off all those calcaneofibular ligament, blood clots and all those things, what you are intent to see is he has used many distractors and many fancy instruments. I use only these 2 right angle retractors. So what you see is now the talar articular surface. Once you see the subtalar joint, including once you do little varus, you can see the vertical fracture line, even sustentaculum tali, anterior facet, orientation, all those things you can see through this small incision. So on the lateral edge of the depressed posterior facet, this is the way I like to do it. On the lateral edge of the, so I pass the osteotomy in a sagittal plane, facing just flush to the posterior facet lateral wall, and retract the lateral wall and skin as a one unit without separating it. And I see the lowermost edge of the depressed posterior facet. Then elevation of the posterior facet. So the same osteotome is lifted in this manner so that the posterior facet will touch the inferior talar surface and you match the subtalar reduction, and the lateral wall along with the skin will go down underneath it. So it is important to dissect between the lateral wall, not to dissect between the lateral wall and the skin to avoid soft tissue problems later. You can see the good subtalar reduction in the picture. And then I pass one subtalar K-wire to fix the subtalar joint. Then once that, because I have pushed the lateral wall underneath the posterior facet with the same osteotome, then I compress with both hands like this, the lateral wall underneath the subtalar, underneath the facet, so that will give a cortical support. Previously I have tried all other methods including plates, Allen's procedure, bone grafting, void created, all those things we have tried. But now I have come to a conclusion that there is no bone loss, no void, nothing is there. Everything is a jigsaw puzzle. You have to be very gentle. You don't crush the cancellous bone, and you just lift, hold the lateral posterior facet with on the outer cortical side and gently maneuver it, and everything will sit in place, and you can see the reduction through the subtalar joint as well. This will create a bony support for the depressed piece. Also, it achieved normal shape and height of the heel with decompression of the peroneal tendons. This lateral wall can be held in position with the osteotome temporarily. Then I pass a tangential K-wire to parallel to the apex of the cruciate angle. Then another K-wire is passed from the posterior fragment into the inferior surface of the tongue fragment into the inferior surface of the calcaneum. And last wire is passed usually to anterior-superolateral end through the anterior facet going posteromedially towards the sustentacular side, so it will have a medial half of the fixation. So my idea is to have 3 to 4 wires which will hold the calcaneum like a raft, multiple wires holding the multiple pieces. 1 or 2 wires here and there may be added depending on the amount of comminution. Axial view, you can see very good lateral wall reduction, subtalar reduction, all wires are going axially well. One posteromedial wire is also going. Then I close the peroneal sheath with Vicryl, 10 Vicryl. Till this stage, care is taken to avoid elevation of skin flaps even for a millimeter. The skin is sutured. Dressing is done, so rapidly tips. Most common complication is because we have been treating conservatively. I think from 1990 to around 2000 we were treating all calcaneal fractures conservatively. Those where patients were also walking. Most of the times, what I remember in my practice is they never come with subtalar pain. Maximum times they come with peroneal tendon impingement only. So subtalar fusions, for that reasons I have done very few, though there are a number of patients who are having calcaneal fractures is more. Probably the kind of patients I am dealing is may be different from all foot and ankle surgeons must be dealing. I am getting all low or class patients who are workers from fall from building, for painting, and all those are very lower socioeconomic patients who have got very good pain tolerance. Most of them, almost all of them have gone back to work even with conservative treatment. But the keeping a subtalar motion, lateral wall extrusion reduction definitely leads to superior results, and with some minimally this is not very invasive. Since I am using this approach, the soft tissue problems are almost nil. So the key is you should treat this as a So this I am showing even 1 millimeter also. Once you suture the peroneal sheath, there is no even elevation of the skin flap for even 1 millimeter. So that much care we take during surgery. No retractor, no K-wire retractors, nothing. So retraction of the lateral wall along with the skin. So for putting plates and all, we were discussing whether you have to little separate the lateral wall bone from the skin and subcutaneous tissues. Actually, this is a presentation of 2015. So I have also little modified. Nowadays through this engine I am putting small plates, small screws and all. But the aim is I wanted to show you only K-wire fixation. Then careful elevation under vision without crushing up the cancellous bone is important. Pressing the lateral wall under in elevated face creates a jigsaw puzzle in terms of height of calcaneum, lateral wall extrusion, correction of heel varus. Also lateral wall supports the elevated fragment and peroneal impingement is avoided. So all the problems are taken care of. And first K-wire tangential to cruciate angle holds the reduction because that is quite a strong bone. And multiple K-wires have a raft effect. Fixation is not rigid, so definitely I delay weight bearing for almost 3 months, so 1.5 to 2 months partial weight bearing, and then as tolerated full weight bearing after 3 months. In comminuted fracture, some fragment specific wires are necessary. So I initially developed this approach for, it is a low cost approach for poor patients, but with experience and now I feel that it can be done for anybody and it gives reasonably good results. So if the surgical tips are followed, it is easy to give you the pure patient a very good end results. Thank you.
Thank you, sir. May I request next Nitin Patil, sir?
Just can I have a quick point? One point.
Yes.
Nagesh, good presentation. Yeah. So you don't have to be sorry for creating a void. If you have created a void, it means you have elevated it properly, because that is the place where that fragment had sunk. You can be gentle with the posterior facet, but don't be sorry. If you have created a nice void there, that means the reduction is perfect. So don't worry about creating a void, and that void doesn't have to be filled with anything. It will heal by itself.
Shall I? Yeah. So my topic today is outcome of calcaneal plating in displaced intra-articular calcaneal fractures. It was aptly said by Cotton, man who breaks his heel is done. So this is the anatomy in simple words. It is a thin cortex, and you all know about the Bowler angle and critical angle of Gisane, which has to be maintained post-operatively. The thickening of the cortex is seen in the region of sustentacular tali, medial wall, and critical angle of Gisane. This is very important for putting up the screw because the bone is dense over there. So the blood supply of the calcaneus is by the lateral calcaneal artery and the medial plantar artery. This is very important because when you take the incision, you have to preserve the blood supply of that flap. So pattern anatomy, I will not go through this. These are the two fragments. The fracture line runs from the anterolateral to the posterior medial, causing the heel into the varus. And there are asexual two types of fractures. One is the tongue type of fracture, where the posterior facet is attached to the posterior calcaneal tuberosity, and another is joint depression, where the posterior facet is free from the tuberosity. So we always follow the Sanders classification. It has got very good prognostic value, and this is best described in 30-degree semicoronal CT scan, which is which describes the groups as according to the number of fractures, 1, 2, 3, 4, and according to the lines of the fractures A, B, and C. So we studied about 50 cases from 2015 to 24, and the functional outcome was evaluated using a CN score comparing both the pre-post of varus angle, restoration of height, width, Bowler, and Gisane angle. So the radiographs needed were the AP lateral mortise view of the ankle and AP lateral and oblique view of the foot. Also, the axial lateral view of the contralateral calcaneus and oblique view of the contralateral foot is also important for comparing. So the Broaden's view is also important, which is to be taken pre-op also and during operation also. So we have to maintain the height, length, and width of the calcaneus, because a decrease in the Bowler angle indicates the collapse of the posterior facet, and which leads to the poorer results. So these are the usual findings of the radiographs. Because of the depressed fragment of the posterior facet, you can see a double density sign, and you can also diagnose the calcaneus shortening, varus tuberosity deformity, the decrease in the Bowler's angle, and decrease in the calcaneal height and broadening of the calcaneus. So this is a CT scan which helps you in planning the surgery, axial, coronal, and sagittal views. So usually 2 to 3 mm slices should be advised to the radiologist. The goals of the surgery are to regain the length of the calcaneum, to correct the varus, and to reduce the subtalar joint. The timing of the surgery is very important. It should be preferably within 3 weeks. And when the wrinkle site is positive, then only you should operate. You should ask the patient to dorsiflex and evert. And if the wrinkles appear, then he is fit for the surgery. Also, the palpation of the lateral wall of the calcaneus is important because of the lateral blowout of the calcaneal wall, you may feel that the swelling is still there, but it is the blowout of the lateral wall. So palpate it. There should not be any pitting edema. And if the calcaneal pad and subluxar peroneal tendons are seen nicely, then the patient is fit for surgery. So I follow this extensor lateral approach of Sellingsen's. I do it under tourniquet. It is a right angle lateral incision which minimizes the peroneal tendinitis. It reduces the devascularization of the anterior skin flap because we take the incision between the zones supplied by the lateral calcaneal artery and the medial plantar artery, and it preserves the sural nerve also. So let us see one illustrative case. This was a preoperative X-ray. This is a tongue depression, tongue type of fracture. He had bilateral fracture, but he was not ready for opposite side, left side operated fracture, so we operated only on the right side. So this was the CT scan. This was the 3D. You can see the lateral wall fragment nicely. There is a posterior tuberosity fracture, and there is a nice calcaneal varus also. So the patient usually taken into the lateral position, and the Siam position is like this. In this way, you can take a nice lateral X-ray and also the axial view. As Sampath sir has told that don't start the operation before you take a nice axial view. You can see that on the Siam picture also. And I keep the heel separate from the bolster or the bunch of bed sheets because sometimes I have to do the varus of the calcaneus to open the subtalar space. And sometimes if you put the K wires or the Steinman pin from lateral to medial side, if there is something below bed sheets directly below the calcaneus, you might, the K wires might enter into those and might cause the, this thing, might delay this thing, the septic this thing will be damaged. So there should be a full thickness flap which should include the periosteum, and we should not damage the sural nerve branches also. No touch technique should be used by putting 3 K wires, one in the subtalar neck, one in the fibula, and one in the cuboid. So this is the initial incision. You should start 1 or 2 centimeter proximal to the fibula and just anterior to the lateral border of the tendoachilles. At the corner, you just curve it, or you can take it 90 degree also. There is no difference between taking it in curved or in 90 degree. But it should be deep directly up to the bone. It should not be a superficial. It should be a thick, this thing, anterior fragment. Then elevate this anterior flap subcutaneously and subperiosteally also. Then cut the calcaneofibular ligament so that the peroneal tendons are exposed. So this is a diagrammatic representation of how you do that, and then you come to the subtalar joint. So this is how you reflect the lateral wall. If you are able to reflect the lateral wall, reflect it downwards. If not, then remove the piece and keep it in the normal saline. This is how you elevate the depressed posterior facet. You can apply the hook, bone hook, bring it down and elevate it with the periosteum elevator. So sometimes the posterior calcaneal tuberosity prevents the reduction of the lateral facet to the sustentacular talum. So you have to correct the varus, bring that fragment medially, and then reduce the lateral facet to the sustentacular tali. So these are the intraoperative pictures.
So can we hurry up, sir?
Yes, sir. 1 minute, sir. So screw is passed from lateral to medial, posterior to anterior, and cranial to caudal. This is the Broaden's view which has to be taken intraoperative. Nice reduction. The plate is fixed on lateral side. Minimum 6 screws should be put, 2 in the anterior process, 2 subthalamic region, 2 in the calcaneal tuberosity. The closure is very important. 2-lever closure over a homovac should be done. Subcutaneous absorbable suture should be put in a figure of 8 from lateral, anterior and posterior side to the center of the incision, and the skin should be closed with interrupted algo or donative sutures. The skin should be approached, not the strangulation. These are the post-operative X-rays. Post-operative care, as usual. Wound complication, main important complication is wound dehiscence. So, union was 7 to 8 weeks, and there was statistically significant improvement of the pre and post-treatment values of the bolus angle in the operative. Heel varus was also corrected. Summary, this is a life-altering event. Goal is to improve function. There is a risk for long-term morbidity if we don't operate. ORF can give good and reproducible results if complications are avoided. These are another patient. This is the joint depression type. Nice results. Take-home message. Results after surgeries, they are safer only if posterior facet is anatomically reduced and complications are avoided. Young active patients with no medical problems with posterior facet displacement is the best indication for surgery. Sanders type 1, 2, 3 calcaneal fractures are best treated with ORIF with plating. Sanders type 4 primary fusion should be considered. Thank you very much.
Thank you, sir. May I invite the last speaker, Dr. Rohan Singh, to talk on MIS calcaneus fracture. As we are running late, calcaneus, questions we will answer in the workshop. We have got enough amount of time to discuss in the workshop.
Thank you, Dr. Gurunath sir and Dr. Sampath sir and the Solapur Orthopedic Society. So I'll try to be as quick as possible. So I think everybody's covered everything over here, but I'm just going to pick up the few slides which are important for an average orthopedic surgeon, how to get hold of the calcaneal fractures. Everybody knows all the etiogenesis, the pathoanatomy, everything. We have seen it today. All the primary fracture lines, everything, the presentation. How I go about it, simple 2 things. Less soft tissue trauma, splintage, x-rays, 3D CT, elevate, admit, wait for wrinkle sign, operate. Massive soft tissue injury and swelling, span, scan and plan. On a 3D CT, wait for the soft tissue settles. It's a difficult task. Different methods of treatment, everybody has talked about it, cast, surgery, plating, fixators. Different approaches, lateral extensile, sinus tarsi, sustentacular medial, MES, other methods. When did I become a happy surgeon, what we aim to become today? I have been fixing the calcaneum for the last 8 to 9 years with significantly good results. But that one bad patient, when you get that wound dehiscence and he's a VIP or he's a low-class laborer, kills you as a surgeon because you could not do the real job for him. So since the last 3 years, I've shifted to this minimally invasive screw fixation of each fragment on the 3D CT with good posterior facet elevation, augmentation of the alignment of the axial view, bolus angle, and everything which has been discussed, and sometimes no stitches at all in these patients. Comparable restoration results have been seen. What are the advantages? No soft tissue insult, minimal instrumentation, couple of stitches here and there, no wound dehiscence, zero infection, mild homage in the last 50 plus cases, no extensile cuts, no post-op cast, no excessive heavy bandages. Obese individuals who are not fit with a poor hypoglycemic control, more HbA1c more than 9 or 10, I give a slab. Tourniquet is a personal choice. Heavy patients on my side of the north side of the part of the country, very, very heavy patients, obese. I do not want to open too much now. So I do it in the supine position now. Clinical pics of the position and how the reduction looks like. Intra-op clinical picture, holding the valgus of the heel with this towel reduction forceps. That Steinman pin is there to elevate the posterior facet. I'll just show it to you. Just going to run through the cases. Depression of the posterior facet you see over here. Intraoperative pics. The crux is you get that posterior facet up is the most solid cortical bone in the subchondral area which is present in the calcaneum. The senior gentleman just mentioned over here the void. No sorry, be happy if you get the void. If you get the void, it means you have lifted up everything. You get a big chunk of a void over there. Your facet is up. Don't lose that Steinman pin till the end, what you see over here. Keep that Steinman pin inside, struggle a bit for it, nothing comes easy. Post-op x-rays, 4 weeks, you can see everything, whatever has been discussed, whatever the alignments are. 8 weeks follow-up, the posterior facet remains up. This wire, like Sampath sir said, the wire remains out, the patient knows that this wire is there, and I don't have to walk on it. If you walk on it, your surgery will fail, with a strict caution. Clinical pictures, right side is the operated one, left is the normal one. No width, no length, no shortening, no varus, no nothing, comparable both feet. See, these are the clinical pictures. The weight-bearing area looks clean, the non-weight-bearing area has those marks. 8 weeks clinical video, I'm not going to run all the videos, we are short on time. 54-year-old male, agriculture worker, again, depression of the posterior facet, post-op x-rays, good elevation from my side, whatever best I could do. This wire was actually the sustentacular tali wire which has gone into the tali, but it has backed out, but again it remains outside. This is a clinical video, is a heavy patient, again agriculture worker, one odd video I'll just show. And that's about it, he's walking absolutely comfortably. Another case, you see everything down again, lot of combination, again everything has been raised up. Post-op x-rays, 6-month x-rays, 6 months clinical video, very classic clinical video. Why? Because this is just 6 months. This is 2 days before coming. He's a really heavy-duty laborer worker. You can see he's working in the buildings, and he will show and he will tell his assistant that what he wants to do. He was telling him, come and take my picture from the side. He will just show you that I have asked for this. So he can sit down, he can carry out his daily activity. That is the most important part. So, another case, manual laborer, bilateral calcaneus, 24 hours of injury, skin blisters. I had to wait 3 to 4 days after fixation. So you can see the pre-op on the right side, the pre-op on the left side. Again, elevation has been done. Those wires, again, I have learned it from Sampath sir. I keep on seeing his presentations. They are out, as you can see. So the patients know about it. And then all the parameters are there. 6 weeks follow-up. This is after the removal of the wires, 3 months follow-up. Now I know that he has to walk, he can do everything. This is again 3 months follow-up. I don't have a widening, I don't have a shortening. Maybe I look at the clinical pictures and I'm satisfied that the feet are looking normal. They come with a grotesque deformity, and then there's the time when they come to you and say that my surgery was not well or my treatment was not well. Try to get the axial alignment, the shortening, the varus, the width and the length, all these things. 8 weeks clinical video, not going to run it. 24-year-old girl with bilateral calcaneus, history of fall from height, within 3 hours of injury, massive swelling. She jumped out of a balcony due to some social reasons, and I had to wait for the surgery. Bilateral calcaneus, intraop right side. I got a very good reduction. I was very happy. It went on to be like this for the next 4 years. The left side was not done good by me. I accepted it. It was widening. There was depression of the posterior facet. 2 years follow-up. This is the patient. The right side is absolutely fine. The left side is fine. But to my most astounding surprise, 3 days back before coming here, I called her. She stays in England now. And this is her 3.5-year follow-up. I like to show this clinical video with some paucity of time. She walks completely naturally. She's very confident, and she will also sit down and she will show it to you. And I spoke to her and she's very happy. She says she doesn't have any pain. So I don't know what happened on the left side, but I will see in the coming years and probably come again after 2-3 years and tell you what happened over here. Last case, 45-year-old male, 4 months malunited calcaneum injury, severe disability to walk. 3D CT is being done for all the patients. From the word go, with this kind of X-ray, massive pain on the intra-articular aspect on the subtalar joint. I contemplated subtalar fusion, again with the screws. You see these screws are there, everything is fixed up nicely. And these wires, I also keep it transarticular now, like sir had mentioned. Graft has been packed up, intra-op pictures after correction, but I use a sinus star-side approach. All the things, just very minimally invasive. See the joint over there, like sir said, Nagesh Naik sir said, no pulling on the skin. Just debride the joint, radically osteotomize it, put the graft over there, and just fix with the screws, and you will not need a plating again. 2 years follow-up of this patient. I have a 6-year follow-up of this patient. So I'm just going to run through a calcaneal miss live inbox. It's not going to take time. I'm going to just rush through it. It's very fast and quick. So just take this marking of the Stillman pin, 5 mm pin that I take. I use the stab with the pointed side, and then I insert the blunt side inside. So it goes down. I do it very conveniently for my anesthetist. The reason being I have heavy patients, they are dyspneic, they are obese, they are diabetic, there are a lot of parts. So just going to finish, this is the last slide. Thank you. And just run over here. Once the facet is elevated, I'm just easily putting my screws over here. My wires actually, these wires like sir has mentioned, Sampath sir, that I have started putting it transarticular now into the subtalar joint, and I don't remove them. I take the measure in a different way. Indirect reduction methods, easy reduction methods, my movement of the hand is very free. I can get the heel into valgus, as you will see if I'm able to zoom up in the C-arm. So a little bit of manipulation, little bit of compression of the lateral wall sometimes. Yes. So get this thing into valgus. That's about it. Fix it nicely. Transarticular you can see with this indirect reduction methods, and then just go on and fixing them with the screws. And I think once the screws are in situ, you can see the image that everything is elevated. Again, wires are there. That Steinman pin remains there. It's like a kickstand Steinman pin. You keep it there to elevate your posterior facet. So that's about it. Take home message is simple. MISS technique is simple, effective method in an average orthopedic surgeon's hand like me. No wound complications, no cuts, no big scars. Simple ergonomic methodology, comparable satisfaction rates, no hampering the blood supply, no early recovery. Patients can go home on day 1 after surgery. And even some of the patients whose skin is good, they are young, just put a band-aid over there or just apply 1 stay stapler. That's about it, or 2 stay staplers. Don't go for anything else. Happy patients is equal to happy surgeons. Techniques will come and go, but patients will always remain. Talk is always dedicated to my mentors, Dr. G.S. Kulkarni sir and Sunil sir, who are present today in Solapur. Thank you so much.
Thank you, Rohan, Dr. Rohan, for excellent rapid fire cases of calcaneal fractures. With this, we end this session of calcaneal fractures. The question will be taken in workshop. Now, I request Dr. Santosh Deshpande to felicitate Dr. Rohan Singh from Ludhiana. I really appreciate all the national faculties who all the way come from various parts of India just to discuss the cases and learn and teach. Dr. Abhijit, please felicitate our moderator, Dr. Sunil Patil sir. Thank you. Now the most exciting session, that is live ultrasonic examination of patients with various foot and ankle conditions. Dr. Mrs. Vaishali Dumbre Patil is there for the demonstration, and Dr. Ashwini Hulle is there. So I hand over mic to, I request the moderator Dr. Sampath Dumbre Patil, Dr. Nagesh Naik sir, Dr. T.V. Raja sir, Dr. T.V. Raja, I request Dr. Ajay, please. So I hand over mic to Dr. Sampath Naik sir, please.
Dr. Ashwini Hoye madam to be on dais. Dr. Vaishali Dumbre Patil is there on with the patient. What we'll do is we'll interact with them. Let me introduce Dr. Ashwini Hoye madam. She is a musculoskeletal radiologist and backbone of our radiology department. And Dr. Vaishali Dumbre Patil, please come on. And she is musculoskeletal ultrasound specialist working with me. I always give trouble to these both of them because most of our foot and ankle patients are less affording, and we always keep on asking solutions to them with minimum investigations, and then they help us a lot. हे नाही वेगळं हे केलेलं ऑर्थो रेडिओमध्ये हे केलेलं. So what we will do is we are going to show you some live examination if they are ready, and then we will start with some cases. In between we will try to show some positive findings live. So yeah,
so live, both picture in picture you can show both there and here.
Yeah, what we'll do first, we'll take 1 or 2 cases, and then in between we'll sandwich with live cases so that, are you ready with the examination findings? Yeah. What we'll do is first let us start with one case so that actually orthopedic surgeons I can get attention to, and then we'll, because all we are going to learn through cases, then they will have practical implications. कुठला ओपन केला आहे? हां मॅडम तुमचं PPT सोलापूर. हां तुमचं. Yeah. Madam, over to you. Let us start with one case and then we'll go to. Sorry? Yeah, it was same. कुठला ओपन केला तुम्ही मला दाखवा, मला परत ओपन करा तुम्ही. हो पेन ड्राईव्ह दिलेला मी. हा क्लोज करा. डे वनमधून नका करू, मी वेगळा हां नाही माझ्या ह्याच्यातून नका ओपन करू. रेडिओच्या सेशनमध्ये केला आहे 2 वाजताच्या रेडिओचे हां 1 वाजताचं सेशन आहे ना याच्यात केलेलं आहे दुसऱ्या बाजूला हां ह्याच्यात आहे. येस दॅट्स इट. येस हां पहिला. What we'll do is, we'll ask her to start with the case and then we'll discuss as an orthopedic surgeon what we are going to do. That will keep it more simple. Yes, over to Madam Ashwin. Yeah, you can start. Okay, so he is a young male who met with the two-wheeler accident. Now, this is the X-ray. So, how do we go ahead? Do we suggest some more investigations? Do we do something more? Nagesh Naik sir, any? Let us keep it interactive because we are going to learn through these cases.
Looking at the spiral fracture, this is an external rotation injury.
Yes. So, any other information we will require, sir, or we'll go for the fixation or
even I have done CT. No.
Sorry?
Have you done CT?
Do you want it to get it done?
Can try, because this appears to be a low velocity injury, you can try some stress X-rays to see status of the medial ligament or something.
Okay, so Floor, do you agree with Naik sir that you will require to do stress views, or anyone like to go for CT scan? Stress views? Okay, yeah.
No, there is proximal migration of the fibula. Na? So once you bring it down, probably it will become parallel.
Yeah, again to note this proximal migration, let us see the lateral process of talus. Usually, fibula should match to the lateral process of talus. 3 to 4 mm of migration. Yeah, so as TV Raja sir has said, lateral process of talus should match the tip of fibula. So probably it is a proximal migration. So
base of fifth is an old one.
Sorry?
Base of that is an old one.
Probably old one. Probably old one. But what most important is this. This is Kotadia sir's case where he sent me video like this. Okay, that video may not. Yeah. It is very unstable. Very unstable. Even that stability itself was so this thing that clinically patient was speaking more than what radiologist speaks. So then in those cases we do advocate to go for some more investigations as stress views and all those things. So Ajay sir, in your institute, he is in one of the most elite institute. You feel that it is unstable. Dr. Swapnil Kotadia sir sent me video that he was almost dangling it like that. What you will advocate? Stress views, MRI, CT scan? Please speak in the mic.
Because we need to see which are all the ligaments which are damaged in that case.
You can see by ultrasound.
You can see by ultrasound also, no?
Okay, so we have done MRI and now over to you, ma'am.
So on T2 axial images, we can see that the anterior syndesmotic ligament and the posterior syndesmotic ligaments are injured. There is a complete full thickness tear. Also, the distance between the distal tibia and fibula has increased. Coming to the next image, there is also full thickness tear of the deltoid ligament.
Yeah, so this much we should read with them, and in fact, we have to give them inputs. It is not that it is a rapid fire for them that we just send for MRI and they answer everything to us. Every case I go to her, I will tell what are my findings, what I do expect. And as an orthopedic surgeon, we should be interested not in ATFL. ATFL is one of the commonest ligament, but most innocent because hardly we are operating on ATFL fresh. But what we are interested is AITFL, which she has beautifully shown. PITFL and deltoid, isn't it? These 3 ligaments, madam, will you just show us again those ligaments? Yeah.
So we also have next slides in which we will be able to see the ligaments.
Okay,
so one would know how normally it looks like.
Because here they are torn and she will not be able to show us, so I agreed. So here anterior inferior was gone, posterior inferior was gone, and deltoid was gone. See, we will discuss in our ortho meet where whether I was justified not doing deltoid, but here I did not do deltoid. I just fixed it indirectly with the two syndesmotic screws. Patient is absolutely happy. But while doing so, when I did not do the repair on medial side, I did post-op CT scan. Got it? Here in Solapur only we have done it. So post-op CT scan done. Good reduction of syndesmosis, medial space was also good, and we are happy to not operate on medial side as well when reduction is concentric stable. So not always all deltoid ligaments will require this thing. In this case also we were ready to do it, but fortunately we got good concentric reduction, stable one, and post-op also we proved it that it was good on that part also. So this was it, that was one case. Now another lady, she has she just fell down from 2 to 3 feet height, and this was X-ray. Sham sir, she just walks into our OPD with this X-ray and was diagnosed as an ankle sprain. Anything different you would like to?
Looks like there is a posterior mal displaced. So I mean,
you mean
to
this one?
Could be. And I would definitely like to go ahead with stress X-rays.
Stress here. Yeah. Naik sir says that middle joint space is little wider. Any other inputs? Anything different? Now, yeah, as Naik sir has mentioned, medial joint space. But what was more important is let us obtain clinical input. She was not able to wet bear. She was hopping. She was hopping like this. Her gait was not steady. So it was more than what X-ray was speaking. And look at this. Look at this. The complete, if you have a complete evaluation, see this, what I was talking about in Girish sir's case, proximal fibula fracture. Now this is something more than what it was showing on X-ray, isn't it? Whole proximal fibula gone. So see this force which has entered from here. This is gone. This is gone. AITFL, PITFL gone. And interosseous also gone. It has gone up there. So it is more than what the X-ray was showing. So it has to be anticipated. Now Sham sir, what investigations you will do in here?
MRI.
MRI.
Yeah.
So on MR, like we saw it in the earlier patient, we can see the part of the anterior syndesmotic ligament, and there is a defect in between this which shows increased PDFS signal intensity. So there is a full thickness tear of the anterior syndesmotic ligament. The posterior syndesmotic ligament is bulky. In the earlier patient we were not able to see even this much, and also there is detachment of the fibers at the fibular attachment. So this is a near complete full thickness tear of the posterior syndesmotic ligament. Now coming to the deltoid ligament, we are not able to see the deltoid ligament at the medial malleolar attachment. So there is also a deltoid ligament injury.
So nicely we can obtain this information from them that, so nicely, can we go one step? See, nicely she is able to show us this, but she is not confident about this because she is able to see posterior inferior tibiofibular ligament. But this is nicely seen, isn't it? This much of information is very vital, okay? But what they do, I am fortunate to have them there because they do limited CT also. How many of us, when we just send it for MRI. Now, just look at this. They give me this information as well. And can you imagine that this was not anywhere seen here? Anywhere. Now, why she was correct here? Because PITFL is seen. It is not seen torn. But still she could not see it complete because of this information that PITFL is intact, but it has been intact with that posterior malleolar fragment which is little detached. So much of information can be obtained, and that's why we have to interact with them. We have to give inputs, our inputs that look, man, she is very unstable. This lady is very unstable. AITFL is gone, but if PITFL is intact, then it should not be that unstable. So she gave me input, sir, even posterior malleolus is gone. But then they will do CT scan free for you. If you send MRI, limited cut CT, they will do free for you because it is not the complete sections they want to take at where you are interested in. So MRI right ankle. So my request to them is MRI right ankle. But then I will draw a simple diagram and I will just get them this thing that okay, this much area I am interested. So even they will take CT scan without charging the patient, but this much is good information we can obtain. Because how many of us will write right ankle MRI also and right ankle CT scan also? Because patient will not afford that much information. But definitely it is going to help us for management, isn't it? Because now we know she has clearly shown us that AITAFL is gone, PITAFL is gone, and probably deltoid is also gone. Definitely it is going to change our approach in treating this thing. So please get the inputs from them. Again, after this we will go to the sonography part. She is a 26-year lady and this was the injury. She just fell from two-wheeler. Mahendra sir, we will not allow you to chat. So this was a 26-year dentist. She just had a fall from two-wheeler and she was in casualty. She was making so much of noise because of pain, and our registrars were saying, sir, this is just a simple avulsion fracture, but she had a lot of pain to that extent that she was given analgesics, intramuscular analgesics, IV analgesics, but she continued to have pain. And this was her X-ray. Slab was given. This was her foot X-ray, ankle X-ray. She was having pain everywhere, sir. She was yelling in pain. And my registrars gave me information that she has low tolerance. She has very little bit, more pain, but nothing is there. They could not find anything in the ankle X-ray, here in the slab, and even on the foot X-ray. Anything there, but tremendous pain. Of course, she was yelling out of pain. All around there. Yes, sir. There is a tip fracture. Yeah, there is a tip fracture at the lateral malleolus and the medial malleolus. That was what information was obtained. But having seen only the tip fracture, this much pain was not expected.
Has the talus rotated there because
TV Raja sir says that is the talus rotated. I will show you the foot X-ray also, sir. No, neurovascular was fine, sir. What do you do, sir, then? If you suspect, what do you do? CT scan. So, actually, I did CT scan and madam looked into it.
So on coronal CT images, the ankle joint seems to be fine. There is bimalleolar fracture. There is also subluxation of the calcaneocuboid joint with the lateral subluxation of the calcaneum and inferomedial subluxation of the cuboid. If we look at the talonavicular joint, it looks fairly normal. But if we do take the 3D reconstructed images, we see the more grave injury. So this is the coronal image and this is the oblique image. On oblique image, we can see that there is a talonavicular subluxation. The talus is rotated posterolaterally, whereas the navicular is rotated anteromedially, and rest of the midfoot and the forefoot is following the pattern of the navicular. Also, there is subluxation of the calcaneocuboid. We can see it on these superior images that there is subluxation of the calcaneocuboid with inferomedial subluxation of the cuboid. There is a fracture of the cuboid, a small fracture of the calcaneum, and also fractures of the navicular. And the ankle joint in the 3D images looks normal in this present scan.
So I agree with, yeah. So I agree with Dr. TV Raja sir, Venu Sambaram sir, that they were suspecting something wrong in the subtalar rotation or talar rotation. And look at this. This is absolutely what she has spotted on, see this, if this much you can subluxate here, equally it should subluxate here also, isn't it? Talonavicular part also. And I will show you beautiful video. See this now. Talus is absolutely rotated. Talus is looking somewhere else. Midfoot is literally dislocated. Midfoot is dislocated medially. Talus and this thing is looking at laterally. Can you imagine? So she had that amount of pain because of all these things. So how do I proceed? Then I thought that okay, I should go ahead and do the fixation. But will you do something else in this? Vascular was fine, sir. Vascular was fine. So, yes, perfect. That is what we failed to look. It was inward, this thing, like this. So this is this is the position in which if it is there, it is not a good thing. So what?
You reduce it. Initially, primary, you reduce it. After that, you take it for fixation.
Yeah.
Immediately, you reduce it.
So, correct. So that's why we did CT scan and we were posting her for the fixation. Now this pain was so severe that she had a complete displaced lateral condyle fracture of knee, which was 2 centimeter down, but she was not complaining of knee pain at all. I thought this is not good then, because one joint up and one joint below I said, madam, did you have any fracture before? She said, no, not at all. 2 centimeter depressed fracture of the lateral tibial plateau and she was not complaining of pain. I said, this is something different. So I asked madam to do MRI also. Yeah, that was old. And yeah.
So on the axial PDFS images, there is a complete full thickness tear of the anterior talofibular ligament. Like we saw it in the earlier patients, this is the anterior syndesmotic ligament and the posterior syndesmotic ligament. The posterior one is normal. The anterior one is showing some sprain. The attachments are normal. It is just slightly bulky. There is a near complete full thickness tear of the deltoid ligament. It is showing loss of its normal striped appearance, and it is also bulky, which shows increased PDFS signal intensity. This is another coronal image where we can appreciate that the deltoid is significantly bulky with increased PDFS signal intensity, and this is our spring ligament. It is normal in its attachment, but the superior portion is looking edematous with increased signal intensity. So if we look at this tibialis posterior tendon and the flexor digitorum longus tendon, we can appreciate that the thickness is almost 3 times more than the normal, and there is mildly increased hyperintensity. Where we take it to the next section, just caudal to the section where we are able to see, there is bulkiness of the insertional fibers of the tibialis posterior tendon at the attachment of the navicular and the medial cuneiform, and also we are not able to see this attachment. So there was insertional tear of the tibialis posterior tendon along with the lateral and the medial ligaments of the ankle joint.
So many positive finds were there. ATFL gone, CFL gone, deltoid gone, tibialis posterior gone. Can you imagine? And how it helped me in the case, I tell you. So Raja sir, as you mentioned, I went ahead, I reduced the midfoot. I put across the K wire across the subtalar and talonavicular joint, and then see what happened. I made foot as a 1, and now it started dislocating through this. Fortunately, I was knowing it before that she had done MRI, because if I would have done MRI after the K wires, I would not have been able to do that. Fortunately, I was knowing that everything else was gone. See, it started dislocating because I made foot as a 1 unit, and then everything else here was gone. ATFL, CFL gone on this side, tibialis posterior and deltoid gone on this side. So it started dangling. So what I am giving you the message, how much to investigate and when to investigate. It is not that every time we are going to send the patient for CT also, MRI also, but clinically do suspect. And that's why I always say patient speaks before investigation speaks. So correlate well. If I would have done only CT scan, fixed it, I would have been labeled as intraoperatively you have done that. Isn't it? Because I was not knowing, I would not have confidence that why this happened. And even in slab and cast, it was not stable because there was nothing medially, there was nothing laterally intact. Tibialis posterior, which was most important medially, and deltoid was gone there, and laterally CFL, ATFL, so everything else was gone along with the anterior inferior. So although not common scenarios, but think of it when the things are not going straight as the way you think. Yeah, so even midfoot injury is uncommon but commonly missed. See this would have been. No. She would be taken care for this thing. The recent case, she is now building up with the treatment modality. I am just showing you how to investigate, because investigation itself, how much to do. Every time you are not going to do CT scan, every time not you are going to do MRI, but how much to do, when to do, you have to read the injury with radiologist. Yeah, are you ready with some ultrasound findings? Yeah. Are you going to project here? Yes. Please. We have few more cases where we will cover all the topics of trauma and collar mic ka hai. Please switch on her collar.
Good afternoon, everyone. Thank you very much for inviting me for the trauma meet. I will just go through different structures of foot and ankle which are very well seen on ultrasound with high resolution probes.
Please go ahead.
Yeah. Just few things about the orientation of the image so that it will be easy for you to understand. This is always the anterior aspect of the part to be scanned. This is the posterior aspect. This is the proximal aspect, and this is the distal aspect of the image. So this is the ankle joint. I am scanning the anterior compartment of the ankle. This is the ankle joint. This is thin black line is the cartilage of the ankle. So whenever there is ankle effusion, we are able to see some fluid over here in the anterior races. So even small amount of fluid can be detected on ultrasound. Even the synovial thickening with inflammation can be seen on the ultrasound with color Doppler imaging. This anterior structure is the
Can you just wait
tibialis
here?
anterior.
Yeah, can you just wait here?
Yeah.
This inflammation is so important so many times in foot and ankle. ESR was normal, CRP was normal, RA factor negative, anti-CCP negative. With persistent inflammation, we gave inputs to rheumatologist, and with disease modifying agents, patient has dramatically improved. So these inflammatory markers, they are helpful for us so many times. I will show you a number of cases when she is going to switch over to presentation. We will show this is very important. Give inputs when you are not finding. We have found out so many positive finds with only ultrasound, which even MRI sometimes we are not able to appreciate. Please go ahead.
So this is the tibialis anterior tendon in long axis. Whenever there is fluid, we will be able to see some black line. Black is always fluid in ultrasound, white is always bone, and the soft tissue structures are in between the gray shades. So whenever there is fluid, we will be able to see along the long axis. Here in this case it is normal. Now this is short axis images, that is transverse images of the ankle. This is tibialis anterior tendon. Anterior tibial artery and veins. Again, this is the ankle joint. This is tibialis anterior muscle.
It is very helpful tool to even trace the nerves. Very helpful because a few times I showed you my the tibial plate upon posterior malleolus was irritating the tibial nerve, which I had to remove, which she can trace and show me very nicely.
Now the structures along the lateral aspect of the ankle. This is the fibula. We are seeing the transverse images. Peroneus brevis tendon, peroneus longus tendon. Now I am at the proximal level. I am going down. This is fibula. I am on the posterior aspect of the fibula. These are the peroneal tendons, peroneus brevis and longus. These are the two tendons. Now I am at the distal level. And see the long axis view of peroneus longus. Till the insertion we can see.
Just a minute, hold on here. So many times MRI report you will see, madam will also agree, so many times magic effect will show that MRI peroneal tendon tears are reported. It is better to cross check with ultrasound because of the acute angle. They may see signals like tear. So that is called as magic angle, where so many times it will be reported as the peroneal tendon tears, but then it is worth to evaluate with dynamic sonography to see the peroneal tendons.
Yeah. So this is the peroneus longus tendon, which is absolutely normal in this case. Peroneus brevis, this is normal structure, very shiny fibrillar structure. So whenever there is fluid, we will be able to see in this peroneal sheath. We can also evaluate dynamically the peroneus dislocations in this view. I will share you one case while doing the presentation. So this is longus, this is brevis. Till the insertion we can see, which is absolutely normal in this case. इकडच्या साईडला झोपा. बस.
Now, medial side evaluation of tibialis posterior tendon is most important because so many times early stage also we can catch hold of the tibialis posterior tenosynovitis.
Medial compartment is very, very important. The first end, this is medial malleolus. We are seeing the cross section image, the transverse image. The first tendon we are seeing is the tibialis posterior tendon. This is the cross sectional image. And this is the long axis of tibialis posterior. This is the long axis.
Just hold on there. Naik sir was asking, when you see the tendon, you can actually see the quality of tendon. So this helps me to take even decision while Achilles rupture repair, whether what is the quality of tendon, how much is the degeneration, what is the fibrillar, now showing us good fibrillar orientation. So it can show us the not only tenosynovitis, it can show us the degeneration, it can show the quality of tendon as well. Please go ahead.
Yeah.
Yeah, it is.
So this is the tibialis posterior tendon, the first one. Just next to it is FDL tendon. Again, this is long axis, EDL, very normal. This is the normal ecotexture. And whenever there is fluid or synovial thickening, we can very well see along the long axis. This is the normal structure.
Any positive findings in this site? Otherwise, we'll like to see Achilles and see your positive findings.
We'll just finish the medial compartment. These are the posterior tibial vessels, and very important is the posterior tibial nerve here on the posterior aspect. This is normal honeycomb appearance of the posterior tibial nerve, very nicely located on ultrasound. Falta zopa petkan, falta zopa.
We'll like to see Achilles normal
Khali sarka,
and
khali
plantar
sarka,
fascia.
khali sarka.
Now evaluating heel pain with plantar fasciitis, again I will show you through cases that we have so much of inputs from their side, inflammatory markers in plantar fascia, and so many like plantar fibromatosis, so many different conditions we diagnosed only with ultrasound.
I will just show you the normal structure of Achilles in this case. This is proximal part, Achilles. Now I am going distally. This is the Achilles tendon. It is very nicely seen because very superficial. This is the Achilles. This is the normal structure. See, this is the posterior aspect of the calcaneum. And this is the insertion of the Achilles.
And this Achilles anatomy is very important because in a ruptured Achilles, I would like to see if the Achilles tendon is normal. If it is degenerated, it is like putting sutures through that degenerated tendon which is just waiting for to fail again. So that time you have to explain the patient that look, I have to excise this much of tendon and I will need probably FHL transfer or not. That pre-operatively we can see. So don't only read the report that there is Achilles rupture. No, you have to ask her many questions. What is the quality of tendon? How much is the gap? Dynamically, how much gap can be closed? These many findings you should ask your radiologist.
This is the anterior aspect of the Achilles. This is the posterior aspect of the Achilles. This is the calcaneum, and here we can see sometimes here we can see fluid in the pre-Achilles bursa also. So this is the normal structure in this case. This is the soleus posteriorly, and this is the tibia, posterior aspect of the tibia we are seeing in this image. The sural nerve also we can trace. Very superficial.
A nice sural nerve can be seen. So many times Achilles repair is done and sural nerve is entangled in it. We come to know it. So you can, if you are doing percutaneous way, it is better idea to mark it with ultrasound. Sunil sir was there. Sunil sir, he does lot of percutaneous. So it is worth if he has ultrasound in his civil hospital, he can just mark the sural nerve so that percutaneous way you can do it.
A very nice marker for the sural nerve is
that is a sural nerve.
Yeah, this is the SSV. The black round thing which you are seeing is the SSV. This is the fish mouth appearance to locate the SSV, and just next to it is the sural nerve. Very small, very small.
Fantastic. Yeah.
Yeah, this is the sural nerve. Just next to the SSV is the sural nerve.
Yeah.
Here.
On the posterolateral aspect, can we see perforators for the peroneal perforators on the posterolateral aspect? Doppler.
On Doppler, yeah, on Doppler we can see.
Yeah, there only, there, little down.
Here.
Yeah. Yeah.
This is the sural nerve. Just next to the SSV.
But peroneal perforators and all that anatomy we can map very well on this.
And we will have to scan with different probe. This is for the MSK.
Okay, can you just quickly show us the plantar fascia and we'll go to the presentation?
Yeah, sure. Sarah Zopa.
Just show us the plantar fascia.
Yes, Sarah Zopa. पाय सरका मागे सरका वर जा.
We can very well see the anatomy of plantar fascia because so many times we just label it as a plantar fasciitis. They can measure that thickness and compare it on opposite side as well.
This is the plantar fascia. This is the plantar fascia. And this is calcaneum. The white border we are seeing is the calcaneum. This is the plantar fascia coming here and getting inserted. Please. Yeah. This is the insertion of the plantar fascia.
And they actually measure the thickness of plantar fascia insertion at the insertion site.
Yeah. This is the plantar fascia which is getting inserted over here on the calcaneum.
And in inflammatory seronegative pathologies, we will get a lot of inflammation over here. And we just give that input to this thing. Yes, sir. Yes, there are studies where they do it thickness wise. We will come to it. We will just finish this. Yeah, thank you. We have done with the.
We have done with the normal anatomy.
Yeah.
I will see. Next, I can show you the Achilles tendon.
Achilles tear. Quickly show us the Achilles tear if patient is ready.
Yeah, patient is ready.
In this Achilles tear, I will show you how do we do the decision making.
No, this is a chronic tear.
Yeah.
हाँ पाय असं करायचं असं ठेवायचं. Now I am at the proximal level. This is soleus. This is Achilles tendon. This is Achilles. I am going distally. This is Achilles. and see how the echo texture is different at this level.
Yeah.
Till here, the Achilles is absolutely normal. This is the posterior aspect of tibia, calcaneum, and here suddenly it is, the echo texture is totally changed. These are
Yeah.
calcifications in the calcaneum. Here
See,
there
this
is
is
no.
this is how we identify what is wrong with the Achilles tendon. So this is healing or tendinosis part of it, and there will be partial tears in this degenerated tendon only. So we don't expect those tendons to do well just with the direct repair, because she has showed us a lot of calcification, and see the thickness and see the fibrillar orientation of that Achilles, which was absolutely thin proximally. Distally it has widened, it has thickened, and it is showing calcification as well.
See the difference? This is normal Achilles tendon. This should be the thickness of the Achilles tendon normally. Here it is so much wide with calcifications in it, and here there is no normal, we cannot see normal echo texture of the tendon.
Perfect.
So this is all torn, this thing, Achilles tendon with fibrosis, bridging fibrosis.
See, now if this is structure given to you for repair, you do expect that I am going to excise this much a portion, and probably if it is less than 3 centimeters, I will be able to close gap by some mobilization protocol. If not, I will have to tell him about the FHL, isn't it? If at all you are thinking of operating on this. So it is not tear yes or no, rupture there or not. It is all about seeing so many other aspects of the tendon itself. Yeah.
Here we can see some amount of fluid in the pre-Achilles bursa.
That's good.
And this is the abnormal tendon.
Abnormal
See the
tendon.
comparison.
Yeah.
This is all big calcification here
Yeah.
with fibrosis.
Very
and the
nice
insertion.
seen, and that is why we need to interact what you want from your side as a surgeon. Otherwise, they will just keep on reporting rupture seen this much centimeter up or not. But it is the quality of tendon, amount of degeneration, how much length it is there. If it is torn, whether it is been replaced with the fibrous tissue. If not, then how much is the closure of the gap. Thank you so much. Let us come back to the presentation here, and you can also show your positive finding through the case. Probably it is healing.
Chronic. It's chronic.
It is healing with fibrosis. Yeah. So, sir, this is actually tear in degenerated tendon. So micro tears keep on rupturing, again fibrosis, again rupture. So, yeah.
It is basically tendinosis with degenerative changes, not actual tear we are seeing. It is already bridged with the fibrous tissue.
So these are chronic ruptures rather than acute rupture. Can you go, yeah, please. Now, this case, he is a young doctor and he has a fall while running. Any inputs on this? Widening of the first, second, this thing, isn't it? Yeah, intercuneiform. This is this. Yeah. So morning I was showing you. We will so for the want of time we will just go rushing through the cases. That is what we wanted. Now what we will do? Probably these are standing views for comparison. This is the uninjured side. This is injured side. You can see what is the difference, isn't it? Diastasis, isn't it? Now what you will do? Any investigations? Any further investigations for him?
That's what I was asking, whether really every time you have to do CT scan or MRI.
Yes, you tell me, sir, what you will like to see. And why? Because if you advise investigation, you have to read it. Don't leave it to them, because then they will give you an answer. But what you are looking for, that also you should tell them. Okay. Madam, did we do MRI or we did CT first? Yeah, please go ahead.
So the patient initially had come to us and we did the CT because he had a fall. And later on standing X-ray, so there was this increased distance at the medial and intermediate cuneiform as well as the first and second metatarsal, also the medial cuneiform and the base of second metatarsal. So then the possibility of Lisfranc injury was raised and the patient was sent to Sir. So then we did the standing X-ray, and after that Sir sent the patient to us again for the MR. So on MR, so this is on the right side, so on the left side, this is the normal foot and this is the abnormal foot. So first we'll look at the dorsal component of the Lisfranc ligament complex, which is going through between the medial cuneiform and the base of second metatarsal. I want everyone to have a look at the normal signal intensity and the thickness, and this is also the intercuneiform ligament present between the medial cuneiform and the intermediate cuneiform. Now we know what a normal looks. We can compare it on the abnormal side and we are not able to see the ligament on the other side. So this is a complete full thickness tear of the dorsal component. Going one slide below, we have the interosseous component. Again, we do the same exercise. We look at the normal side. This is the interosseous component. We will see the signal intensity and the thickness of the ligament. Going to the abnormal side, we are not able to see the ligament. Also, the distance has increased. So there is a complete full thickness tear of the interosseous component. Going to the most important ligament, that is the plantar component of the Lisfranc ligament complex, which is going between the medial cuneiform, the base of second and the third metatarsals. We can see the morphology, which is quite firm, and the signal intensity, it is normal. Coming to the opposite side, we are not able to see this ligament component, which is again suggestive of complete full thickness tear. So with comparison to the abnormal and the normal side, we are more confident about the ligament injury with more confidence, and likewise the further decisions can also be taken.
Now see, they have, yeah.
Now this information actually we had from the X-ray also. No fracture but the widening, so must be the ligament injury.
Yeah. So, yeah, correct, sir. So
is it essential in everything? Because this we could infer from the X-ray itself.
Absolutely. So it is not must. He was doctor and he was not convinced that this much was required. But more than that, what I discussed in the morning, just see this, sir. See this. Again, don't miss on to this. Navicular, this is a facet for first cuneiform. And everybody of you agreed that there is a diastasis here. But mind well, second is in place, first is moved. Usually what happens? First is in place, second moves. This is other way. See what has happened. Whole first ray, phalanx, metatarsal and cuneiform has slided over navicular. That is what I wanted you to see. See this. This is navicular. This is navicular on normal side and cuneiform is 1 centimeter inside. And see here, this is navicular and it is in line with it. Got my point? So don't miss on to this. And usually we miss on to MCL and fix the ACL. This is like that. If I fix on to the second, it is going to fail. It is going to show me abduction just because I have not corrected medial way. And morning I told you about the under contour plate. Shiv Shankar sir was there. I will just show you, sir. See this, what I did. See this. First screw is this. First screw is this. First screw, only one unicortical drill here. I am not going to penetrate joint. Second screw this. Straight plate. See, it has taken that first cuneiform inside. Go, yeah.
In this case, if you have to alone a screw from medial cuneiform to medial cuneiform, because the ligaments of those are ruptured, rest all others are intact. So is it not good to pass only that screw and the Lisfranc screw?
Yeah, that is also good, but amount of buttressing this gives, no sir, that alone screw will not give, that will give. But this buttressing, you see, no sir, whole medial column has been sucked there. See this, I am aligning this to, I am aligning this to navicular. You are talking about that screw that will take only here, that will take here. But I want length also, it has slided proximally. Cuneiform has slided proximally and medially. Whole this unit has slided proximally and medially.
We can actually compare the first and second metatarsophalangeal joints also.
Absolutely. Absolutely. Now you got it?
Just slide it down.
Now you got it? So that's what I wanted to impress you, that so many points can be learned. That this is not only this part. See, on the contrary, probably this was in place. and this everything has moved. So while reduction, what I did longitudinal traction first.
Yeah, here you can see that the keystone is there on the.
It has to, see no, so that's why it has to be first. And again to answer your question, after that, do I need Lisfranc MRI? I answered, okay, yes, this was also injured. So I needed to go there also, but not in that aggressive manner by putting plate and all those things. I just put this particular home run screw. This is called as home run screw. Usually after that, if this was a primary, this thing which was going down, I would have put a dorsal plate as well. But see now, this is a one post. I have created this post, and then this screw which is taking care of the second TMT joint as well. Got it?
The length is still, you feel that a bit less than if you compare the method.
No, this has to be long, sir. This has to be always. Second is always longer.
Okay, but still.
No, you will not say unless you compare with the opposite side. Yeah. So I just wanted to impress that first column has to be, yes sir, first column has to be. No, that is different, that is different view, sir. It is absolutely good. We have got different distinct, but that is good one. It is not exact distinct because it was probably taken in some different angle, but it is good because we have got good follow. Yes, sir. Yes, and proximally. Here, see. But after giving longitudinal traction. No. But I'm taking hold here. And it is under contoured plate. That's what I was showing in your case. It is under contoured straight plate. It is going to be sucked towards this. Plate is going to suck towards the second cuneiform. Plate is going to pull towards the second cuneiform. See this, sir.
So what he wants to say is that the navicular should be a bit lateral to the navicular tuberosity, the medial cuneiform.
See,
by straight plate they will come in the same line.
Yeah, no. But this screw is going to pull it, but this and this is going to drive this inside first. It will. No. Yeah, but till that time I am holding on this with the towel clip also. I am holding on. See, first I gave longitudinal traction. First we have given longitudinal traction so that length is correct. Then we are holding this with the towel clip as well. But do not counter the plate. Keep it straight. This screw first, and then this as an interfact screw to get the compression. Nine.
Here you should lock here. So it will not move.
Yeah.
The question is, once you put the plate, both of them will be able the same because you are telling that it has to be at least 1 centimeter inside.
Yeah.
So by putting that plate, you are pulling it more laterally.
No.
You should bend it a bit.
No. We are first giving longitudinal traction, sir.
Anyway, we will accept that. My question now is, when you are going to remove this implant, or this implant removal is required or not?
Sorry?
Whether you are doing the implant removal or implant removal is not.
I will do implant removal only if it breaks or irritates. Otherwise, it will take long time for fibrosis. It will take long time for fibrosis. I will not remove in 3 months or 6 months. At least 1 year I will keep. And about that question, sir, one case which we have seen, when it is projecting out, people tend to counter the plate. That will definitely not help. Then that will keep them out. That is what I am saying.
If you would have countered it slightly medially, probably the distance between medial and medial cuneiform.
But yeah, that is what it has happened in one case. You counter it like this, but then it will keep on medially only. It will not push the medial cuneiform laterally. It will not push the medial cuneiform laterally. And it is not only the plate which is causing. we have to give longitudinal traction, we have to hold. Compressed with the towel clip. Intercuneiform. No. Intercuneiform instability. Wind out.
स्वप्नील सर नंतर जेवताना डिस्कस करूया.
Okay. Yeah, I will just go through one more case and then we'll go to the ultrasound. Madam, I will just give her. I will just present last case. This was an engineer who fell down in who had an sinus which was draining for 1 year. He was operated twice. History was he was an engineer and he stepped on a nail and nail was removed, khira kadla, but this was explored twice, but it was not healing, sinus was not healing. So X-ray was NAD. When we did ultrasound, she showed me some track which was visible, and MRI and CT scan was done. Now, this was MRI picture.
So on this T2 sagittal image, there is a hypointense area. This was the foreign body, and there was also a lot of soft tissue around it. The bones in the region, that is the intermediate and the lateral cuneiform, we can see it better on the coronal images. They were showing bone marrow changes. So as we go on to the next image, we can again see the foreign body here. And on this coronal image, there are, see if you look at the normal bones, these bones are showing abnormal marrow signal intensity, with adjacent soft tissue is also showing hyperintensity. On CT, there are areas of small lytic areas with cortical irregularity, and this was the hyperdense foreign body which was seen. And again, like what we saw it on the coronal images, this is the CT image of the same, where we can see the cortical destruction of the bone and few small, if we look at the normal density of this, of these bones, then in comparison to that, there is increased density of these bones with some lytic areas.
So actually, this was reported by them as an osteomyelitis looking at this, and we were also not sure what it was. Twice it was explored, and third time we were exploring, and to our surprise, there was an impacted sole of the shoe, which was in the cuneiform. Impacted sole. So this is a common injury. After this case, we have done 5 cases. What happens is, खिळा बुटातून आत घुसतो, खिळा काढला जातो, पण तो खिळा जो सोल कट करतो ना, तो सोल आत राहतो. It is very well established injury. So I purposefully presenting this because so this is possible because this happens so many times. They come to you and we take X-ray and we say that nothing is remained inside. But think of this particular, after this we have done 5 cases. All those cases we have mounted here, but for the sake of time we will not present it. But see this they were correct. This was reported as osteomyelitis, and this was so deep from plantar aspect, that was at the height of arch, second cuneiform. It took me a while. I took plastic surgeon with me because there was neurovascular bundle. Even he gave up. I said, no sir, there was a track going on, let me explore. And this was my artery forceps. I had to palpate that particular, this portion I had to palpate. And that time when I was palpating, I was not able to see. I could feel some rubber-like thing. And when I removed, this was see this. And I showed that engineer, was this the shoe? He said absolutely same. So we curated out that particular part, because on Siam, then I made it clear that I was into this only, and it has healed now almost 3.5 years. That time I did not, but then later on I started putting on biocomposite. Okay, so this was interesting finding, and keep it in mind, खिळात घुसल्यानंतर चप्पल घातली होती का विचारा, because then it is going to leave some foreign body inside, because तो खिळा निघतो, foreign body आत राहते. I am just going to end by showing some positive ultrasound findings. आपण बाकीचे विल स्किप. अल्ट्रासाउंडचं फाइंडिंग हे करूयात आणि विल जस्ट रॅप इन 3 to 4 minutes. Just show the cases. It's the mic. Just go through cases.
Yeah, we'll just go through some cases. This is 35 years old lady with Lisfranc fixation was done, and she was complaining of post-operative
This was done by
pain.
me only, and this everything looks all right, but she had severe pain, and we did ultrasound. Go ahead.
X-ray was satisfactory. Cursor, yeah. This is the tibialis posterior tendon, and this is the tip of the screw. This is the tip of the implant. We did dynamic movement of the foot, and we were seeing that this tibialis posterior tendon was getting irritated because of this implant.
And I had to remove it, see, because previously I went little bit more down. Rather than horizontally, my screw direction was little plantarwards, and so this length looks adequate, but since I was plantarly out, it was irritating the tibialis posterior tendon, and she was getting the pain. So
yeah. Here it was getting irritated. So USG helps us to know the pain generator. This is again post-operative patient. 50 years old lady with trimalleolar fixation was done, and she was complaining of paresthesia on the plantar and medial aspect of the foot. So X-rays were satisfactory. This is the posterior tibial nerve, and same here, this posterior tibial nerve was getting irritated because of the tip of the screw here.
My plate was proud. This was again my case, irritating the tibial nerve, and she had typical burning sensation there. So I had to confess the patient that, look, I'm proud there, I need to remove it.
So has this changed your positioning of the plate?
Yes, that's why morning we talked about that. While going medial to midline, it should be very low profile implant. This was little thick plate, anatomical plate.
This is 22 years old boy, presented to us 6 weeks after the injury with heel scar on the medial aspect of the midfoot. He was complaining of paresthesia along the plantar and medial aspect of the foot. On ultrasound, I could trace the medial plantar nerve. This is the medial plantar nerve, which looks intact till here. This is the scar, and this nerve was getting entrapped in the scar. These are the intraoperative images with medial plantar nerve. And this was relieved, this nerve was released, and patient was then free of the
He
pain.
improved symptomatically, very nice.
Yeah.
He was from Solapur, and he's doing good.
Again, a foreign body case, 35 years old lady with trivial injury while working in the garden. This foreign body is actually very, very small in size, just 8 millimeter in size and 1 millimeter in the thickness. But with high resolution probes, we can very well localize these foreign bodies. Yeah, this was on the plantar aspect of the midfoot. This black thin line is the foreign body, very, very small. This one.
No, they mark it. So best part is they both of them, they will mark for us actually on this thing, and they will tell from this skin. Yeah, 2 planes they will mark on this thing. Yeah, so that we will know where to explore. Depth also.
Depth also we can give. And
sorry. They are permanent markers, sir. They will remain. They will remain.
they are permanent markers, and we take the picture also after marking.
We can. Only thing is, those are not very high resolution, but they will help us.
गवताची काडी असते ना,
Wooden.
very thin, 1 millimeter, yeah, wooden.
She significantly had pain. We were giving her medicines, but her pain never settled down. Yeah.
Not seen on the X-ray.
Yes.
Yes. Very trivial history of trauma. Working in the garden. Another case of foreign body. With this was also on the medial aspect of the foot. I could see some features of this osteomyelitis, some tiny echogenicities along the medial aspect, and this thin foreign body was localized just like hair thickness, just like a hair, and this foreign body was not even detected on the X-ray, CT or MRI. We can see on the ultrasound very well. Very thin body, 1.6 millimeter, 1.6 centimeter in length. So radiolucent foreign bodies are very nicely located.
Yes, we removed, sir.
Yes.
The picture was there. They will help us to mark. It was in the toe.
Yeah, it was in the toe.
Go ahead.
Achilles tendon tendinosis.
Go ahead.
Yeah. This is a nice case. This is posterior tibial nerve with neurofibroma.
Tarsal tunnels, this thing was positive, tap was positive, tenal sign was positive.
This is the normal nerve fibers and with the neurofibroma. Posterior tibial vessels, and this was neurofibroma just lateral to it. These are the intraoperative images.
So we resected that neuroma in the tibial nerve itself.
30 years old male patient with
this is just
peroneal,
to show the
peroneal dislocations, recurrent peroneal dislocation.
Fresh ankle injuries, we term them as a ankle sprain, but it is actually an avulsion of superficial peroneal retinaculum. So many times, and it snaps away.
Lot of stress fractures can be easily diagnosed.
Stress fractures are best diagnosed with ultrasound very early.
X-rays are normal. This is the cortical break here, indicating stress fracture, shin tibia. Ganglion cyst in the intermetatarsal region. So we can differentiate between the cystic from the vascular or solid lesions on ultrasound. This is EHL complete rupture. This is a scar. This is proximal portion of EHL which is retracted till here, and this is the distal portion. There is a gap between the EHL. Achilles tendon, this is the proximal portion, distal insertion, this is the gap, this is the defect, and we can see, as Sampath said, the condition of the tendon, whether it is feasible for the surgery or not, whether there are calcification and tendinosis or degenerative changes. Also, for the follow-up, USG is very helpful in knowing whether the bridging fibrous tissue is forming or not, if the patient is treated conservatively. Tibialis posterior tendon, significantly thickened.
See, the amount of tenosynovitis is huge. I mean, we cannot miss on to this. This tibialis posterior synovitis, if you give inputs to your rheumatologist, they will optimize them very nicely with the medicines.
And with conservative line of treatment, 1 month after the
see this, even it is
anti-rheumatic
going to
drugs.
show you the effect also.
There was significant resolution. This is again tarsal tunnel syndrome.
I was asking him where it hurts. He was showing it, and so it was tarsal tunnel syndrome, and this was so classical tarsal tunnel. But then which tarsal tunnel you should release? It is not like a carpal tunnel. It is tarsal tunnel surgery is not that rewarding as carpal tunnel. So when to do it? See in these cases.
Ganglion cyst, just
in this case, tarsal tunnel was there, but it was because of this space occupying lesion. So tarsal tunnel release is recommended to release only when there are such space occupying lesions into it.
Posterior tibial nerve, and the ganglion cyst was there just next to the posterior tibial nerve. So that was causing the symptoms. This is 40 years old male patient. He was doctor by profession, complaining of continuous pain in the heel region. This is the plantar fascia, long axis, and a small Fibromatosis, nodule
plantar
skin
fibromatosis. So
This is
we can
plantar
differentiate
fibromatosis.
plantar heel pain with plantar fasciitis only. We'll just,
Okay. Yeah.
Thank you. For the want of time, we'll just hold on here. Thank you so much. Ashwini madam, thank you so much for. Thank you.
I request Dr. Joshi sir to felicitate Dr. Dumbre madam. After delicious lunch, we are going to proceed now with Dr. K.P. Daga, IFAS President talk. I request Dr. President IFAS, Dr. T.V. Raja sir, please come on the dais. I request Dr. Milind Joshi sir to come on the dais. I request Dr. Manmat Rao sir, please come on the dais with Dr. Joshi sir. After the presidential talk, we are having very interesting session on charcot and diabetic food session. After that, we have non-academic talks, health of orthopedic surgeon by Dr. G.S. Kulkarni sir. Very interesting talk by Dr. Metan, migrating birds connect to the nature. You will really enjoy it. Then our own senior member Dr. Sanju Bhandari sir with self-drive tour to abroad countries. After that, we are having workshops, distal and tibia plating, nailing around ankle and calcaneal fracture fixation. And today evening, we are having a special Solapuri Hurda party at Ratnai Shivar. It is 10 minutes from this venue. Bus arrangement will be there for all the delegates and the faculties. So don't miss this special Solapur treat. One more thing, just sorry to forgot, after the talk we are having the very interesting session, that is ankle instability and OCD talus. It is purely case-based discussion. Moderator is Dr. Girish Motwani. It is supported by EPSurf. The panelists will be Dr. Rahul Upadhyay, Dr. Ajoy SM and Dr. Sampat Dumbre Patil. I request Dr. Girish Motwani to introduce our today's guest speaker, presidential talk, and President of Indian Foot and Ankle Society, Dr. T.V. Raja sir.
Yeah, welcome Dr. T.V. Raja sir. Dr. T.V. Raja sir is current president of the Indian Foot and Ankle Society. He is a director foot and ankle expert at Visa Hospital, Chennai, and he is a master of minimal invasive surgery in foot and ankle in India. Welcome, sir.
You want to talk with her? Come.
I wanted you to sit beside Aga when you are introduced, that's all. So thank you. Carry on.
So, good afternoon everybody. Thanks for the opportunity. So this talk is going to be a little different from regular foot and ankle. So I'll be talking on MIS in foot and ankle surgery. MIS is minimally invasive surgery. So what procedures you do by open techniques can also be done by minimally invasive procedures. I've been doing this for since 2005 I've been doing all these procedures. What is the reason for going into minimally invasive surgery? It was first they were doing knee arthroscopy, hip arthroscopy, and now robotic surgery, and now there's no room or space in foot already, and we have started doing minimally invasive surgery in foot and ankle. What is invasive in the forefoot, midfoot and hindfoot? Today the discussion will be on instrumentation of forefoot, instrumentation for the motor system, and how I do it. There's actually, you'll have to dream where the bones are, where the joints are, and then do through a small pinhole. I was initially doing with 11 blades, now I have changed to 18 gauge needles for all my portals. So this is, the first image is a open regular incision for a hallux valgus. Next one is a mini invasive or a mini open. Now we have started doing percutaneous bunionectomies and osteotomies. The basic instrument is a power instrument and fluoroscopy. These are my mini blade holders. These are the mini blades that I were using before. This is my bone rasp or elevators. And these are the rasps, periosteal elevator, soft tissue scissors in small incisions if required. These are my retractors, Halley's, curved, all this you actually know. This is the power instrumentation. I use a high power motor called Osada. It has got a very high torque with a RPM of about 20,000. It is a foot control. This is my hand piece. 2:1 means if the RPM is set at 20, there is a reduction in the speed and RPM is only 10,000. This is my motor, hand motor. There are two types of burr. One are called bone cutting burrs, the other one is called bone reducing burrs. The ones that you see, they are all cutting burrs. These are cutting burrs, so when you want to do a osteotomy, you can do. This is also 3.3 mm burrs for cutting. These are the minimum ones, which is 2 mm size. These are also the cutting burrs. Here the first one you see on the top is called a Christian burr, it looks like a Christmas tree, and it is a reduction burr. So when you want to debride the bone or reduce the bone spurs, you use those type of burrs. These are the close-up shots of the cutting burrs. The only thing with these burrs with a high torque, it does not cut any soft tissue. These are the silicone washers to prevent blood from going into the motors. The regular Siam machines. What is the idea of doing, or what is your treatment goal? Correct all the deformities and recuperate and maintain the function. The indications are limited and very precise. So, what all procedures you can do with an MIS? You can do a soft tissue procedures like a tenotomies, you can do exostosis removal, you can do osteotomies, and it will help you in arthrodosis. The indications are tenotomies and capsulotomies. First we will see about soft tissue procedures. This is how in a hallux valgus you want to do a capsulotomy and a adductor tenotomy. This is the blade you use. look for the metatarsophalangeal joints, you go and make a small nick there by keeping a force there, it snaps off. This is your flexor tenotomy. Initially I was doing with these blades, now I have started doing it with 18 gauge needles. That is the anatomical position cut sagittal section. Here this is your extensor tenotomy, how you do it. This is a flexor tenotomy, now I have started doing with 18 gauge needles. Any claw toe which is flexible, you can correct it with a flexor tenotomy with an 18 gauge needle. You can see the toe will get corrected with a snap. Other things, you can remove bone spurs or exostosis with this. At the first metatarsal, when you see a bunion, you can do with this. The lesser metatarsals and the fifth metatarsal and phalanges also, bony spurs can be removed. This is how you do a little toe phalanges. When you want the exostosis to be removed, this is how you go ahead and do with the reduction burrs. That's your entry. Now I use only 18 gauge needles and all the procedures are outpatient procedures. Here you can remove the spur like this. It is only control in your hand what amount of bone you want to remove. View it under the image and you can go ahead and do it. When you get a con like this is how we'll have to go and remove, and you do a flexor tenotomy, the toe will get corrected. Here the flexor tendon is too tight, so there's a bend at the middle phalanx, so you'll have to snap off the tendon and then do a bunionectomy there. All these exostosis can be removed. Bunionectomy, this is how you do a bunionectomy, and you remove all the bone that you have debrided through a bone paste like thing will come out. This is how you do a Haglund. The posterior calcaneal tuberosity can be removed with a burr. Here you can see the X-ray image. You can even go like a C and cut off more bone. Osteotomies, what are all the osteotomies you can do? You can do first metatarsal osteotomies, you can do phalangeal osteotomies, and you can do proximal and distal metatarsal osteotomies. Here, this is how you do an Atkin. It is a unicortical osteotomy. You do the osteotomy and close. I normally, if I do this type of osteotomies, I do only strapping. I do not use a K-wire because these are intraperiosteal osteotomies. They don't get displaced because it is unicortical. One. If suppose you are starting to do, you can use a K-wire if you are not good at strapping. This is how you do Atkin osteotomy. This is how a unicortical osteotomy. This is how you close your osteotomy. You can hold the osteotomy just with a strapping. This is your proximal wedge osteotomy for getting your intermetatarsal angle right. You want to reduce your intermetatarsal angle, you can do a unicortical osteotomy, close the wedge. If required, you can put a wire, or a screw also if required. This is how you do a distal osteotomy. Here I call it a oblique osteotomy. Dorsal distal plantar-proximal osteotomies. This is for correcting the metatarsal parabola, or when you get an intractable plantar keratosis, you can do at the neck these osteotomies and your parabola will get corrected. And I don't normally fix it when I do it percutaneously. If I do an open veils, then I go and fix it with a screw. This is all the incision is required. Maximum I use is about 2 ml of xylocaine and that's it. And I'll allow the patients to walk the next day or the same day. Here you can see a bicortical osteotomy of the proximal phalanx. When you get a tight IP joint and you think you want to reduce the bone length or a longitudinal shortening, then you do osteotomies like this so that the joint becomes loose. So you cannot go and release all the soft tissue. The easiest way is to adjust the bone to the length of the soft tissue. That is the concept of this. What are the phalangeal osteotomies you can do? You can do a wedge osteotomy, you can do a transverse osteotomy, or you can combine the osteotomy. So these are all the osteotomies that can be done in any phalanx, starting from a great toe to lesser toe, to correct deformity. So these are all some of the osteotomies. When you have a talus bunion, this you can do a bunionectomy, you can do a lateral wedge osteotomy and correct the toe there instead of opening. I have done opening scarves osteotomy, and I think my paper has already got published in Asia Pacific. That is an open scarf for a talus bunion. Here I have done MIS. These are all through percutaneous technique using an 18 gauge needle. That is the osteotomy that I do to correct. And in this, I normally use this osteotomies when there's a plantar keratosis on the plantar surface of the fifth metatarsal head. And normally in a diabetic patient, they get stand up with an ulcer there. So to prevent the ulcer as well as for the healing of the ulcer, I do this percutaneous technique. Arthroplasties, it is very limited or there is no indication. So this is some of the surgeries that I have recorded. This is a Haglund resection that I do. I think this is percutaneous. I have a recording of mini open also. So I mark, infiltrate with local. I go ahead and do. This was done about 12 years or 13 years before. It's on YouTube. So I am sure that lateral entry, I am into the bursa. I remove the soft tissue and the periosteum on top of the bone here. I use my probe to mark for the posterior calcaneal tuberosity. The whole bone can be removed. That's how the bone comes out. Normally from the place I learned, they normally don't wash, but I thoroughly wash it now. If it is an osteotomy site, please don't wash. The bone paste acts as a bone graft there and it sticks. Whereas Haglund, I normally wash and remove everything, all the debris are normally removed. The whole piece will be removed. But if it is going to be a calcification of the tendon, you cannot remove it through using a burr. So I normally allow the patient to walk because there is no tendo-Achilles injury normally in this. Alex valgus. Very big deformities, you may need mini open, but now there's a company which has come out with instrumentation and screws, thereby you can still do it with this thing. All my blocks I only do I do a bunionectomy and an osteotomy. That's my bunionectomy. It is exactly, the rocking movement is like a wiper on the glass. That is how the bone paste comes out when you remove the bone. There I am doing a adductor tenotomy. That is, I am going for the Atkin now. This is the basal osteotomy. Only 3 holes and 1 for the bunionectomy. Phalangeal osteotomies. This normally I have started doing, this is a displacement osteotomy, bicortical osteotomy. I do it for preventing the subungual ulcers in diabetic foot. Once there's a thick callus forming in the IP joint level, I go and do this osteotomy, thereby preventing ulceration. If there are ulcers, I normally do an offloading, then wait for the ulcer to heal in offloading, and then I do a osteotomy. This is called as a longitudinal displacement osteotomy. So when you cut the bone, what happens is there's a small shift and it is displaced dorsally so that the pressure on the callus decreases. Thereby wound heals and recurrence also comes down. This is to prevent the skin necrosis there. Now I have my own developed irrigation system. These are all done quite some time ago. You can see the osteotomy there. You can see the osteotomy there. This is a percutaneous metatarsal osteotomy of the second, third and fourth metatarsals. When you have a plantar keratosis or intractable plantar keratosis, you can go ahead and do this. Or even in metatarsalgia, here after a hallux valgus correction, I am going ahead and doing. That's a chevron, mini open chevron, and here I am going for the third and the fifth metatarsal to correct the metatarsal parabola. That's a chevron with a single screw there. You can see the fifth and the third there. For the height, I have done that to correct the metatarsal parabola. Keller, initially I was doing mini open technique Kellers. Now I have started doing, for these type of ulcers, I have started doing MIS Kellers, where the base of the proximal phalanx, I normally grind and remove it as a bone paste. For ulcers like this, normally I offload them. Later on, I take them up for Kellers, where I do a percutaneous Kellers. Because neurovascular safety procedure, it is an outpatient procedure. Weight bearing in the post-operative period is allowed. There is no displacement. Only longitudinal decompression happens with this type of surgery. So, why do these ulcers come? It is mainly because of abnormal high plantar pressures and they form calluses. So, I normally do a displacement osteotomy. This is my percutaneous osteotomy. If I do this osteotomy, there is a displacement and thereby, as I told you, the wound heals well. So it was developed to minimize patients' disability and trauma. Results are comparable to traditional procedures. It may be used in combination with traditional procedures. MI is an excellent alternative for correction of foot pathology. Thank you.
Thank you, Raja sir, for excellent talk on minimally invasive surgery in forefoot. Very elaborative and informative talk.
I would ask Dr. T.V. Raja to wait on the stage. On behalf of Solapur Orthopedic Society, I would request Dr. Vache sir to felicitate Dr. T.V. Raja with a token of appreciation. I would request Dr. Sunil Handaralmat sir to please come on dais and felicitate our patron Dr. Daga sir. This is speciality of Solapur. This is wall hanging piece, handmade piece, specially for you, sir. I request Dr. Sunil Handanmat sir to please felicitate our patron, Dr. Daga sir.
Next is very interesting session, that is ankle instability and OCD talus. So this session is supported by EpiSurf India. I request Dr. Girish to moderate this session, and I request Dr. Ajoy, Dr. Sampat Dumbre Patil, Dr. Rahul, please. I thank you Daga sir, Dr. Milind Joshi sir and Rao sir for chairing this session. Thank you.
Yeah, good afternoon everyone, and afternoon session in STM is now about the ankle instability. So for next 30 minutes, we will have 4 to 5 cases, 4 cases by me, 1 cases by Dr. Rahul Upadhyay, and the cases are based on chronic ankle instability with and without the osteochondral defect and the other problems in ankle. So for this session we have the wonderful set of the panelists. It's not working. Move nahi ho raha. Yes. Yeah. So case number 1 is 35-year-old female. She twisted the ankle for many times. So she was basically the sports player. So she has a first lateral ankle twist almost at the age of 30 years. That was partly okay with some kind of immobilization physiotherapy. But again she had another twist. And in last 2 years she had 10 to 12 twisting injuries of the ankle. Of course, as a conservative treatment, she has tried everything because she is a sports girl. So she tried physiotherapy, binder, and now the main problem is she is having ankle giving away, a feeling of loose ankle. So, and this is my clinical examination. She don't have too much pain. But the main problem is, doctor, I cannot go upstairs and the downstairs, I cannot run fast. The ankle is loose, I have a fear that I can have a twist. May I have panelist opinion, Dr. Rahul? How do you see this injury, and what do you look, and what do you want to look more to get more diagnosis, or how do you see it?
Yeah, so this seems like a case of a primary lateral ankle instability here. If you see, it's a clear anterior draw test which is positive. Also, I would like to know if she has any signs of associated peroneal involvement in this case, if she has any pain which travels upwards, and
any deep-seated pain inside the ankle if she has, because it has been 2 years that she has this instability. So she, and being a sports person, she is at high risk of developing an osteochondral defects of the talus also as a result of this injury. So I would like to know if she has any deep-seated pain inside the ankle which troubles her along with the instability at the same time.
Yeah, so Rahul has made a very important point that ATFL tear is most of the time is not just a ATFL tear, and it is not an instability in one plane. It can be because of chronic 2 years old, she may have a pain, or she may have an instability, or she may have other problem associated. We called it intra-articular pathologies. So very commonly we get in the chronic ankle instability, you need to find out what is the cause of pain to know by clinical examination and by other investigations. May I ask Dr. Ajoy, sir, what more investigation you like to do apart from the clinical examination which Rahul said?
Okay, so clinical examination itself, again, I think
Yes.
one of the things we also look for is whether she has got any varus alignment of the heel itself, because that itself predisposes to quite
Absolutely,
a few
yes.
ankle instabilities, also peroneal pathologies. Then clinically tenderness, where she's having the tenderness. Is she having any tenderness at the talus? If you completely plantar flex the ankle and palpate along the talus, so the posteromedial talar OCDs or something generally, which are very common, especially somebody who's been having it for 2 years,
Yeah.
they'll also have some tenderness at that location.
Perfect.
And
Yeah.
also any tenderness along the medial side. So these are the things clinically we would like to know.
Yeah. So these are the elaborative clinical examination, and posture wise the cave foot, they are very high prone for the injury. May I have opinion of Sampath sir? Yeah.
One more thing in particularly girls, you should see for the generalized laxity, because if you miss that point and you do anything, you will sometimes not do well.
Yeah.
Girls, you see the generalized laxity, ask them to hyperextend their thumb themselves. And so many times, particularly young girls, now she's a 35-year lady, but generalized laxity is very well known in young athletes, young women athletes. Second thing is, always try to compare this with the normal side. This anterior drawer has to be compared with the normal side. It should be 6 millimeter, but difference between these two should be noted, those 2 points. And I will always ask my patients why you have come to me, what I should do to make you better. She will tell very correctly, look doc, I am not worried about pain. I am not confident in running.
Yes.
I am not confident in playing. That straightforward question has to be asked.
Absolutely. Great points. Yeah.
What makes you better if I do something for you. If she's a painful condition, she will tell, doc, it's severe pain. Or if it is not, she will tell, I'm okay with the pain, but I'm not confident that I will do this particular run.
Absolutely. 2 more points from Dr. Sampath Patil. So always look at the opposite side. So whatever I am doing here, it may be a subjective for me, it may be the instability for me, I may have a similar finding on the opposite side. So, but the girl was having only the pain, the instability on the affected side, and she had a history of twisting injury to the one side. Fortunately, she was not a generalized ligamentous laxity. May I have an opinion of Ajoy sir? What investigation you want to do before you? Now it is clear that she had ATFL, she has peroneal tendon normal, she has no any sign of synovitis or the OCD on clinical examination. What investigation you like to do more, or you directly proceed for the management?
Okay, no, investigations wise, routinely standing lateral and AP ankle radiographs is what we'll look at to see if there's any malalignments or anything, or if there are any bony pathologies that are there. In addition to the ankle X-rays, we also go ahead with ultrasound in some sittings. Again, in good hands, ultrasound can tell us if there are any ligamentous injuries, what is disrupted, and all those things can be known. Or also an MRI of this.
Yes. Rahul, your way of treating this patient by MRI, how helpful in your practice?
MRIs are, but just to add a point before that, in X-ray I would also like to get some stress views. Apart from the weight bearing views, I like to, So there's anterior and posterior stress views where you do anterior draw test and take a lateral view, and do a tailor tilt test and take a AP view. These are very, very important aspects to manage this.
Yeah. Before I proceed to management, Sampath sir, your few points about the use of ultrasound in this situation?
May not be that helpful except to know the perineal compartment, because it is over diagnosed on MRI. When you do MRI, they will always give you something on perineal side, which due to magic effect, it will show some signal changes.
Beautiful. So these were the MRI findings. There you can see that the whole chunk of the ATFL was completely avulsed from the fibula, and you may find some fibrous tissue, and that is the reason it was unstable. So these are the anterior drawer and the talar tilt test, where you need to stabilize the hind foot, and you have to move the hind foot in the varus so that you can see the tilt. That tilt indicates the insufficiency of the calcaneofibular ligament, and the anterior drawer, I mean, when you see the talus is coming out of the mortise for more than 5 mm, that indicates a significant instability or the anterior drawer test. So, Rahul, just continuing with you, what you want to, now it's clear that we don't have the osteochondral defect, this is a pure ATFL, she has some synovitis. How can you proceed for the surgery? Now she needs surgical fixation or complete relief from the instability.
Yeah.
What is your treatment of choice?
Yeah, so I would go ahead and do a primary repair of ATFL. Also, at the same time, I would see if I go by the MRI, I cannot really comment on the CFL here. But talking about the ATFL, I would go with the standard Boston Gold repair technique. And she was a sports player, and I would like to know whether she wants to continue. She is actively into the sports right now, or she has any plans to continue with that. I have a bit of more inclination towards even the augmentation with the internal brace in case of the sports person or the athletes. If she wants to continue, I will do that. Otherwise, a primary modified Boston Gold repair is good enough.
So we followed the Rahul advice. It's a beautiful advice that you should do the Boston Gold repair in this case, because isolated ATFL and some part of the CFL involved. So this is how you do the ATFL repair. So you have to mark the surgical landmark for the Boston Gold. You have to take a anterior incision anterior to the anterior border of the fibula. You have to do the subcutaneous dissection, identify the ATFL from the soft tissue, because they are usually blend with the capsule, and this is how you have to separate the fibrotic ATFL from the fibula. So you have to separate it from its fibrous attachment, and then you have to reattach it in the tight lacing position. So this is how the ATFL, how to make a thick repair. So this is how I use the peroneal, I use the the periosteum of the lateral malleolus to make the flap thick. You have to cut the fibrous tissue, 2 anchors, usually 2.7 mm at the distance of 1 centimeter, holding the anterior and the inferior part of the ATFL. And then you have to hold the foot in the full dorsiflexion and the 20-degree eversion. And the modified part is the Gold's modification is to bring the inferior extensor retinaculum on the top of the repaired ATFL, so that it will improve the it gives more collagen tissue for the healing of the ATFL. And this is how the inferior extensor retinaculum, and this is the instability. See, you can see that in just before the surgery, too much of the anterior drawer is positive, but after the surgery, you can see that the foot is completely stable. So this is the way of handling just a pure ATFL injury, chronic ankle instability, when the things are not resolving conservatively. And so learning points are recurrent ankle sprain for more than 6 months, they need surgical repair. MRI is the investigation of choice, as Dr. Sampath sir has said. You have to rule out the other pathologies, which Ajoy sir and Rahul has beautifully mentioned. And Boston Gold repair is a treatment of choice. And it's a very successful surgery in foot and ankle. Almost 98% of the time it is successful. Now we are moving to the case number 2. So he is a 19-year-old male. He has a full diagnosed chronic ankle instability, ATFL tear. He has osteochondral talar defect, as well as you can see there is some loose body as well. Same scenario, chronic ankle instability, tried everything, multiple orthopedic consultations, and now this is a scenario where I am putting you 2 more pathologies apart from the ATFL. Rahul, back to you. How do you see it? What additional procedure you want to do apart from the brostrum?
So apart from the Boston, this is a very good case for an ankle arthroscopy. And apart from the Boston, I would like to first know the exact size of the osteochondral defect that has been there.
That was 0.8 centimeter.
0.8 centimeters, so
Yeah.
less than 10 mm. So my treatment of choice, apart from the ATFL, would be to do a microfracture here.
Okay.
Apart from microfracture, I would do an arthroscopic removal of the loose body, which is over there,
Okay.
and plus finish up with the ATFL.
Yeah. Ajoy sir?
Same.
Yeah.
Same. No
Okay,
changes.
okay. So here you are getting two more intra-articular pathologies, and the same thing was happened. Here is done the modified Brostrom gold repair, but because all the defect osteochondral thing were gone lateral side on the same incision, so we have not done an intra-articular. We have not done the pre-operative arthroscopy. The loose body was outside, so. And there was a fibular avulsion fracture as well. So in the same setting, it was removed. Osteochondral defect was micro-fractured, as you can see on the image. The multiple micro-fractures were done because it was a lateral defect. If it is, of course, it's a medial side, you have to go with the arthroscopy first and then repair. So this is how the treatment is done with the use of two anchors, same pathology. And so 1 out of 3 patients in chronic ankle instability, they have a cartilage lesion. So this is not uncommon we are talking. 1 out of 3 patients, you may have some problem related to the osteochondral talar defect. Case number 3, she is a 50-year-old female. She has a chronic ankle instability. When I asked her, she said since 3-4 years, she has a multiple rolling injuries of the ankle. Even on the normal walking, she is very active in the profession. She runs a boutique and she is very active. She go upstairs, downstairs. For many years, she has tolerated with the pains with some orthotic relief, and now this is a situation when we see some abnormal talar cyst as well. So it's one step beyond the osteochondral defect. Ajoy sir, how do you see this injury?
Yeah, that's what. So now this is something way beyond. Now this and the region that is, it's one of the most inaccessible regions with arthroscopy, and retrograde drilling, or for that matter, any of these would not really work in this case. And what's the exact size of the lesion? I can see that it's quite big.
Yeah.
Is it between 9 and 15 mm?
Of course, it was more than a 15 mm, sir. I don't have a size now, but it is more than 15, yeah.
Okay, so with that much, I think we should be, and since there is not enough of a underlying bone there, I think any procedures wherein a cartilage can be replaced, or maybe AC, MESI, or those would not work in this case, because if you put in cartilage, it will just be into some free floating kind of
Yes,
thing.
yes,
So
sir.
I think better in this case would be to go with a partial replacement for this.
Okay. So what cartilage status you expect in this talar cyst? Like, do you think that this cartilage is salvageable if you just fill the subchondral defect with the bone graft, or you need to replace marrow, the bone as well as cartilage?
This might need a replacement.
Okay. Sampath sir?
First thing is these X-rays should be weight-bearing X-rays.
Yes.
Because we will go ahead only when weight-bearing X-ray shows very nice joint. Second thing is CT scan should be done to know exactly the size of lesion. If it is beyond 1 centimeter size, then of course what our colleagues they have talked about, this cartilage replacement is not going to work. Within 9 millimeters, literature says that still your subchondral drilling and everything works, but not at this size.
Not at this size of the lesion. Okay, so considering the opinion of Dr. Ajoy and Dr. Sampath, this case was proceeded with the medial malar osteotomy, because we want to see the lesion, how bad the lesion, and this is how the osteotomy is completed. The lesion was curated, the cartilage was not that good, there was multiple breaks in the cartilage, so cyst debridement was done, and because that was a time we didn't have a availability of the cartilage replacement which we have right now, the episurf, but that was the surgery which was done 3.5 years back. So on that time, although this was a shoulder lesion which is not now considered as, it's not a good indication of applying a oats, but this was the surgery which was done 3.5 years back, because it was a good subchondral bone attached to this cartilage. So we have replaced it with the osteochondral autograft transfer was done for this osteochondral lesion, and this is how the osteotomy was closed. Same Brostom gold repair done for the ATFL, because you need to prevent that further instability and the insult to prevent the further disruption of the cartilage. And this is beautifully healed in 6 months, and this is a weight bearing X-ray you can see on the right side, where the osteotomy and the cartilage is completely healed and the patient is doing good with no instability. So the learning point here is, if you see the investigation of choice in such situation, Rahul has beautifully said that there is an intraoperative arthroscopic role is very important, you to know what is the status of the cartilage, and of course the MRI, because pre-operative MRI is very important to know what are the associated lesions. And if you look at the literature, there osteochondral defect, which I said 1 out of 3 patients, majority of the lesions are limited to the talus, and majority of those lesions, they are on the medial side. So the medial talar osteochondral defect is not uncommon pathology associated with the chronic ankle instability. So it is a common lesion. Case number 4 and my last case, and then Rahul will proceed with the last one. So this is again an unresolved ankle sprain, lot of lateral ankle swelling, anterior drawer test is positive, 30-year-old female farmer, and he has an acute ankle sprain almost 3 months before, but he has continuous pain and a ballotable mass on the lateral malleolus. Sampath sir, how do you see this injury?
Any X-rays?
Sorry sir,
Okay.
yeah. I don't have an X-ray, but the X-ray was normal. I mean, it's not giving us too much idea.
So what do you think that ballotable mass was? Was there any loose body there?
No, so that was the soft tissue mass around the lateral malleolus. So this was moving around the lateral malleolus. So we suspected the peroneal pathology, and we directly advised the MRI.
Yeah, so that is the recurrent dislocated peroneal there.
Yeah. So this was basically the additional damage to the superior peroneal retinaculum and the peroneal tendon subluxation. Rahul has done a lot of work on the peroneal tendon. Rahul, how do you see this injury? ATFL and peroneal subluxation, is it common?
It is pretty common actually.
Okay.
Yeah, it is pretty common. And subluxation is pretty common, like, but a persistent dislocation is not that common.
Okay.
So, and usually if you see in a chronic lateral ankle instability, these patients on the extreme range of movement, they do have some sort of peroneal subluxation, and they present with persistent pain which travels right up to the knee. And if they keep continuing over the same unstable ankle, they tend to have this kind of persistent dislocation. So when you can feel that the peronea, they are persistently quite anterolateral over the fibula rather than behind into the groove, and that's what is felt as a mass over there, and that's a persistent swelling.
Yeah, Ajoy sir.
This was a persistent mass, so I think we have to think, was it reducible at all? Were you able to get this back into the peroneal groove?
It was a reducible, it was ballotable, you can reduce it back,
Okay.
but this was the MRI, when the MRI was done, this was the situation of the peroneal tendon.
So it's staying quite outside, because ideally that should have been much behind, the peroneal groove itself.
Correct.
So now, there's a brevis also, there's a tear, yes.
There seems to be a tear inside the peroneus brevis also. So
Okay.
if you see, there's a small signal change, and this is not going to be an artifact because the peroneal are already outside the zone groove.
Right. So I am putting 2 MRIs of the same axial cut, where you can see how the dislocated tendon look like, which Rahul has explained, and what is the normal position of the peroneal tendon. Ajay sir was asking, it's looking far away from the groove. So this is the actual groove where the peroneal tendon should lie, and there should be some intra-articular pathologies, because peroneal tendon pathologies are also common with ATFL tear. So this was the lesion. And this was the location of the pain and the ballotable mass. I can put it, the video is not working. Otherwise, I can show you that it is moving out of the groove, going inside the groove. So the tendon was completely ballotable. So this surgery was done with little extended incision, because you want to see the peroneal tendon as well. The sheath was removed, the superior peroneal retinaculum was smashed, and it was almost completely tear because he presented at the end of 3 months. So a transosseous repair of the superior peroneal retinaculum with the use of the local periosteal flap was done, retromellar groove deepening was done, and this is how the SPR ligament repair was done, and the brostum was done on the top of that using the same anchors. So the learning point here is the peroneal pathologies, it may be tendinitis, it may be tear, it may be subluxation, they are associated with 75% cases of the chronic ankle instability. And associated peroneal pathology, they need an additional operation, as I did a extra incision and the long repair of the SPR. So these are all the associated things. I will not go in the fifth case because that we have a lack of time. Over to Rahul. राहुल का कनेक्ट कर दो तेरा इसी में नहीं जो नीचे वाला था ना आपका Yeah. Okay, so we will have this last and a short case about the osteochondral defect of the talus. So this was a 33-year-old female who presented with a pain and swelling in the ankle. She has history of a couple of ankle twists and difficulty in walking. It's very specific history that this female gives is a deep-seated pain in the anterior ankle, especially on the anteromedial aspect. Ankle instability is present. Even now, if you see, this patient had anterior ankle instability and anterior drawer test. So Girish, we start with you now. Yeah, Rahul, it's the same case like we were discussing, like a talar defect.
Yes.
It's a huge defect on the shoulder where most of the weight bearing stress will concentrate. So there is always a option of oats versus a cartilage and the bone replacement. But as I said that in the huge defects, particularly for the shoulder, if we have an option of complete custom made replaced implants, is far better than oats.
Exactly. So by all the discussions that we have had, this defect particularly fits quite right into the realm of a cartilage replacement. So we went ahead and did a cartilage replacement. The episurface here. Now if you see it very nicely covers the entire involved area. It covers the shoulder region of the anteromedial talar dome, which was the culprit in this case. So this is a very novel technique now which has been introduced in India. Rather, we are the very first nations around the world which has this technique right now with us. So we have done a couple of cases of this new technique, and the outcomes have been excellent. Yes, the cost of the implant is a challenge right now, and I think and I hope if the episode people are here, it's up to your notice that you have to take care of this. But the outcome, if you talk about the outcome, and also if you talk about the options vis-a-vis cost, so you don't have any other option rather than waiting and later on converting this ankle into an ankle arthrodesis or ankle replacement, which is rather even costlier option to go ahead with. So in that case, this is one of the beautiful options that we have, and this is how we do damage marking of a 3D reconstructed protocol-based CT scan. We do a detailed damage marking report. We get a 3D customized ZIG system for this device. Through this ZIG, we do a medial malleus osteotomy. You get an osteotomy ZIG, an osteotomy blade accordingly. And then you have this ZIG which is measured in 0.2 millimeter segregations so that we get a very specific seating of this implant over the talar dome. So now if we see in this video, we'll just get the light better. Yeah. So this is how this implant looks after it has been set nicely. We had done a medial malleus osteotomy. The osteotomy was pre-drilled with a ZIG, so we know where to fix it back. and this sits nicely over the shoulder region of the talus. So the entire 3D symmetry of this bone it can be remade into its original posture. So I think this is one of the novel technique that has come up and gives us a very good chance to get back the natural anatomy of the ankle joint.
Correct, yeah, because it's patient specific. So that is,
Yeah,
I think that's very
that's the
important.
best part
so
of it.
we'll get to know that, and this is meant predominantly for defects between 9 and 15
9
mm
and 15.
and at the shoulder. So these are the ones for which no other treatment options are currently available.
Yes.
I think so. Then it fits in well.
That fits because the oats is not going to work over here.
Right.
Even the autologous cartilages and autocart, if you talk about, or the chondrocytes, the artificial synthetic chondrofillers, they are difficult for this particular position.
They won't work.
Yeah. So I think this is just what I wanted to introduce you with this case. Thank you.
Yeah, so here we comes to the end of this session. We invite 2 or 3 questions and then we'll wind up this session.
Would have loved to see that video, how you've done. Okay, if time permits.
It's a very long video actually. I can explain you the
We'll
steps.
send the videos personally to
Yeah,
all of
I
you.
can So we'll
because
request the Mohanji-
We are running 70 minutes late now.
Acha.
But I can,
Sorry for that.
we can ask Mohanji to just, concise
We'll
videos.
forward to every delegates.
Yeah.
We'll put it on common.
Thank you.
Yeah.
Over to you, sir.
So, thank you, Rahul, Girish, and Dr. Ajay and Dr. Sampath. I request Pradeep Kotadia sir to felicitate Dr. Ajay SM. Next session is on charcot and diabetic joint. I request moderator Dr. Ajay SM, please be on the stage only. Dr. Girish, Dr. Senthil Kumar. Panelist Dr. Vijay Degaukar sir, Raut sir, Dr. Swapnil Kotadia. Please be on the stage as a panelist. Dr. Dantakale sir, please. First talk is Dr. J.S. Kulkarni sir, recent trends in charcot joints. I request sir to deliver his experiences, a huge experience of charcot joints.
Recent trends in charcot management. See, charcot neuroarthropathy presents as in our stage 1, 2, 3, with or without infection, with or without deformity. With infection, usually 2-stage procedure are required. However, it can be done with 1 stage by Lizaro method, if the infection allows. Charcot neuropathy presents as hind foot deformity, valgus or varus, with or without forefoot abduction or adduction, midfoot deformity, abduction, adduction, again with or without rocker bottom, forefoot abduction, adduction, with or without rocker bottom. Ankle may present as arthritis, deformity and subluxation, and combined may be any of these 2 or 3 together in permutation and combination. Basic treatment of neuroarthropathy is non-operative. Debridement and maybe excision and total contact cast. Over the past decade, however, there have been a lot of changes during the treatment, and the operative management have been very controversial. The Americans were leading, and they were very, very active in treating the cases with surgery. And this is because of improvement in technology, Charcot specific super implants, and control of infection. Current methods of treatment are total contact cast, TCC, exostomy plus TCC, deformity correction and reconstruction with modern implants, infection in two-stage procedure, maybe one stage as I told you, Lizaro, and amputation. Indications for non-operative treatment are by TCC and brace, maybe clinically or radiologically plantigrade foot, mild deformity, no instability, and the patient is not willing for surgery. This is a case of exostectomy, and this exostectomy was done, and the patient did very well with TCC and this how the patient went. I had ulcers, but I somehow missing the huge ulcer and the exostosis. But however, the first step is to correct the muscle imbalance, because due to myopathy and other problems, there is always some amount of myopathy, some amount of imbalance of the muscles. So it may be equinus, may need TAL or gastrocnemius lengthening, and hind foot varus, tibialis posterior may be contracted and tight, requires lengthening and may be cut. Hind foot valgus, the tibialis posterior may be lengthened and need shortening, and peroneal may be contracted, may need lengthening. Planning for deformities in forefoot deformities is to calculate the angles. This is Meyer's angle, you have to calculate, and calcaneal pitch has to be calculated. Insert a Chinman pin and push it down to restore the calcaneal pitch. Beam nail may be used to correct the Meyer's angle, and the angle of the talometatarsal angle should be measured. The wedge resection will correct the deformities. Now, how to make this peak of deformity should be pointed out, and that should be the base of the resection, and the peak of it should be at the center of the cuboid. And measure the base. Ankle fracture dislocation, this is an interesting case, and this needs rigid fixation with nail and plate and lag screws. Nail plate combination is very, very good. Since last 10 to 12 years, we are, as in trauma surgeons, we are trying our best to treat the complex fractures like subtrochanter, intertrochanteric, complicated intertrochanteric, complicated non-unions with 2 or 3 combined treatments, and it has given us wonderful results. So the same thing can be applied for Charcot joint. Nail plate combination is an excellent combination. Nail alone is very unstable. So you can see here this nail, and this is very, very important. And recently we are adding this, in addition to this, anterior plate going from lower end of tibia to talus, calcaneum, and to the tarsal bones. This is final X-rays. This is Sampat's case, which is very interesting, so I thought I should include this in this. Diabetic 65-year-old lady with a diabetes neuropathy, could not walk for 2 years, and she has a medial dislocation of calcaneus, talus tissue almost destroyed, combined ankle, subtalar and midfoot deformities. And this is what he has treated with the same thing. Note that screw going from the calcaneum into the base, lower end of the tibia is very, very interesting. That should be supplement to the implants. And she had excellent results. We had also a similar case. A 60-year-old man had fracture dislocation of the ankle 1 year back, and also had a severe neuropathic foot. And you can see here the calcaneus shifted medially and this is talus and this is calcaneus navicular. And this was our first case of 3D printer. Calcaneus is medially shifted, you can see very well. And this was all covered with fibrous tissue. Talus, calcaneus. Again, you can see how the 3D printer can give you a very good idea of the deformities. And we tried to save the talus but could not. We had difficulty, so we had to do talectomy. And once you do talectomy, everything was very easy to manipulate and correct the deformity. You can see this was done about 8 years back, and so we had used that pin. But now we use a plate and a screw this way. Now rocker bottom deformity may be with abduction adduction deformity or no abduction deformity. So when there is no abduction adduction deformity, base should be plantar based. And if there is abduction deformity, it should be plantar medial based. Depending on if the medial is more, you can have a base more medially and a plantar less, or if the plantar is more, you can have plantar. So it can make it adjusted. So here in this case there was no abduction deformity, but rocker bottom foot, and we did dual beam nails, and beam nails is very good addition to armamentarium of foot surgeon, because it gives a very good stable fixation, plus it corrects the Mary's angle in one on the medial side, and both medial and lateral side are balanced. So you can see these good results. Mid-foot dorsal dislocation talonavicular joint, and these are the osteotomies. And we used dual plate here, but there was a gap, so we had to fill it with Stimulan calcium sulfate antibiotic, and the cavity bone got filled up nicely. So this is a case of Charcot ankle pain, and he had a deformity of the talus. So this was treated with 2 screws and a plate, again dual implants. So now it is better to preserve the medial malleolus, because it gives you a good support and more area for fusion. And as Pele has said, that if you cut the medial malleolus, then you are likely to talus may be medially or shifted, and then that will give you a bad mechanical axis. So it is better to preserve the medial malleolus by a, okay, 1 minute, by a box cut, that is you cut on both sides and do a box cut. Ankle and subtalar joint, you can see this. Again, same way, you can add this. Here radius plate we used. The 60-year-old man had 8 months old lateral instability, and this was treated with modified Brostrom. This is a fracture calcaneus. Most of these cases are treated by Madhura, only a few cases, old cases, are treated by me. So, Charcot specific implant are straight retrograde nail, beam nails, and special plates and screws. So, Ilizare has the advantage of limited exposure, no foreign implant, better correction of deformity. It can be done one-stage procedure, if infected, debrided, deformity correction, and Ilizaro is preferred by many. So in conclusion, plantigrade foot and no deformity, exostectomy done with TCC, surgery even in braceable patients if there is deformity, dynamic motor balance is to be corrected, is to be restored, deformity correction by wedge resection, rigid fixation by dual or even triple implants, and Charcot using this Charcot specific special joints. Thank you.
I now request Dr. G.S. Vachi sir to felicitate our esteemed speaker, Dr. G.S. Kulkarni sir. Two GS on the dais.
Okay, good afternoon. I'm just going to carry on from Dr. G.S. Kulkarni's lecture. It's going to be a little bit of revision. So I'm going to speak on, first let me thank Solapur Orthopedic Society for having invited me here. So I'm going to speak on basic principles and go a little bit more on specifics. We all know that Charcot disease is a process, and it doesn't go one way, it can go backwards in 23% of the cases. But we would like to operate them when they are little less angry, as we say, but more and more surgeries are being done even in the stage of inflammation. Now, these are the classifications. I'll go quickly through it because they might be repeated in the subsequent lectures. It is very important to assess the deformities. Now, what are the deformities? There are mid-foot deformities and the hind-foot deformities. You have to look for soft tissue contractures of tendons, look for bony prominences, because all these have to be resected and have to be corrected in order to get the tripod plantigrade foot. And also you have to remember that once you correct a lot of deformity, closure can be a problem. So you need to also plan for that. In the radiological assessment, we have already seen that the Meary's angle is one of the most important criteria, and you have to try and get it as much as close to normal, and that would improve the 10-year survival rate. Using the 3D model also you can plan your surgery. Now what is the enigma in Charcot osteosynthesis? The problem is delayed wound healing and infection, altered bone healing because it is inflammatory bone, there is decreased bone density, the soft tissue envelope is compromised, and there is a recurrent progressive fracture patterns. It just doesn't stop, it's a disease process. The approach generally is that in an acute Charcot you can just offload it by putting a total contact cast. If there is a chronic Charcot with no ulcers, no deformities, you can do a total contact cast. If the Charcot is with an ulcer, you have to debride the ulcer, eradicate the infection, remove the bony prominences, and then put the patient in a total contact cast and do whatever tendon lengthening procedures like a TAL. It's the chronic Charcot with a deformity and in infections which are the challenges. And here we have to do the corrective osteotomy, you have to do the arthrodesis and also control the infection. And you might have to do it in the staged procedure. The pendulum towards aggressive approach happens when there is a severe instability of the foot and ankle, when there is an acute dislocation, or there is an infected long-standing recalcitrant ulcers, or there is a failure of a conservative treatment. In the surgical principles, you have to optimize the premorbid status of the patient, a sequential deformity correction, soft tissue closure with flaps or VAC, stabilization of the hind foot followed by the midfoot. You have to follow this sequence and use the standard post-op regime of protecting the repair. Excuse me, can you just, hello, in the back.
At the back, can we
I'm
have
sorry.
some silence, please?
You can enjoy your tea, but I think I'm getting disturbed. Thank you. Autogenous antibiotics and autogenous bone can be used to heal the unions. Now, this is the most important slide in the presentation. Deformity correction by bone wedge dissections and soft tissue release, a durable long segment rigid fixation with good bone apposition is extremely important in Charcot. What we want to achieve is a stable plantigrade ulcer-free foot which allows full weight bearing in a shoe. And as I said, correcting the Meares ankle is what is going to help you to succeed. This is the second important slide. What is the super construct principle? Samarco came with these principles because with the normal conventional fixation it started failing. The fusion has to extend beyond the zone of injury, which means that the inflammatory bone will not hold on any implant. You have to go beyond that. Bone resection is extremely important to shorten the bone, because once you shorten the bone, there is good apposition, the soft tissue will close. The strongest device that will stand the soft tissue envelope has to be used and in the best position. In a Charcot specific fixation, you can use plates with locking screws, axial beams, retrograde IM nail. You can also use a circular ring fixator, either Taylor's type or the Elizarov type. You can use antibiotic coated intramedullary nails, but positioning the implant and adding additional screws will always make this fixation more rigid. Combining IM nail and external fixator actually improves and gives the best outcome, especially in a hindfoot, midfoot Charcots. Soft tissue releases are very important, like on the concave side, you have to release the gastroc, or you do a Hoax procedure, or do all the tibial lengthening. Now, basically, there are three patterns in the midfoot and 2 patterns in the hindfoot. The rocker bottom are the forefoot abduction type, the dorsal subluxation type, forefoot adduction type, and in hindfoot, you have the varus valgus and certain variants. In the forefoot, you have to basically give a dorsal medial incision, a plantar and medial base wedge, and the apex, the resection has to be on the cuboid. You start with a saw, but complete it with a curved osteotomy so that you get a good bone apposition. This is very important. This is a very small tips, but this will allow you to oppose the bone properly. Gradual closure with good bone apposition. You have to remove all the joints, the cartilage and subchondral bone which are part of the superconstruct. You can use a 6.5 mm beam screws or larger if possible, and span it from the talus to the first metatarsal shaft. In the second type, which is the dorsal subluxation dislocation pattern, there is more of overlapping of bone. So you have to resect that bone, do a periosteal stripping, bring it down to level. So again, bone resection is extremely important, and you can either do a single column or double column fixation and maybe add a plate to it. The forefoot adduction pattern is exactly reverse of forefoot abduction. So again, it's a lateral base wedge and a bicolumn fixation. Now this hindfoot Charcot patterns are very important. You can have the tibial type where the tibial involvement is more, which naturally happens after a fixed ankle fracture, and they drift into a varus. The talar involvement is more of an axial collapse, whereas the parietal collapse is one of those most complex ones to reduce, where actually a talectomy will allow you to correct it, otherwise it's the most difficult pattern to do. You can get in 1/3 of the patients a combined hindfoot and midfoot Charcots, and these are the ones which are very, very difficult to treat. You start from the hindfoot and go to the midfoot. You start at the ankle and the subtalar joint by doing wedge resections, but you have to preserve the medial gutter, as was mentioned by Dr. J.S. Kulkarni, that the medial malleolus is a very important structure that you have to preserve. If it breaks, it compromises the fixation. As far as the nail is concerned, try to use a straight nail with a good ismic fit and position it in such a way that you can add another compression screw from the sides. A medial column locking plate extended to the tibia will increase the rotational stability, and you can also do a lateral column fixation by an antegrade or retrograde beam screw. Now for the hindfoot varus approach, it's a transmalleolar lateral approach, and another additional approach you can do on the anteromedial side to correct on the medial. But in the varus, it is the lateral side which is the major incision. Can you just... Slide is not moving. Okay. The hindfoot valgus approach is exactly the opposite. External fixation can be used in presence of poor bone quality, or there is a hindfoot midfoot combinations. The problem is that at 16 weeks, no matter what you do, even the wires will fail. So you just try to buy you some time, but definitely combining an IM nail with an external fixator definitely improves the outcomes. In the post-op care, the total contact cast in situ removal, non-weight bearing for 3 to 5 months, maybe more. This is all that has to be included in your counseling of the patient before the surgery. So your idea is to eradicate infection, facilitate the healing process, prevent the risk of re-ulceration. and achieve the braceable shoes. Now, what are the perils of Charcot surgery? One, that deformity can recur because these unions may not occur in some patients. You may get a fibrous union, but it is still good enough to brace your foot. So you won't achieve a 100% union, but in studies we have found about 81%, which is not bad, because considering that the poor bone quality, neuropathy and vascularity, and the poor glycosylated diabetic tissue is going to make always problems for you. And in addition to these patients are overweight, they are not able to comply with the whatever advice you gave them. And this is the final slide. The big study here was done where 1,116 feet, 726 were underwent internal fixation, 31% had external fixation, 4% had both. No single technique has a benefit. It all depends on how well you fix the fracture. But the overall bone fusion rate was 81%. Complication rates are part of the learning curve or to a particular technique. But post-reconstruction amputate rate was only 5.5%. So the whole idea of doing all this huge reconstruction is because any major amputation has to be avoided, because amputation in a diabetic is a killer because it kills patients. Amputation is not a savior for diabetic patients. So the mortality rate is very, very high for major amputations. So protecting this foot, reconstructing it, whatever time, and you require a resilient patient and you require a shameless surgeon to do Charcot fixation because you need to go in again and again. Thank you very much.
Thank you, Dr. Mahendra. That was good and giving us all the inputs with regard to Charcot. And I think we have been hearing more about the surgical management and overall management principles. So, but today I'll be speaking only about the conservative management. How far can we go? Can we conserve everything, or is it only certain things that we can conserve? Can I have my slides? Yeah, there we are. So, what is it that we can conserve now? Okay, so what is it we can conserve? Can we conserve everything? Or should we also be intervening as and when required for surgery? So this is what we'll be summing up in the next 7 minutes. I'll try to be on time. So you are seeing a patient like this. How many of you would want to conserve this? Would you give some conservative option? Yes, Girish is giving. Sham is giving. No? Amputation? No, some kind of an operative work, operative only. But no, okay, no, okay. So let's see. So that's what, just get us thinking. So can we conserve these? That's what we are looking at. So in this, we are looking at, to recapitulate the pathology of the Charcot foot. I think this has already been told. Then we explore the role of thermography in early diagnosis. Can we diagnose these feet early? Is it possible? Yes. And to familiarize with conservative treatment options, whether anything works, what are the best ones, decide a given best treatment in the given scenario, and to understand when a surgical intervention is imminent. So that's when we should. So this is a slide which was there. I think Mahendra also had shown this, that we go to the Charcot, whatever the etiology, whether it's neurotraumatic or neurovascular, either ways it will lead to the formation of an inflammation. And that leads on further with fragmentation, coalescence and remodeling. So at least 23% of these patients have got a tendency to again get back into a stage of inflammation. So if you feel that once somebody had an inflammation, once somebody had a Charcot, is not going to develop it further, that's not the case. About 23% of them can redevelop it again. So what actually works? It's the initial conservative management, and if you are able to pick these up in the earliest stage, then you can salvage almost 93% of these feet. You don't need to think of anything else. So just a conservative management can help in preserving 93% of the feet with a Charcot in diabetes. And for this, patient education is the foremost thing that we need to do. How can we do this? There's a very simple test which is available, so a clinical test which you can perform. If you're seeing a patient in the very acute stage, at an acute red foot, all you have to do is just elevate this foot, hold it up for a minute. If the whole foot is blanching, it indicates that it's a Charcot and not an infection. And if it is not, then you're dealing with an infection and treat it appropriately for an infection. So that's how you can clinically differentiate this with a 1-minute test. And any other ways of doing this, this is something which we actually were looking up. We are due to publish this also. We used an infrared camera to identify what's the temperature difference between the feet. Who are the ones who are prone to develop a Charcot? Does every diabetic foot develop? No. It is the only ones who have got a temperature difference of more than 2 degrees Celsius on an infrared camera who are more likely to develop a Charcot foot. So this is what we were able to obtain, and in about 30 patients we have been able to go ahead with it. So conservative management, what does this involve? So this we ended up writing up a narrative review for our own journal, and in this we were able to look at all the options of conservative management of these patients. So offloading is one of the first and the foremost thing, and if you have a Charcot foot, if you offload it, the chances of it developing and remaining in a normal arch is very high, 93%. If you don't, then the chances of it going into a collapse is very, very high. So it's almost certain that they'll end up with that. What are the modalities? We can use a basic offloading, and we could use a total contact cast. More about this we'll learn during the workshop. Then we can use a different customized orthosis for these patients. You can give them walkers, you can tell them to be non-weight bearing, and you can use pharmacological adjuncts such as biphosphonates, calcitonin, or rank ligand inhibitors like denosumab. So this is the same patient which I had shown you in the very beginning. So I had asked you if you would want to go with operative treatment for this patient. It was just only TCC application for this patient, and the end of 8th dressing, which is just about 2 months following the first visit of this patient. You can see that all of his ulcer has healed and his foot is almost in this shape. For him, then I made a customized orthosis for him and went ahead, and he is doing quite well now. It's almost a year since I've treated him, follows up regularly, and he's maintaining it very well. Another patient, again with an ulcer, imminent, anybody would want to feel that with a foot like this, why is she going around? Why not amputate this? But no, just with a simple total contact cast application. These are very difficult ones to treat. The ones on the calcaneals and the heels are the very difficult ones, and they can heal up very well with just a total contact cast application. But now if you are dealing with a patient like this, so she has come to me, the initial stages for her involved the application of a total contact cast. So whenever we are seeing the patients in the acute stage, we start with a total contact cast, but by then this lady had already come to me when she was beyond the stage of a collapse. So those were the x-rays when I had seen her. So you can see that at this stage I would not be able to conserve this, so I had to wait till she consolidated and then went ahead with the beam fixation for her, and all inside internal fixation with a middle stabilizing plate, and that went on to heal quite well. So the role of bisphosphonates, this is something which has been discussed in the past, and also many people have advocated, but these are supposed to be used as an adjunct and not as the only thing that can be used in a treatment. Rank ligand inhibitors have also the same role. They can be used as adjunct. In addition to a total contact cast or any kind of a conservative treatment, you can add these two things up in the initial stages. One of my other patients who would come with a classical Lisfrank's kind of a dislocation with which we generally see, and so he was treated only with a total contact cast and an AFO for some time, and then went on only with an UCBL and developed this. 5.5 years following that, he's still doing quite well. Instances like this, where you are going to see patients like this with a complete total loss, I'm sure is not something which we can go ahead and think of conserving. So these are the things where we should be operating upon. So this is how far we can go with conservative treatment, and so this is what I'm just summing up here. So it's a multidisciplinary approach. It's a long-term follow-up which is essential, and we need patients to be educated very well, and offloading is the earliest and the best way of treating all these patients, and a CRO or a customized orthosis is the one which can help them the best. And thank you all very much for a very patient listening, and thanking myself for sticking to time. Yes, can I request the next speaker, Dr. Raja, to speak on?
Dr. Ajay, good that you talked about conservative treatment, because most of us, probably more than 60 to 80% will be conserving. And I will urge Solapur Orthopedic Association to develop your own orthotics here, because when 60 to 80% things can be conserved with good orthotist, I think through this conference, take one initiative to develop a good orthotic center, because without that, I think only 20% people will benefit from your surgery. 80% people will need orthotics only.
Okay. So, good evening everybody. The talk is going to be about Charcot foot. If you are not conserving, then what else you can do for limb salvage? So a patient comes to you like this, has gone to another surgeon, has got a beam screw done, and the beaming screw has failed. So now, what will you do with a patient like this? You will again go for conserving, or you refer to a higher center, or refer to your best friend. So what to do if TCC, beaming or ORIF fails? For a limb salvage, by what method, when to do it and how to do it? There is no contradiction with any modality of treatment. It is only success that is more important to limb salvage in a Charcot. There are a lot of publications that have come out comparing internal fixation and a external fixator. So everybody says about 80% of union rate and limb salvage by both the methods. So here internal fixation and external fixation for a Charcot reconstruction. If you see here, it is about 95% confidence there were in an external fixator, and it is only predisposed that most of them choose external fixator than an internal fixator. Why? So all this you know, we'll go into the X-ray. So the patient came to me like this. So I removed the screws first stage, then went in for a Elizero fixator, and patient started. We mobilized her. She's about 120 kilos. Started walking by end of 4 weeks. This is another case where I did internal fixation as well as an Elizero fixator. This is the post-op X-ray. It's gone for a bony union, midfoot. You can see the patient walking with an air walker. This is another case where the medial cuneiform has already come out. So did a little bit of osteotomy, distractors, got the chisel, the medial cuneiform, both the sides, pushed it in for medial column stability, external fixator. This is the patient with internal fixation as well as. She's also started walking with the air walker. Later, after 9 months post-surgery, she walks without air walker, barefoot walking. This is another patient, a fifth metatarsal base fracture, was mismanaged, landed up with a Charcot midfoot, did an Elizero. He has a little bit of valve is there. He's accepted it, he's walking. I told him for a supramalleolar osteotomy, he was not willing. He said, limb salvage, I'm saved. He continues to walk normally with a normal sport shoes on. This is another case presented like this. I think one of the X-rays Dr. Ajay showed was like this, pus pouring. We did debridement, 2-stage. After that, took it up for Elizero. You can see the patient walking today. I have removed the rings for him now. He walks with a crow walker. This is his fibrous union, post-op, 7 months, but limb salvage. Another patient, here midfoot, tracking down the calcaneum. You can see I have opened it, debride through the calcaneum. Elizero, he has started walking normally. Here there's a patient, here there's a study about retrograde IM nailing with Elizero. Here you can see a patient who went for a hindfoot nail, got infected, was revised, again got infected, So they came to me, did a thorough debridement, 2-stage on a Elizarov. It's totally healed now. She is also walking with a crow walker. There's another case, midfoot, rings on, everybody is mobilized, you can see there. 2-stage percutaneous approach I've started doing now. So normally I debride my wound or any infection I debride. Then when I'm going to do a midfoot, I use my burst to remove the cartilage there and go for a Elizarov. So in a vascular compromised, MIS helps me in debriding the joints. There's another patient. Here we've done a posterior arthroscopy to debride the joint. This is a tibia, tibiotalar mainly. So I did a posterior arthroscopy, debrided the joint and an Elizarov. It is healed very well. This is post-surgery. So midterm walking ability after a Charcot foot reconstruction using Elizarov ring fixator, there's also a study which shows about a study of about 26 to 27 patients where 96.3% had a very good success rate and limb salvage was 93%. So all the patients were able to weight bear between 3 to 4 weeks. Total Elizarov frame was removed after 5 to 8 months depending on the case. Solid fusion was obtained in about 80%, 20% had fibrous union. Still limb was salvaged and they're all using crow walkers and walking. No major complications occurred. So these are all the studies about Elizarov fixators, comparing with internal fixation. So they have even compared with limb salvage versus amputation. When you work on the cost, it is almost not much in US. So conclusion, Elizarov fixator is an alternative and effective means for handling a neuropathic ankle, and smokers should be warned a high risk of non-union and they go for fibrous union mostly. These are my references and thank you.
Thank you, Dr. Rajab. And thank you so much. And can I request Dr. Amit to tell us about reconstructing the Charcot, when and how?
Sir, 5 minutes last. 10 minutes, 5 minutes. Disease named after the French neurologist and characterized by the denervation-induced destruction of the foot and ankle joints. Baseline neuropathy, superadded trivial or gross trauma, autonomic neuropathy and AV malformations. And we'll pass through the phases of Shibata 0 as the hot and swollen foot, Eisenholz 1 as the fragmentation, 2 as the callus and debris resorption, and 3 as consolidation of the deformities. And location-based Brodsky's classification is also important to take the decisions because it's a time and location that will win the war to catch a prey and to reconstruct a Charcot. So we should know exactly when we are going to hit and where we are going to hit. What I learned so far from the history and my own cases is Shibata 0 and Eisenholz 1, TCC, TCC and TCC. There is no other discussion. Complicated Eisenholz 1, cellulitis, patient treated, but surgeon had not done the X-ray. That was complicated Charcot and just debride, get him back to non-complicated Eisenholz 1 and go for the TCC. Now let's go to the case. A 47 years old man, type 2 diabetes, moderately controlled, 1 year deformity, and since 3 months developed the wound. So this was the clinical presentation. X-ray, classical Eisenholz type 3. This was the patient, this was the target. So for the target, the angles were calculated and it should be a 12-degree varus of the first metatarsal to the talus. In reality, there is a 20-degree valgus. So plan is to design osteotomy for 32-degree varus. So this is what I did on the paper, executed on the paper, and on paper at least I could get the correction. So I went ahead, TA lengthening, medial bumpectomy. So why we have to every Charcot, it will begin with the TA lengthening. Short TA is going to cause the midfoot rocker. On-table osteotomy planning. And after completion of the osteotomy, the first tray in the line with the foot as it was planned. This is antibiotic coated cement. Laterally also put a bone graft. It should act as a strut and give additional external fixator on the lateral side to cause the distraction. Could achieve the arch laterally well. So this was the follow-up. Post-operative protocols are very fixed. Strict non-weight bearing for 5 to 6 months on that foot. And we have to take the good wound care in this patient. After 4 weeks, all the wounds healed. 12 weeks post-op, fixator is out. 19 weeks, all grafts are united, but we cannot stop here. This is clinical picture. We have to consolidate what we have achieved so far, and these are the beam screws and the beam wires. And still I was not happy even at this stage because it's not working. So there was the lateral laxity which was corrected by the peroneus brevis shortening. Don't touch peroneus longus, otherwise you will get the plantar also on the first metatarsal base. This is the clinical picture. The same patient, opposite side, having the deformity, and 3 months it's stable, but I will be planning it before it gets into the wound. Charcot neuroorthopathic. In diabetes, it's a time of paradigm shift where Dr. Venu and team are trying to work whether we can offer the early surgeries, but still it is on the experimental basis, no way to do at the individual setups. We cannot forget the contribution of this great man when we are discussing about the Charcots and the neuropathy. So in preoperative planning, the location of the deformity, clinical evaluation, vascularity is usually not an issue, but deep infections are to be considered. In the X-rays, 6-view X-rays and MRI to see the viability of the talus and infection. And international working group has got these two main concerns: upfront costs of the implants, high post-operative medical complications, and the recurrences. So we are trying to, I'm not going into the implants, everybody is well versed what is to be used and where it is to be used. Bone grafts and the bone graft substitutes, you have to keep in table. And now we'll go. So some more cases with humble salutations to all my VMMC teachers. 15 ounce non-healing wound at debrided, osteotomy is done, Elizaro, a complete arch restore, and there's a wound healing. The same patient on the opposite side, only the calcaneal wound and type 3B, Charcot, only debridement, no need of fixation. And at the end of 6 months, lady has the pink shoes. Patient should not be in those black and dirty shoes. One more case, 18 months old wound, non-debrided multiple times. In the X-ray you can see talus is almost on the ground. Talectomy, fusion with only K-wires and the bone grafts, and this is the result. This is 8 years follow-up. The same patient came to me after 8 years with 6 months non-healing wound, more aggressive radical approach and complete reconstruction in a super construction manner. This is 6 months old patients. This is a swollen and neuropathic foot. Whenever it is a subtalar, there is always a dilemma whether it is a Charcot or there is an infection. Most of the times there is the possibility of having it dual. So it turned out to be grossly ghastly infection. Everything came out. It was an E. coli. Me and Swapnil had operated, and we just debrided, put the stimulant, put the fixator, and this is the result. We would prefer to wait. So it is an infected situations, don't try to put internal fixation. This is again ankle, what we call a type 3A. Most of the times these are neglected fractures rather than the Charcots, but if in this synovium you see the AV malformation during surgery, then consider them as the Charcot and go ahead accordingly. So this is what is done. TCC, Dr. Adar is going to take care. So in short, Charcots are going to come like this. They are going to come like this and all diabetic foots, but we will be ready like them. Thank you very much and welcome to DFSI 2024. I hope I am in time.
Thank you, Dr. Amit. I think we'll listen to Shyam now.
Yeah.
Okay.
Good evening all. Thank you. Thank you, Solapur orthopedic team and my seniors. This was the scenario a few years back. Charco, I used to run away, but now I am into it. So we'll talk about tibio-talocalcaneal fusion, or sometimes it is just tibio-calcaneal fusion, not talus. So what is hindfoot charcos? Resulting into deformity, instability, causing ulceration, and finally amputation, which leads to high mortality rate. But we can stop this with salvaging reconstruction. So our objective is to aim stable plantigrade foot with a proper footwear and full weight bearing mobilization. So how to achieve our objective is early intervention, appropriate wound care, osteotomy stabilizing until TTC fusion. So I choose internal fixation because of following reasons. Provides more stability, it's a load sharing device, and potentially early return to weight bearing. This is as compared to plating, not as compared to Ilizarov fixation, because there are no studies which suggest which one is superior. So it allows intraoperative axial compression by using a straight nail. It allows compression at both subtalar as well as the ankle joint. Enhanced rigidity of the fixation and option of delayed dynamization is also there, and hence improving the construct. So what are the patient selection with gross instability, deformity, not active stage, like it was discussed, stage 1 we can do only if it is limb threatening situation. Otherwise conservative methods and ideal stages I can hold stage 2 or stage 3, preferably 3. So initial assessment, glycemic control is very important. Other comorbidities, vascular status which needs to be considered before jumping in for surgery, infection status, and tobacco smoking to be ruled out. So pre-op planning approach, single approach, major single approach, you can do an additional minimal invasive approach. First debridement of the ulcer, if at all there is an ulcer. Non-infected. If infected, then we have to go stage surgery. VAC as a standby, stimulant beads, bone grafting, and with all the implant armamentarium. So surgical steps, supine position, foot located at the edge of the bottom of the table, bolster, big bolster under the leg so that the other leg does not come in your view, tourniquet, and on-table Doppler. Sometimes the deformities are so grave that the vascular anatomy is completely disturbed. It should not come into the way. Like I said, one major approach, usually the convex side of the deformity, because when you correct it, it can easily close. Non-infected, thorough debridement, samples to be taken for culture biopsy, and full thickness flaps. Okay, so surgical steps for TTC is lateral approach, even if we consider varus deformity, transfibular lateral approach, prepare ankle and joint, try to retain the medial malleolus. In cases where medial malleolus is absent or fractured, it becomes difficult for healing. So correction of the deformity, here the important point in Charco is we don't want anatomical reconstruction. We just want fusion plantigrade foot. So shortening is the most important solution for this. So after reducing the alignment, use TTC nail entry guide wire, confirm the position and on, and I preferably don't do percute. I do a small incision, retract or medial and lateral wall of the calcaneum, and then put a guide wire. So inserting the nail in this case, apart from traumatic cases, is we want long isthmus fit, sometimes bone grafting as well, and like it was discussed previously, we want a super construct. So only nail will not be sufficient. We need to add something like compression screws, miss a nail from calcaneum to tibia outside the nail, screw outside the nail, or adding a plate. Post-op care, walker boot, antibiotic cover, non-weight bearing. I prefer to use parathyroid for 3 months in severe osteoporotic cases. Orthobiologics, I don't have that much experience. I don't prefer in Charco for personal reasons. So this was one of the cases how we proceed for TTC. This was a relatively younger 54-year-old male presented with this deformity. He was advised amputation by 3-4 surgeons, but still wanted some hope. This was the ulcer. I didn't think that was going into amputation. All vascular status and everything was okay. Diabetes were also under control. So debrided the ulcer. This was the marking which the skin incision was including the ulcer. So steps was debriding ankle joint. Here talus was absent, reducing. So here in this case we want the ankle foot to go as posteriorly as possible to provide a shorter lever arm. So reducing, then putting a guide wire. Check the guide wire in axial so that there is no blowout, and putting a nail with the bone graft. So after getting compression, we want another miss a nail screw. So this was screw and a plate attached. Unfortunately, in this case, patient had a minor fall after the surgery. So this was the post-op X-ray, and after 2 months, this was the X-ray where the plate was bent. Fortunately, till 5 months, nothing has happened. Is going into stable thing. So whether to use a plate, whether to connect the midfoot to the hindfoot, it's still questionable. This was the skin for 5 months, and he is happily walking and blessing me. Another case, this was the surgery done elsewhere. 72-year-old male, diabetic, ejection fraction 20%. I was afraid whether to go in. This was the second surgery done by the previous surgeon, and these were the X-rays, and this was the case at presentation to me. So I did debridement 2-stage, external fixator, waited for the skin to heal. It was approximately 3 months, and then went in for the second stage. Here in this case the medial malleus was missing, so I had to do something apart from total TTC nail. So this was the nail. Apart from it was a good rigid fixation, but still I wanted to add some. I could not add a plate, could not add a miss a nail screw, so I thought of adding a plate. Wanted super construct. So here the talus was present, so job was little bit easier. So this was at 2 months, good skin. Another last case, 56-year-old male, swelling, diabetic, and this was the X-ray. So mostly it looked like talus osteomyelitis. So again infected, so went in 2-stage. This was, the talus was completely, just into pieces. Debridement done, put cement, antibiotics, stimulant cement beads, and it turned out to be tuberculosis. I don't know whether it was correct or not. So I waited for 8 months, gave AKT, and sugar was under control. Went in for second stage, tried to fix. So in this case, I applied the principle of bamboo hut technique by my mentor, Dr. Rajiv Shah sir. So after reducing, you can see there is a fibula strut just anterior to the nail. So this was after fixing, added a miss a nail screw and a good construct. This was post-op X-ray, and this is X-ray at 1.5 months, good fusion. Only drawback in this is the lever arm is become longer, but she is doing good. The red flag signs: poor sugar control, smoking, missing medial malleoli, loss of talus, peripheral artery disease, renal disease, and post-op infection. So TTC fusion is a good salvage procedure, provides stable plantigrade foot. Achieving union is a concern, but still there is a debate that even if there is fibrous union, it is still acceptable. However, overall complication rate are there, but eventually it is a successful surgery. So take home message: no significant difference between techniques, preservation of bone stock, good bone opposition, super construct, using adjuvants, and shortening. If you if you can give this, thank you. I appreciate my mentors, Rajiv Shah sir, Venu sir, and Sampath sir for teaching me. Thank you.
Thank you very much, Dr. Shyam. We just added one more talk to this particular session. This is by our President, Dr. TV Raja, and this is on why a Charcot foot or a diabetic foot treatment is an orthopedic surgeon's domain. Dr. Raja, please.
Yes. Okay, the talk is going to be that a diabetic foot, now more general surgeons are doing it and plastic surgeons are doing it, and mainly they do amputations. So I feel it is an orthopedics domain. Why? The vital role of an orthopedist in a diabetic foot. Diabetic foot lesions are public health issue with growing importance. The management of a diabetic foot can only be a multidisciplinary approach, but the orthopedic surgeon plays a central role in providing a biomechanical perspective to avoid complications and recurrence. The orthopedists play a larger role in wound healing, minimizing amputation risk and preventing new and recurring wounds because of offloading. Orthopedists can treat them by providing long-term protection and prescribing protective shoe wear. More amputations are being done by general surgeons and vascular surgeons, but orthopedic surgeon does a better job because they are more focused on the function and a unique position to understand the rehab and requirements of any levels of amputation. Normally 7% of the population is diabetic. In that 15 to 25% develop foot ulcers, 40 to 80% are infected or suspected to be infected. In infection, it is 40% is mild, 30 to 40% is moderate, and 20 to 30% is severe. So India is going to become the diabetes capital. In 2030, India will be having the highest diabetic patients. So then, if diabetic patient, and then 40% of them will have a diabetic foot, and probably we'll have to take care of them. So lifetime risk of a diabetic patient in 15%, 14 to 20% need amputation, more than 80% are potentially preventable. Normally toe ulcers are 50%, plantar metatarsal head ulcers are 28%, dorsum of the foot 14%, and multiple ulcers are 7%. By the time I'm talking to you, one leg is already amputated in 30 seconds. Statistics, Indian standards, 44 lakh Indians aren't aware that they are diabetic. It affects the rural population by 34 million, and 33 million diabetic are men and 29 million have high blood sugars. The IDF has raised a serious alarm for India that nearly 52% of Indians aren't aware that they are suffering from high blood sugar. India is presently home of 62 million diabetes and increased nearly about 2 million in just 1 year. By 2030, India's diabetes numbers are expected to cross 100 million mark. So why do you get a diabetic foot ulcer? It is mainly because of these three things: neuropathy, limited joint mobility, and vasculopathy. So this is the pathophysiology in a diabetic foot ulceration. It is mainly because neuropathy, where it is motor, sensory, and autonomic neuropathy, which leads to the ulceration. And on top of this, there's going to be vascular insufficiency leading on to infection. So there is neuropathic ulcers, there is ischemic ulcers. So these are the causes. So normally blood supply to the skin is decreased in a diabetic patient. Lack of nutrient supply to the skin leading to thick skin formation or callus formation. When there is a callus, there is shear and pressure on the callus leading to tear of microcapillaries, which leads on to bleeding within the callus, which leads on to infection. So what happens? Stiffness in the callus, the same story here. So there is hematoma which expands inside and going for bacterial growth. What is offloading? Very, very important in a diabetic foot. It is to precaution in wound care that is required to keep all the weight off the extremity in and around the ulcer. The amount of pressure generated can inhibit blood flow and in effect hinder the development of new blood vessels as well as the tissues. So offloading can slow healing and leave time for more complications such as wound infection. So what is offloading? Offloading can be an external offloading or it can be an internal offloading. Orthopedic surgeons are good at doing internal offloading. So external offloading devices are TCC, special shoes, crutches, wheelchairs and felt pads. All my friends today spoke about external offloading. So let us see what is internal offloading. So you have ulcer like this. I told in my MIS talk that I do a osteotomy and do a internal offloading. So this is everybody had shown you on TCC. All this is okay. Crow walkers, air walkers. These are all external offloading devices. Let us see what is internal offloading. How you do. What is a devil's triangle in a diabetic foot? Bad sensation, infection and a bad perfusion is called as a devil's triangle, and it is very dangerous in a diabetic foot. So this is grading of ulcer, Wagner's. So calluses is mainly because of pressure and usually bony prominences. So bony prominences, you can do a exostosis removal and the pressure goes off and the callus heals. So cryotherapy is another adjuvant therapy where you use for removing of plantar warts and calluses, thereby preventing breakage of callus and ulcers. So mechanical debridement, how you do in a diabetic foot for a callus. Using a surgical blade, you can use the regular burrs for removing the skin tags. It's not playing. This is how you use a surgical blade and remove all the thick skin and then do offloading. How do you do offloading? Is you use felt pads which are available in the market. There are 2 companies which are making. You stick the pad just below the callus and the callus gets offloaded. And this has to be done on a regular period of a time. This is your debriding, a mechanical debridement of a callus or this. You can, if it is a plantar wart or a very thick callus, you can use salicylic acid, local application to debride it. I think I'll show you how you do. This is total excision on other patient. Here in a callus like this, you see the center nucleus there, it is developing a con because of more pressure during that. You can see it on the second toe also. All this you do osteotomy, it heals very, very well. This is a surgical excision. You can all do a surgical excision of the con. We'll do the next slide. These are stages of ulcer. See, this is what I showed you on MIS slide. Because the thick skin, you remove the thick skin, you can see the ulcer. This is because of the terminal phalanx with a clot or deformity causing a more pressure. Because the limb is insensate or he's got a neuropathy, he does not know that how much of pressure is putting on the tip of the toe. So because of more clawing this happens. If you do a osteotomy, the bone slides up and the loading is decreased. So internal offloading, which I was talking, you can do it in the great toe, you can do it in the lesser toe. Great toe you can do for tip toe ulcers, IP joint ulcers and first MTP. How do I identify the ulcer? Once the ulcer is there, I take a X-ray by keeping a ring on the ulcer. It exactly shows on a AP view where this belongs to, whether it is IP joint, it is tip of the toe, or it is at the first MTP joint. If it is and I'll tell you where osteotomy. So you can do a proximal osteotomy of the metatarsal or a distal osteotomy metatarsal. If you do a distal, you get more of longitudinal decompression. If you do a proximal osteotomy of the first metatarsal, you get elevation of the metatarsal. You make a dorsal wedge osteotomy, you get elevation of the metatarsal, so the load on the medial column goes down. So you can do a soft tissue procedure by doing a capsulotomy, tenotomy. For flexed toes, you can do tenotomy, and a capsulotomy, you will get through it. Osteotomies, wherever there's a bony spur, you can remove it with your burr, and you can do a floating or a fixed osteotomy. So these slides, I think you saw it there. These are the osteotomies that you can do and relieve the pressure on the toe. The idea is completely to relieve the load on the toes, thereby you prevent the ulcers. This is the metatarsal shortening. You do a Wales and shorten. What happens is you adjust the metatarsal length according to the metatarsal parabola. So thereby you prevent metatarsalgia and intractable plantar keratosis. This is how you do a Wales, how I do a Wales. Media not found. Okay, this is not coming. Let's go to the next slide. So gastrosolius, any 4-foot ulcer, medial head of gastrocnemius release you can do to decrease the load on the 4-foot. So this is very, very important. It can be done at the medial head of the gastrocnemius or at the gastrosoleus complex. Here you can see it being done at the medial head of the gastrocnemius. You release, you will get about 10 degrees of dorsiflexion. So in your takeoff phase, the load in the front foot is decreased when you do a gastroc release. So all 4-foot ulcers, if you are going to manage, the first thing to offload is doing a gastro release with your osteotomies. This is a gastrosoleus release at the level of the gastrosoleus complex. Do a surface marking. This is direct posterior, you can go from the medial side also. Very important, when you release the gastroc, you can see the dorsiflexion increases by at least 10 degrees. There is an article by Samuel Baruch in Preventing 4-Foot Ulcers and 4-Foot Loading. He says you can do a gastroc release, and the article has been published about 10 years ago. In all my diabetic foot, in 4-foot load, I want to decrease, I do a gastrosoleic release. That's it. So this is the great toe ulcer. You locate whether it is a plantar ulcer in the IP joint or it is the first MTP hallux limitus. You do a Keller's procedure. Keller's I showed you in the morning. You can do it by MIS or an open technique. And the other side, if it is a subungual ulcer or IP joint release with a proximal phalangeal osteotomy, you can do. This is your Keller's where you do. Okay, this is the exact Keller's, open Keller's, and I do by a displacement osteotomy. The IP joint ulcer goes off because the phalanx displaces upside, so the loading is decreased. The next one is you can do a Keller by removing about 4 mm of bone from the base of the proximal phalanx, including the articular surface. So it is basically this soft tissue tightening is reduced by shortening the bone to the soft tissue tension. Thank you.
Thank you, sir. Excellent talk. Now, last session before the workshop is there. So I request Dr. Ajay to felicitate Dr. Shyam Thakkar and Dr. Amit Burande. Next session is non-academic session. I request Dr. G.S. Kulkarni sir to deliver his talk on health of an orthopedic surgeon. It's a very interesting talk. Every orthopedic surgeon should listen. I request Dr. Metan sir and Dr. Bandari sir to be please ready because we are running short of time.
Unfortunately, we orthopedic surgeons do not peep into the research what is going on in the other fields of medicine. Now there is an anti-aging program going on in the world. The scientists of the world have unlocked the secrets of health, happiness and longevity. Life-changing research. You can now postpone and reverse your old age, prevent diseases and sufferings like Alzheimer's, stroke, heart disease and so on. Health, happiness, longevity depends on lifestyle, your lifestyle, how you active daily life. Exercise, most important is exercise. Second is diet. Supplements, some supplements are, they have introduced some supplements which will energize you. Tension-free mind, sound sleep, no smoking, no drinks. And now today we are having early detection of diseases. Every 6 monthly you should do around 80 tests. They are costly, about 30,000 in India, but is costing around 60 to 70,000 in Western countries. And they are all doing it. By biomarkers are blood tests, ECG, X-ray, MRI and so on. And they are treated by experts. If they detect early disease, they are treated by disease. Now this is the person who has devoted his whole life for 25 years with his more than 100 postgraduate students at Harvard University. And after 25 years, he published his research work as Lifespan. He was called in India for 2 days lectures in Delhi University. A revolutionary science, why we age and why we do not have to. That's very important. The conclusion of his research are aging is a most common disease. It is not an inevitable process of life. We think that once we age, we have to undergo sufferings of old age. No, it is not. It is preventable and should be aggressively treated. He shocked the whole world 4 months back by making 25 old rats into young rats and 25 young rats into old rats. And he showed to the world. The aging is a disease, is the mother of all diseases, that is the cause of all diseases. By preventing aging, you can prevent major diseases like heart disease, cancer, stroke, etc. Prevention is very, very cost effective. For example, heart, you can prevent heart by just diet, exercise, non-smoking, control of diabetes and diet. But once you get a heart attack, it is very difficult to, very costly also and very tension producing. And imagine how it will save the great national saving it will cost. Now, health span versus lifespan. Lifespan is from birth to death, measured in years, 90 years, 95 years, 80 years, something. But the health span is span in which you are very healthy, happy, independent, and no disease at all. And the last few years, maybe last 10 years or 5 years or some are lucky that they die on these. My mother was very healthy at 94 and one fine morning she was found dead. So her lifespan and health span are equal. The aim of the scientist today is to equalize health span and lifespan. It should be 120 years. That is their aim. When to end your life should be decided by you. How can you prevent aging? We can slow down or even reverse the genetic clock. Now, see what I am going to little details in the cell biology. DNA controls all cell functions. This is DNA, a double helical program. Epigenome, which contains tiny balls, surround the DNA. In that, this is epigenome, which is surrounding the DNA. And what happens is DNA gets damaged because of repeated cell division, radiation, pollution, infection, and so on. And epigenome does emergency repair of the damaged DNA. But what happens is, as we age, the functioning of epigenome, a drug NMN is required, that is nicotinamide mononucleotide, which is derived from food, is required. As age advances, absorption of NMN is reduced. Those functioning of the cell suffers, old age and diseases set in. The simple is just supply NMN, the cell function returns, aging and diseases can be prevented. So the anti-aging drugs are, first is NMN, metformin and resveratrol, turmeric, that is halad. These 4 drugs are the anti-aging drugs. Large number of human trials have been done and with promising results, completely harmless as supplements, and it is in great demand all over the world. This is Yoshinori Osumi from Japan, a Nobel Prize winner of 2016 for his work on autophagy. He proved that intermittent fasting or fasting, eating less, causes the recycling, it stimulates the recycling of the cell and the old cells become young cells. Eat less, that is his message to the world. Now this is another Elizabeth Blackburn, a very interesting scientist, and devoted her whole life for last 30 years to what is called a telomere and its importance in life. She was given Nobel Prize for 2019, and after 8 years study, she gave world how you should behave so that your telomere can work better. Her message is lifestyle is important. What is lifestyle? Lifestyle is just regular scientific exercises, balanced diet, reducing mental tension, some supplements. How much competitive you are? Are you in the rat race? We all get older, but how we age is very important, dependent on our lifestyle. Scientific exercise is most important part of the whole program. The aerobic exercise, walking, swimming, cycling, hiking, etc. At least just 30 minutes of walking is what is important. But just walking is not enough. You must walk fast so that your heart and lungs are stimulated. When the heart becomes stronger, it pumps better so that your brain and other organs get good blood supply. And what required is the blood supply is the main cause of all diseases of the world. Oxygen and nutrition are requirement. Muscle strengthening is most important again because muscles protect the joints from abnormal loading. Stretching is also very important, yoga and Surya Namaskar, etc. And balancing to prevent falls is very important because the fall is the cause of pathological diseases of the hip joint, and you know how the trochanteric fracture has become so common in our country. I'll go fast a little bit. Importance of exercise is high intensity interval training. Exercise improves the density, muscle mass, balance and coordination. Exercise releases the news and boosts metabolism. Muscle development is very important. You must go to gym at least 3 times a week, half an hour, or make a home gym, or you can have some dumbbells and other things at home. I'll just go fast because warning sign has come to end. These are some of the exercises. This is very interesting. This old man was surfing every day without fail at 98 years old. So age is no bar for doing exercise. Now this is the important is avoid food. What to eat and what not to eat. These are things which you do not eat. Fried foods, meat, bread, best of the nutritionists in the world do not agree on which is the ideal diet for Homo sapiens, whether it is non-vegetarian or not. But the robust evidence is vegans live longer, less affected by cancer and cardiovascular. 4 or 5 of his friends came to Churchill and said, Churchill, you are one of the most important person for England. Why are you eating like a bull? Why are you drinking whole day? Why are your churrut is all the while in your mouth? Please stop this. Churchill said, see, 4 of the top Harley Street doctors, world famous, came to me and talked the same stuff that you talked just now. And none of them are living today. That's what he said to him. So when this question was asked to Sinclair, he said they carry a special gene variant, simply a lucky winners of a genetic lottery. No matter what they eat, drink, smoke, they live longer. But for us, we have to work hard. Omega-3 fatty acids is required. If you eat sugar more, what will happen is your fat becomes like an apple, that is the abdominal gets the bulging, which is very bad fat. But if you are doing proper eating, it gets a pear-shaped body. I think I should go ahead. So mental tension is the what is this? Now this is the Tanya Singer, which is the very fascinating studies on compassion, helping others, their effect on brain, and they did the most sophisticated technology of mapping the brain areas for emotions like anger, fear, etc. by using 9 Tesla. We are using 3 Tesla, and that is available at 9 Tesla, which gives you what you are thinking inside brain, and that will all be mapped on the MRI. So they and 40 neuroscientists from Europe and America, they did study and published a book. It is freely downloadable. The Compassion, Bridging Practice and Science. Most sophisticated ultra-modern technology was used, and this is how the brain is mapped for various emotions like anger, fear, etc. The mystery of Einstein's brain, I will have to hurry up. Now this is the French neuroscientist, a Buddhist monk, who came to India and Tibet for 15 years, and he is now working in London as a neuroscientist. And he was declared as the happiest man on earth, looking at all these 9 Tesla MRI. And the secret of his was compassionate, mindful, helped others with loving kindness, with no selfish motive. Now, this is a very interesting meditation, and that is what is called a vagal meditation or pranayama. In fact, we all know everything in our philosophy. In Hindu philosophy, it is there, but they are now claiming it as a new philosophy. That is, you take a deep breath, focus your attention on this simple action of breathing in and out slowly, and during this period, you do not think anything. You have to keep quiet, but thoughts come always. The thoughts are the dangerous thing. So thoughts always come, but you have to stop them and bring back to. This is a very simple and it is said to be very effective meditation. So this is should be our motto: Sarve api sukhinas santu, sarve santu niramaya, sarve bhadrani paschantu, ma kaschit dukkham apnuyat. Now I want to keep this slide. Please click this and have this books. Some of these books are very, very interesting, and you please take this book. So thank you very much.
Yes. Good evening all. My today's topic is connect with nature and few important information of amazing bird migration. For me, nature is not a place to visit, it is a home. And I'm doing bird watching, I'm working as a bird or a birder for last 27 years. I spend on an average 1.5 hours per day in the nature. I'm doing professional photography for last 10 years and with these top gears, and I got recently a master degree in the fine arts photography from a prestigious Indian Institute of Photography. When in 1996, when I went to Hipparga Lake here, literally it is called as a Premat Padne, love at first sight, when I saw the flamingo and I connected with the nature. And I have learned many things and many lessons from nature, not less than 1,000 I can quote, but out of that I am going to share with you only 15 to 16. This nature has given me one strong message that it encourages me to travel a lot, and that's why an excellent quote is there, to travel is to live. And travel is the only thing you buy that's make you much richer. And this, all the national park in last 23 years, not less than, I completed nearly 65% of national park in India and abroad nearly 6 to 7. And very interesting facts about the bird migration, which a very nice quote is there, never stop chasing your dreams unless and until you reach your destination. And bird migrates for food, shelter, reproduction, predator avoidance, and to avoid climate extremes. And this is a perfect period between the October to the January. The migratory birds from the Europe and Russia comes to India. And this is a highway of the birds, which is called as a flyway in the birds language. And this is a popular world migration routes. And these are very nice and flyways for individual birds. And I'm going to explain you in next few slides. This very beautiful bird, a geese family, bar-headed geese, fly at 37,000 feet. And they travel not less than 3,000 miles in only 12 stops. Only within 13 days, they comes to India. And this is their traveling track. They come all the way from the Mongolia and they go. And the beauty of that, whichever flock, the flock from Solapur bar-headed geese, they comes to Solapur only. From Mysore, they go to Mysore only. They never change their destination. And this is the way actually, these are two geese. One is a geese, bar-headed geese, and one crane fly above the domestic airlines. Just imagine. And they fly above the Mount Everest. And they take 2 stops in the Mount Everest. How the bird find their flyway? There are 3 clues. One is a sun compass clue. Second is celestial clues and magnetic compass. Actually, bird migration, I can speak for 1.5 hour. 1.5 hour. This is a very interesting topic. But I'm summarize it in very fast because of the time has been given only 10 minutes. Dear friends, about 40% of the total number of the birds are regular migrant, and Arctic tern has the longest migration of any bird. They fly more than 49,700 miles in 1 year. Just imagine. And recently in 2022, the Alaska-New Zealand distance crossed by the bar-tailed godwit, which fly non-stop for 11 days to travel 13,560 kilometers. Non-stop. And so I got this one more lesson, that is discipline. You see, whenever the bird flies in the migration or even in the domestic, they fly in the one disciplined manner, and which these all cumulative lessons made me an organized person. Lesson number 3 is a teamwork. What is a team? T-E-A-M. Together everyone's achieve more. and they always fly in the V shape. The strongest and the leader is in front, and the weakest and the small babies, they are the back. So the air resistance will be less at that higher altitude. And this is a compounder of the jungle, it called as oxpear bird, which cleans not only the wounds, but also nasal cavity and oral cavity of the mammals in the jungles. And lesson number 4, what I got is a life is unpredictable. Be grateful for the every moment. And when I had been to Amazon forest, rainforest for 14 days, and our guide, when we are traveling in the dense forest, he came and just asked me to go away from nearly hardly half a foot or 1 foot, and he's shown this poisonous viper there, sitting hardly 6 inches away from my shoulder. So life is unpredictable. One more lesson we get from the nature is you have to be powerful. You have to be powerful, your health should be good, and you have to, if you want to live for long, you must be powerful. And this is a lizard, a fan-throated lizard, which is showing the power to the female, attracting the female for the mating. The quote is fight and dominate or hide and evaporate. One more lesson I got is a health is a wealth. In Corona period, everybody has experienced it. I had been to any wildlife photography, I have to carry such nearly 9 kg of weight, and we have to travel not less than 20 km per day. And birds and mammals, and they never go to the gyms. They do their all joint and ligament strengthening exercise once they get up in the morning. You observe them. One more lesson I got is a patience, which has helped not only in my wildlife photography, but in my day-to-day activity, day-to-day practice, social, friends and family. I got a lot of patience. I learned from this. And if you have patience, sit quietly, not less than 2-3 hours, but you get excellent images of your choice. These are a few images. And this image of the Great Indian Bustard, though it is we see in the Solapur, but the best image I got after 22 years. Just imagine, a best image. And this one, it took me 2.5 hours to wait for this line in the Nubra Valley, then I could get this beautiful image. One more lesson, life is a balancing act. You have to balance your life, not only profession, one must enjoy the other aspect of our life. Being an orthopedic surgeon, yes, everybody is busy, we are earning for a living and we are enjoying our practice, but apart from that, there is a life. So you have to balance your life. One more is always stay focused on what you decide. Whether it is a life goal, professional goal, family goal, social goal, what you must stay focused. If you stay focused, then you get such excellent images. These are the recently taken pied kingfisher diving images. Then life is very colorful. If you go in nature, it is a kind of meditations. You relax and you forget everything. And I will share some few beautiful birds images. And color are the smile of the nature. This is a common shelduck. This is a blue lobing. This is a red chikla. And one more lesson I got, 11th lesson I got is a hard work. There is no substitute for hard work. This composition, to get this composition image, I took nearly 6 to 7 years. Usually these kind of nests are near the well in the crowded places, okay? But I could get this image. And for that, you must have just kind of a workshop. You must have training, regular updation and hands-on workshop and lot of discussion. Before going to this Amazon forest, we had a 3 days workshop to capture the hummingbirds images. Lesson 12 I learned is know yourself. As an orthopedic surgeon, we are busy at the end of the day, we sleep, but we never talk with ourselves. What you have done entire day and what you are supposed to do next day or a coming 4 or 5 years. So you must know yourself. A beautiful quote from Maxime Legas, by discovering nature, you discover yourself. And that's why I do periodically SWOT analysis myself. I do SWOT analysis periodically. I improve on every stage. Lesson 13 we got during, everybody has got this during Corona era, that is how much we really require to live. There is, when I had been to Amazon forest, for 3 consecutive days, we actually lived on only fruit juice and fruits. That's all. You can't eat their food. We never get food which is palatable for us, only for 3 consecutive days. And there is no fixed asset for any birds or living creature in the nature. They never deposit their money at the Swiss bank. And 14 lesson I got as a nature is full of surprise. If you sit quietly for 2 hours, just go outskirts of your city or town and sit quietly for 2 hours, something will happen in front of you. Such beautiful picture, stories or images you can click. And nature always teaches us to celebrate. On daily basis, on the north and south pole, the earth or planet celebrates. That is called northern lights. So these northern light I took at the minus 19 degrees Celsius on the Tromsø at Norway country. So what it reflects, sending a strong message, create your own rainbow every day and be a enjoy the colorful life. And according to me, a single sun ray gives us 7 colors. If you go through the prism, every human being, sitting audience has a 7 characters. You define your characters and enjoy, nourish them and enjoy after doing practice. And last lesson I got from the nature is a rule of nature. What is a rule of nature? See, the tree never eats their own fruit. The river never drinks their own water. The flowers give fragrance to the society, and sun, they burn themselves but gives life to the humankind. What is the rule of nature is, next. What is the rule of nature? Living for others is the rule of nature. That's why we have started our own, since last 7 years we have started with the quote Art of Giving, our own foundation. We are doing a lot of community service and we are sharing all the work with the society in the form of exhibitions, documentation, seminar kind of things. I have my 2 exhibitions were displayed at the Jahangir Art Gallery, and many celebrities have visited that galleries. And in Bangalore, we have exhibited thrice, and in my own city, Solapur, we hosted one exhibition. And above all, we have hosted 34th Maharashtra Pakshi Mitra Sammelan. See, after profession, you get every orthopedic surgeon sitting here, after your busy practice, you get 6 hours. So encash the 6 hours and nourish your own passions and do what you love most. So my mantra will be, change yourself, not the nature. And I came as a mediator to connect with you, with the nature. To review my presentation, what the nature gives a strong message to you: travel a lot, live balanced life, be fit and healthy, stay focused, know yourself, live in present tense, no substitute for hard work. Above all, you must connect with the natures. If time permits, go on the Google, type only Dr. Methan, you will visit our 3 different websites, and in near future, we can organize a simple bird watching tour in the next conference. Thank you very much for patience listening.
Friends, Dr. Methan has told you a very important thing, that there is a personal life beyond your professional life. Today we have learnt a lot of academics, but all of us, to have a stress buster, we like to travel. And today I am going to talk about my passion, that is not only traveling, but arranging my own customized tours for a small group. And Dr. Pradeep Kothadia is my regular companion in my tours, and also Dr. Shivshankar and others have traveled with me. So as I said, my passion is for planning my customized tour abroad for a small group, and I usually prefer to visit one country at a time. These are the various points you have to cover when you are planning your own tour. I can talk hours on these various aspects, and I have written even articles on that, but today my focus is how to arrange internal transport in a foreign country. The modes of internal transport in a foreign country are public transport. In the city, you can use metro, bus, trams. Intercity, you can take domestic flights, you can take trains, buses. We have used all these public transport facilities over the years. Private transport is a bit costly. You can have chauffeur-driven taxis, but it is quite costly in most of the Western world. So the third option which I am going to elaborate is self-drive tours. A self-drive road trip is convenient, enjoyable, definitely much more economical than other modes of transport, and it gives you a unique and memorable experience. As in this movie we have seen, Zindagi Na Milegi Dobara, in this they had traveled Spain in a car and we also enjoyed with them. There are two ways of doing a self-drive tour. You can get ready-made self-drive tours, tour packages, where they give you the car, they give you accommodation, they give you the sightseeing, coupons and everything. And you can take that ready-made self-drive tour package from a local travel agency in that country. When we went to New Zealand, Dr. Kauthadia must be remembering, I stumbled upon this relaxing journey site where they were offering self-drive tour packages from 3 days to 35 days. You can choose anything. And again, in each, they were giving economical package, middle package and luxury package. You can choose anything. So we decided to go for this package of 14 days. And when we arrived in Auckland, nobody came into the picture. Just we got the keys of the cars and the whole bunch of coupons, and we traveled on our own with this. Similar tour packages are also available in other countries like Iceland. Now I am planning a tour to Iceland and I saw there are self-drive tour packages which are available from local travel agencies, and you can just take the car and go around from 8 days to 12 days in Iceland. Other way of doing self-drive tours, which we have done most of the times, is planning your own customized self-drive tours and booking a rental car. Now, my first self-drive experience was in 2010. That time, we had planned to visit Scotland and Lake District of England, and I planned starting point at Edinburgh and traveling 1,350 kilometers. We ended at Birmingham. Now, how to rent a car? The car rental is quite easy nowadays in most developed countries. You can do online booking of the cars. Actually, this concept started in US or Canada or Australia, such big countries. They can't travel from one city to other city in a car. So they fly, and when they get down on the airport, there are 7-10 storied car rental companies which give you the car. They just pick up the car in 2 minutes, go around their tour for or any work or business, anything for 4 or 5 days, return the car and fly back. So renting a car is very easy for many years in foreign countries. There are various car rental companies which provide you the rental cars. But the better thing is to go for online car aggregators like Car Rentals, Skyscanner, Kayak, and even sites like hotels.com or booking.com. If you book the hotel rooms with them, in the lower part, they say, do you want a rental car? And you can get really cheap and reasonably priced cars with this your hotel bookings. So that we did in Australia. We were booking the rooms on hotels.com and we got nearly 50% discount on the rental car. Of course, if you don't know, these days even in India, we get rental cars. In big metro cities, we have taken rental cars in Cochin, I have taken rental cars in Bangalore, we have taken rental cars in Ahmedabad. So you can rent your own car, travel, return the car there, and though it is in nascent stage in India and not like in Western countries. Such type of beautiful cars you can get, and even the convertible car which you can see here. This convertible car, you can enjoy this, though it may be a bit costly. Now, various ways of renting a car is that you can have the same start and end point, or you can rent the car at one location and return at another location. This is quite really convenient, though it may turn out to be a bit costlier. But you don't have to return to the same spot again to return the car. We started at Edinburgh in Scotland and returned the car in Birmingham. So I've never wanted to go back to Edinburgh. So you can rent at one place and in America we took the car in San Diego and returned it in San Francisco. So though it is very convenient, though a bit costlier. And total charges are usually car rental fees, which depend on the car which you are choosing, whether a small hatchback or a SUV or a big MUV, etc. The number of days and the return location, as I told. In addition, you have to take insurance, and the insurance fees are included in your car rental fees. Plus, if you are 2 or 3 people are going to drive, then you have to pay additional driver charges. Usually opt for a unlimited mileage car. They give you the car with full tank, and when you are returning, you have to return it with full tank. These are the self-service fueling. We enjoyed this very much. You can see Dr. Shiv Shankar there, and even with my son there. We enjoyed because we never had this experience. This is in 2012, when we had gone to AOS. We never had this experience of self-fueling the car, and we really enjoyed and took the pictures there. Now about driving license, many people really feel that international driving permit or IDP is needed. But if you search the net, you will find that Indian car driving license, if it is in English, and so we have a car driving license in English, and it is valid for 6 months in 21 countries, and these are the various countries. And normally we will travel to these countries only to have a self-drive tour. So nearly in every country where you visit, the Indian car driving license is valid. You search on the net for the country which you are visiting, but if in doubt, obtain international driving permit, which is very easy nowadays. You can get it online. Navigation, previously in 2010 and 2012, we had to take these navigation devices, this TomTom and this Garmin. These we had to take so as to navigate our ways through the small country roads or the highways. But nowadays, it is very easy with Google Maps. You have to purchase a SIM card. You can go and purchase it locally, or even before traveling, you can purchase a SIM card nowadays 2-3 times in Norway or anywhere. We had really taken a SIM card on this tsim.in. You get very cheap SIM cards in India, and they arrive to you before you start your travel, and on the day when you reach there, they are immediately activated. Of course, if you are taking these SIM cards and using the mobile, you will have to have a dashboard mobile holder, otherwise it becomes very difficult. But nowadays, even most cars come with an inbuilt navigation on the screen. But if the inbuilt navigation is extra and costly, then you can connect your mobile by Android Auto, and then you can see your Google Maps on the car screen. So it is much convenient than having their own navigation. Now, which side of the road you drive? If you see this map, you will be surprised that except India and a few Commonwealth countries, most of the world drives on the right side of the road. So, but don't worry, once you get used to this in 1 or 2 days, even if you are driving on the right side of the road, it is very easy for you. Only thing is that follow the traffic rules very much, because they are very disciplined road traffic is there, and if you make mistakes, never think of breaking the rules. So there are clear road signs everywhere, even painted on the road. What are the distinct advantages of a self-drive tour? There is a freedom to choose your own route. You can search the net before you go and see, I want to see this, I want to see that, and then you can choose your own route and places to visit. So in US, when we had gone for AOS 2010-12 with Dr. Kothari and Dr. Shiv Shankar at San Francisco, we decided to have a West Coast self-drive tour, and we decided this route. And we were so enchanted by this that when we again flew to Las Vegas, we again took one more car and visited Grand Canyon. Leisurely itinerary, so there is no grueling schedule like a conducted tour. Freedom of stay, motels, Airbnb, and bed and breakfast away. So these were the various beautiful places where we stayed in the nature, away from the cities and in mountains. And they are very cozy and tastefully decorated rooms, halls, you have bedrooms, and you have kitchen and dining rooms, etc., so that you can all sit together and enjoy in the evenings. Or if you choose hotels, you can choose cheaper hotels away from the city center. Another is point-to-point transfer with luggage convenience, and as I said, definitely is economical. The major attraction is enjoyable drives. So especially in 2010-12 when India did not have that good roads, we enjoyed these freeways and motorways. Of course, nowadays we have similar roads in India. But you can also have many scenic roads in the mountains, in forests and everywhere, which you can enjoy. Now you can see these various roads. One is the mountainous road where we went for seeing the fall colors, the ocean road in the Key West, USA, or this forest in Australia. Second is you can stop at beautiful sightseeing spots like lakeside spots, etc. They have designated parking lots on highways at scenic spots. These various exciting adventures we could do in New Zealand only because we had our own car. And interesting detours to whiskey, Scotch distillery, this Atlantic Center in New Zealand, these Elephant Seal beaches, the Whitemoor glowworm caves, different lakes in Scotland, and in west coast of USA we could go to Grand Canyon, Yosemite National Park and Muir Woods. And last and most important is no hurry and fixed time starts and stoppages. You can stop anywhere whenever you want and you start ahead when you feel like. So friend, there's so much to explore in this beautiful world and there's no better way to do that than a leisurely self-drive. Thank you very much.
Thank you, Bandari sir. Excellent 3 non-academic sessions we all have enjoyed. Now the most important part of this conference is there is inauguration of the conference. I welcome our Dean sir, Dr. Deshmukh sir here for the inauguration as a chief guest.
We'll take 2 minutes for setting, 2 minutes. Rajendra Abhyankar sir is there. Yeah. Karade sir. Karade sir. Yeah. Don't roll this. Table. Good evening friends and all my seniors. We'll now proceed for a short but sweet inaugural function. I would like to call for the dignitaries on the dais. First, our chief guest, Dean Dr. Sudhir Deshmukh sir. I would like to request Sunil to escort sir. MOA President sir, Dr. Rajendra Abhyankar sir. MOA Secretary, Dr. Narayan Karne sir. IFA's President, Dr. TV Raja sir. Solapur Orthopedic Society President Dr. Gurunath Vache, SOS Secretary Dr. Sunil Handanamat sir. Good evening to one and all. It gives us immense pleasure to start this inaugural function by heartily welcome everybody. Just to brief of Solapur Orthopedic Society, it was started in 1919 by our founder, president and our patron, Dr. V.M. Iyer sir, Dr. K.P. Daga sir, along with all other members. Since its inception, SOS is always ahead in the forefront of academics, arranging various workshops, CMEs, state level conferences. SOS has decided to conduct trauma meet which will involve specific joints and bones rather than routine concept of orthopedics. SOS had earlier done 3 trauma meets, that is fracture around knee, elbow and hip. Today is the 4th Solapur trauma meet of fractures around foot and ankle. I would now like to request President Dr. Gurunath Vache sir, our dynamic president, to give the welcome address.
Good evening, respected dais of the dais. So this is first Solapur trauma meet, specially on foot and ankle, and with a huge response from more than 230 registrations, more than 50 national faculties, international faculties. I really appreciate our national Indian foot and ankle faculties. I appreciate our president IFAS, Dr. T.V. Raja, and all the IFAS faculties to come all over from the India to, in spite of their busy schedule, they have given 3 days full of Dr. Girish, Dr. Sampat Dumbre Patil, Dr. Rahul, Dr. Ajay, all these. So thank you very much, and I welcome you all for our this inauguration ceremony. Thank you.
We will now move ahead to lamp lighting ceremony. We are about to commence our event by lighting the lamp of knowledge and wisdom. This is a symbolic moment that signifies the dispelling of darkness and igniting of knowledge and wisdom. The flame's upward movement shows that it defies gravity and stands up as a symbol of our quest for knowledge, upliftment, and the resolve to rise above all challenges. It stands as a testament to the power of light over darkness, knowledge over ignorance. To make this evening a blessed one, let us invoke Goddess Saraswati by kindling the lamp of knowledge and wisdom. I now request all the dignitaries on the dais to join for the lamp lighting ceremony.
वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा प्रथमेश्वरा गणधीश्वरा चिन्तामणि परमेश्वरा वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा प्रथमेश्वरा गणधीश्वरा चिन्तामणि परमेश्वरा गणनाथ सुरमणि गणपति गणनाथ.
On behalf of Solapur Orthopedic Society, we would like to do a small felicitation of our faculties today and our dignitaries. I would like to request Dr. Sunil Handanamat sir to felicitate Dean Dr. Sudhir Deshmukh sir. TV Raja sir, if he is available, please come on the dais. TV Raja sir. I would move ahead. Now I would like to ask Dr. Pradeep Kotadia sir to please come forward to do felicitation of MOA President Dr. Rajendra Abhyankar sir. I would now request Dr. Vache sir to felicitate MOA Secretary Dr. Narayan Karne sir. Dr. Vache to felicitate Dr. Narayan Karne sir. Today we are fortunate to have MOA President Dr. Rajendra Abhyankar sir. May I request to express his views on today's occasion.
Good evening, friends. It's always a pleasure to come to Solapur because I lived here for 8 years as an undergraduate and a postgraduate. Solapur Orthopedic Society is always at the forefront. As seen here, I am coming regularly for last 8 years and I see every time there is a new topic, new discussions, new faculties. It is really something to take away. Maharashtra Orthopedic Association, as I last time said, has given its journal to an international publisher and now we are publishing the first issue in this month. I would like to invite you all to MemoEcon 24, which is going to be held in Bombay for the first time. In last 40 years, the conference was not held in Bombay. This year, we are trying to hold in Mumbai. I invite you all for the same. I congratulate Dr. Vache and Dr. Handramat for the excellent show and I wish all the best to that. Thank you.
Thank you sir for your words of appreciation. I now request Dr. Narayan Karne sir to express his views.
Our chief guest, Dr. Deshmukh sir, our president, Dr. Abhyankar sir, Dr. Kotadia sir, who is the president-elect, Dr. Vache, Dr. Handramat, my guide, teacher and philosopher since my PG days to this day, Dr. J.S. Kulkarni sir, Dr. Iyer sir, my senior colleagues and my dear friends. It is a great pleasure to be here on this occasion when Dr. Guru told us that such and such conference is going to happen on foot and ankle in the Solapur trauma course. I was really wondering that how this conference will go because there is a little bit off the board, you can say, the topic, but there is a good response and the way the topics are chosen, the content of the faculty and everything is fantastic. So hats off to both of you and congratulations for that. Right. As our president has just declared that we are going to the MAOCON for the first time in the last 40 years and it is one of the challenge for all of us because every MAOCON gets 2 years to prepare and we have got only 3 months to prepare and that also within 6 months of the previous MAOCON we are doing this. But I am sure that we are going to be successful with the participation and proactive work by all of us because we are the MOA, all of us are the MOA. One more I want to just tell here that for the first time we have introduced a district 1 hour session and it's not necessarily an academic session. When I saw the both lectures of Dr. Bhandari and Dr. Metan, why don't you come with these lectures and present it? It is a bit off the track because this is going to take the Solapur at a higher level because we are going to have the national and international faculties also. So you can try this also, not necessarily an academic session. And one more which we have started with for the first time it is happening that the Friday night is generally some celebrities called for the Friday night. We spend 10 lakhs, 15 lakhs for the celebrity. This time it will be our family function, MOA family, MOA talent one. And I suggest we are going to keep a strict session also on the Friday night like a Sangeet Sandhya one day before our marriage. all of us, the MOA members, their family members, their spouses are going to present their own talent in singing, dancing, musicals, skits and whatnot. So I suggest Solapur also has got such a wonderful talent and to come forward and get the MOA Idol prize. So congratulations again for all Solapur people for making this conference successful, and we welcome you to our grand MAOCON 24. Thank you very much.
Thank you, sir, for your words. Now, I would like to request our chief guest, sir, Dr. Sudhir Deshmukh, sir. Before that, sir, one second. I would like to request the first president, sir, TV Raja, sir, because sir was late. Thank you.
Good evening, everybody. It was a wonderful meet here in Solapur. This is the first time I'm coming to Solapur. Seeing all giants from Solapur and hearing to their talks, it was wonderful. And it was knowledge enriching and memorable time here in Solapur with traditional, and I never expected Gurunath Vache would conduct everything in a short span. 2 months back he met me and told me that we are planning to do a program in Solapur. And it was a grand success and a wonderful meeting here. Thank you everyone for this wonderful feast.
Thank you, sir. I would like to now request our chief guest, Dr. Sudhir Deshmukh, sir, who was a witness for all the activities involved in Solapur Orthopedic Society. Thank you, sir.
Today's Solapur Trauma Meet, that is STM 2024, we are meeting for this conference under the leadership of Solapur Orthopedic Society. The President of Solapur Orthopedic Society, Dr. Gurunath Vache sir, the Press Secretary of this society, Solapur Orthopedic Society, Dr. Sunil Hindralmad sir, and the Vice President, Dr. P. Aurangabadkar. These two surgeons, orthopedic surgeons, are faculty of my college, and they are taking a lead role in this particular conference. I congratulate both of them for such a nice meet and arrangement, that is STM 2024. Today's meet, or rather 3 days meet, is under the aegis of the IFAS, that is Indian Foot and Ankle Society, and the aegis of Maharashtra Orthopedic Association. So we have here the Honorable President of the IFAS, Dr. TV Raja sir, and the President of Maharashtra Orthopedic Association, Dr. Abhankar sir, and the Secretary Karne sir, and the respectable honorable delegates who come all the way down from all parts of this country, and my dear delegates. First of all, I heartily congratulate the Solapur Orthopedic Society for arranging such a big meet in this Balaji Sarovar Hotel. The theme of the meet was foot and ankle surgery, national to the international perspective. They have put a word that let us put first step towards foot and ankle surgery. I think up till now for 2 days you have enjoyed the academic feast about orthopedics. I am a general surgeon. So all are sitting here are orthopedic surgeons. So you deal with bones, muscles, joints, ligaments, tendons. This is your area. I think most of the weight of the body and the structure of the body stands on your power, and you take care of this important power in the body. The mobility of life mostly depends on your department. So mobility, stability of life, the movement of life, and to restore the movement of life is a function of orthopedic surgeon. Not only they restore the lost function, but they prevent the further disability and they prevent further problems in mobility of life. and the life is restored by the orthopedic surgeons. I salute all the orthopedic surgeons who are working here and giving stability to the society through their fabulous work. I can't say much. The foot and ankle, I think it is one of the very important. Most of the weight of the body is bear throughout the life by these foot and ankles. So the foot and ankle, like as we say, the knee is also one of the most complex and most important joint in the body. Likewise, foot and ankle also is very important, which affected by many diseases and affected by trauma also. So the constant innovation, constant study and constant improvement in the treatment of foot and ankle injuries, diseases, and the prevention of further disabilities is done by these particular meets. This meet is going to definitely improve the knowledge, skill of the orthopedic surgeons, those who are attending here. I heard that almost 230 registrations are there. It's such a branch where orthopedic surgeons is a rare reality, but still 230 registrations and people are ready to accept knowledge at various ages, I think. Right from the younger surgeons to the older ones, everybody is contributing to this conference. So I salute to your work, and I once again congratulate the organizers for giving such an academic feast to all our orthopedic surgeons. Thank you so much.
Thank you, sir, for your words of appreciation. Now we are coming to the end of the inaugural session. One thing we have forgot. Now I would like to request Dr. Vache sir to felicitate Dr. T.V. Raja sir, since Raja sir was a bit late for this occasion. Coming to the last part of the session, I would like to request Dr. Sunil Handanamat sir to express his vote of thanks.
Good evening all. Again, I would like to welcome you for the inaugural ceremony of this STM 2024. I would like to have sincere thanks to my boss, the Dean, Dr. Sudhir Deshmukh sir. He is always encouraging. He is into very much academics. He pays a very in detail attention to undergraduate and postgraduate training in our college. And since he had come, the NAC scoring of our institute has gone up. And probably we are the second in Maharashtra among all medical colleges. So I'm proud to welcome him and thank him for attending this STM inauguration. Again, I would like to thank MOA President Abhyankar sir, Karne sir, and AOFA's President Dr. T. Raja sir. I am really impressed by his work. These are fantastic percutaneous things. I am really amazed by him. I have become his fan, and maybe I will learn so many things from him. And again, our upcoming President MOA, Pradeep Kothadia sir, who is always joyous and enthusiastic to learn new things. And we will always be inspired by you, sir. And now our SOS President, who took this, who is like an atlas, who took all the brunt of this conference. My contribution might be a very minimal. I must confess to that. Everything, each and every minute detail was planned by Dr. Gurunath Vache sir. He was tirelessly working for last 6 months to make this happen. And I think by looking at the registration and the content, academic content, by looking at the faces of the delegates only and the presence in the hall, I think this is going to be a huge success. And this is just a start. Next 2 days also will be full of lot of academics as well as extracurricular things. So thank again, and I would also like to invite you all for the Hurda party, that is the delicacy, and that is a classical thing which is done in the rural parts of around Solapur. That is, Hurda is the jawar, the young jawar, which you can eat, this millet actually, young millet. So I would like to invite you all for that wonderful Hurda party, and through that also we can enjoy our residency days memories together. Thank you. Thank you once more.
I declare the inaugural session is over. To add to Sunil's few words, we have taken care of today's banquet, Solapur's specially delicious taste, where you will not get any part in any part of world, that is khima sheikh and chicken biryani. I think everybody should enjoy that.
So for your
and just to announce.
For your information, 2 buses are ready. 7:30 onwards the buses will run from here. It is a 10 minutes from here. That is a Ratnai Shivar on Mangalwada Road. So you all are invited there, a special Hurda party there.
I think the organizing committee and Dr. Guruna deserves a standing ovation for this.
Yes.
Brilliant.
Yes, thank you, thank you, thank you, thank you. Thank you, thank you. It's a team effort. It's our SOS efforts.
Slight announcement, today's workshop, since it is very late now, 7 o'clock, we'll be doing it tomorrow. The time will be declared tomorrow morning. So we'll be joining in the banquet session Hurda party at Akkalwade Farms. 2 buses will be ready outside. Buses
VMMC meet. There is also a VMMC meet at Hurda party. So all VMGMC students.
So for all the VMMC students, please wait here, and for rest of the delegates, the Hurda party bus will start from here. So there is a small VMMC get together. Dr. Iyer sir, Dr. Bhandari sir, Dr. Sunil Andramat, and late Dr. Khairnar sir students, and myself. So all the VMC students should wait here for the get together, and from here we'll go there. And for rest delegates, the bus will start from here at 7:30. And today, because of the huge response and huge interaction between our faculty and the delegates, we are delayed for 1.5 hours. So today's workshop will be shifted to tomorrow. And tomorrow I request all the delegates and the faculty also will be in time and will stick to the time, so that we'll cover everything. Thank you. Thank you.